Vishwanathan. Rheumatology has had an evolutionary change from rheumatoid arthritis or rheumatic fever to the detailed classification of diseases associated with joints and serosal membranes to even the several visceral parts of the body. Today, we have with us Dr. Vijay Vishwanathan, who will take us on the journey right from the identification and categorizing the disorder, but also leading us to the various avenues of treatment and finally prognostication. Dr. Vijay, please.
Thanks a lot for the kind introduction. I thought I was given only half an hour, but if I go through all the things that were mentioned, it will take till the valedictory function. So I'll try to be as short as possible, kind of pretty much like MAHAPEDICON, meet new friends, renew friendship with old friends again, and so on and so forth. So my topic that has been given for today is pattern recognition in rheumatology. So can anyone who has been attending the last 3-4 MAHAPEDICONs recognize what's the pattern in this? Okay, I can hear a few words. Anyone who wants to get a bit more closer? So this often is used to be and probably will continue to be my first slide of every conference. This was Mahabaleshwar, MAHAPEDICON, about 4-5 years back, where I was the last talk of the day. And then Vijay, someone said Vijay, and then obviously there is a connection with Vijay. And the famous dialogue is most of the time my talks happen with this famous dialogue. Most of us will, I don't know if it's visible, but it says, Main aur meri tanhai. So it's often me and empty hall. But then this time, thanks to the Nasik organizing committee, I have been promoted from number 11 to number 1. And I am happy that I still will probably change the slide next time because I can see more than a few heads. So I'm no longer Tanai. The first pattern I had sent or tried to sell in Mahabaleshwar was come at Mahabaleshwar, come at MAHAPEDICON, comes November, you start seeing strawberries. And I saw some nice grapes yesterday outside the hotel. And there's a strange connection because I think KD has started arriving everywhere, including Nasik. So the first patient who walks into your clinic tomorrow, start looking out for a red lip or a red eye or a... So these things have been constant patterns in the last few years. So I have had my eureka moment from number 11. I have reached number 1. And not everyone's favorite, but these are a few of my favorites. So we all know that Ravi Shastri started at her 11th number and graduated to become an opening batsman and won an Audi car. So thank you for giving me this opportunity. I was told that the banquet is in Sula yesterday, so I was mentally ready for a hangover and a hanging up session. I held a few mini CMEs yesterday there with some of my friends. And the good thing about Zoom and YouTube linking is we'll still continue soaking, sulking and sinking, but this time in some knowledge because following me, there is a whole list of stalwarts and excellent lectures lined up. So I'll try to drag on as much as possible for other people to get warmed up. So 2011 and 2022, MAHAPEDICON, what has changed? I still like to use the Nasik theme, and the first time whenever anyone tastes wine, you start wondering, whether it's to be liked, whether it's to be loved, is it responsible for a good life? They all look the same, but some strange things, all of them look the same. But thanks to the constant efforts from knowledgeable colleagues, we've started using this term pattern recognition a lot. And this time, yesterday in Sula, we were very comfortable looking at faces. Something similar was the story in pediatric rheumatology, where everything used to look the same at some point of time with constant hammering, constant understanding. You start sensing that there are few patterns which are there to be made out, and they all look the same, but you can make out subtle differences in each of them. Disclaimer, I don't pay any royalty to the Kapoor family. The other way is due. So we are here to improve our PR skills. So it's a nice uh, way of approaching pediatric rheumatology, I feel. So without wasting more time, we've always been told by our seniors to start looking at the patient. And I want all of you to look at this patient. Volume karu shakta ka? Right. You can see the nice vineyards behind this. So this boy actually is from Nasik. And then if I ask you, both of them were referred as probable JIA or JRA. And sometimes God is kind enough to provide clues. So does he look sick or does he look happy? Both of them. They look sick, right? But by the end of this talk, I would ask you to stop looking and start seeing. Despite getting hints in the form of this boy incidentally had a t-shirt with probably a written diagnosis. I've never seen a t-shirt with JRA written on it, which is something very strange. But you looked at the boy and you saw the t-shirt. But then disto tasa nasto. Manun, so this is just my take on it. Jug fasto is a problem, but I don't want you guys to faso. So my take is disto tasa nasto. त्याच्यामध्येच निदान असतो. And the only message that I want you to say is stop looking and start seeing, because the patient shows you a lot of clues that you need to inculcate. And then as Dr. Prabhu yesterday allured to, I think our job is not to treat alone. We should probably start looking at us as healer. So you don't need to know the diagnosis on day one. Just figure out which chapter of the textbook you're supposed to hunt. And then we'll see how to go through this. Sorry, I didn't do anything. It's happening from there. Okay. So we won't make a diagnosis on this. Suffice enough to say that this is a sick child, right? So what's the difference between a pediatrician and a rheumatologist? So this is my understanding. Pediatrician is extremely hardworking. The rheumatologist is extremely hardly working. So the pediatrician is hardworking because he keeps thinking of infections, inflammations, malignancies, trauma. Time मिलेगा तो inflammatory disorder तक पहुंचता है. My job is ulta. I look at inflammation in every patient I see. Maybe and then think of the other possibilities as probably causative or coexistent or maybe associated with. Multiple etiologies are what pediatricians encounter. So it's like finding a needle in a haystack, whereas my job is easy because we all have a concept or a theory that rheumatology is only about 10 seemingly rare conditions, though I don't think it's as rare as it's made out to be. And my job is, of the 10, I have to rule out them. And in the process of ruling out, I end up ruling in many of the conditions. Whereas the pediatrician has the other way to do it, where he has to rule out the infections, malignancies, then it becomes a bit stressful. And this is just my way of thinking, as the pediatricians and parents want resolution of the problem, whereas the rheumatologist wants evolution of the problem. And that's exactly the way to achieve that. We need to have slightly upgraded pattern recognition skills. So I'll start with the joints. Whenever you see a joint in your OPD tomorrow, first patient, again, Monday morning, try to use these 7 or 8 conditions or terms in front of the joint? What's the age of the child? What's the gender? Is the child sick or not sick? Is the swelling acute, subacute, or chronic? Are the joints large or small, upper extremity, lower extremity, or central or peripheral? Is there morning stiffness or is there nocturnal pains? We know all of this, but it's just a matter of putting everything together in one line. And then you start adding in, Dr. Nitin Shah, good morning. You entered at the right time. So morning stiffness versus nocturnal pains, additive versus fleeting pains, and is there a presence of any concurrent systemic symptoms? Very simple, very easy, and just make a sentence out of this. So for example, a 2-year-old girl, non-toxic, happy looking, subacute onset, ankle and knee with morning stiffness, additive involvement with no systemic symptoms. If I make a sentence like this, even Dr. Google will help you with probably send an ANA, right? And then most of us know this. This is just for a revision. The most uneducated patient will probably come and say, "Sakali utल्या utल्या अर्धा तास पाव दुखतो." And the Hindi speaking patient will come and say, "Starting trouble होता है साहब, सुबह सुबह गाड़ी खुलती नहीं, आधा एक घंटा चलने के बाद ही खुलती है." Which is often and almost surely telling you it's an inflammatory problem. Whereas the nocturnal pains, night pains, any pain that wakes this child up is often a sinister problem, or rather a sinister problem like a leukemia to be ruled out, right? Lower extremities. Remember the lower extremities, when you see a child, you will end up invariably diagnosing a reactive arthritis, Reiter's syndrome, rheumatic fever. Still we see occasionally, but from rheumatology, it often ends out to be ERA or enthesitis. When you have an upper and lower, the list is extensive. When I have a spine, remember that JIA is a very, very unusual disease to start from a spine. So any child who has a spinal issue, please rule out a malignancy first, rule out tuberculosis, and then you start ruling in JIA, etc. And then what is about the additive nature? So a child, this is where the history is very important. A child who keeps on adding up joints versus a child who's fleeting, right? So fleeting tells you it's probably rheumatic, where one joint gets better and the other one gets affected. Whereas additive is where he keeps on adding up the joints. So both of them have different explanations. And then we all know this migratory. So we all know migratory arthritis is rheumatic fever. I'm going to give you one more secret, that any pain which keeps on fleeting with an ESR of 120, think that it could actually be arthralgias or bone pains because of leukemias, right? The message and the pattern that I'm sending you today from this slide is, when you have acute and subacute arthritis, generally there is more of pain as compared to the swelling. Whereas a chronic arthritis patient, the problem being in the synovium or a chronic JIA as a prototype, you will have more of swelling relative to pain, right? What are the known patterns when it comes to JIA that we have been hammering for over so many years? So I'll just read the take-home messages. When everything is less, the age is less, the joints are less, the acute phase markers are less, you will always think of an oligoarticular or early onset JIA, and life begins with age 1, and alphabets begin from alphabet A. You will only send an ANA in this child. As against a 2-year-old, when I have a 12-year-old girl who's having 12 joints, high ESR, everything is high, again, girls more than boys, mostly symmetrical, you will think of lupus because it's a girl, send an ANA, but then this is a situation where you will throw in a rheumatoid factor also. So when age is more, joints are more, upper extremity, please throw in an RA factor. Lower extremity, please do not send an RA factor in isolation. That's the next situation, which is a 12-year-old boy. Below the belt is not the right term to use in the mornings, but it's an easy way to remember. When I have below the belt, boys more than girls, everything starts with a B, 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 right? So you have the hips, sacroiliacs, knees. Think of a B27. And when you send a B27, do not send it with a flow cytometry. You will always use a PCR method. So these are classical situations where we are very unlikely to have a problem. And the last, which is the most common scenario in most of our day-to-day OPD, is PUO. What has been happening as I am being upgraded from number 11 to 1 is the definition of PUO is also getting shortened. From 3 weeks of OPD and 1 week of IPD, any fever after 1 week, we are starting to panic post-COVID. The issue is simple. Ask for a virgin history of fever. If the patient says दिवसाला 2 वेळा ताप येतो, सकाळी एकदा, संध्याकाळी एकदा, think that it is a quotidian fever. And then you will be lucky if you start seeing a funny rash and hepatosplenomegaly. This happy child in 23 hours and gets sick only for 1 hour in a day is the typical description of probably TB for the medical student in an exam. But in practice, most of them will evolve into a systemic onset JIA. And all you need to send is only ferritin, no role of any ANAs, RA factors, etc., etc. The clues: fever of unknown origin, quotidian pattern, hepatosplenomegaly, serositis, high ESR, high CRP, and obviously you will document a high ferritin. This is a term which is no longer called SOJIA. It's a term called systemic arthritis, right? Now, this is another important clue that I'm sending across today. Whenever you're stuck with the PUO, especially extending 2 weeks and beyond, once you've ruled out the usual malaria, typhoid, dengue, etc., and you are stuck, what do I do with this child? Is he an immunological story? Is he a malignancy? So this is a simple thing. What used to be called an aspirin test in the past is now called a naproxen test. You don't need to start naproxen when you think of me, but it's a scientifically proven evidence-based story where if I have fever with joint pain going on for 2 to 3 weeks, and I have ruled out the known infections, etc., just subject this child to 10 mg per kg of naproxen for 3 days and see the response. If fever and the joint pains disappear, you are looking at a possible systemic arthritis-like situation or inflammatory. Fever goes away, but the pains persist, then you will think that you should be looking at a probably leukemia-like situation because the bone pains do not respond to naproxen as compared to the joint pains. And when there is no response at all, so nothing has changed before and after naproxen, start intensifying your search for any occult infection or a tuberculosis or a retropharyngeal collection where the whole world is moving towards possibly a PET CT scan towards for better and early diagnostics. So naproxen test will come handy after 2 weeks of fever. So I'll just show you an example. Pediatrician looked at this patient and referred this child to me. He's a 5-year-old male with low-grade fevers, which generally is not documented, and right elbow and feet pain, and it was referred as an oligo-JIA. So everything looks okay, like how we learned. Everything is less, age is less, joints are less, but something is funny about this, and then कुछ समझ में नहीं आया, तो let's give naproxen test like we discussed. And then there was a suboptimal response to naproxen. That was clue number 1. And then when the child came to me, this was an educated family who said, there's something odd, doctor, he just doesn't put the foot down, but he can swim and he can cycle, which is quite an interesting thought. But then there should be a reason why I don't want to walk, but I can swim. And then the next question, morning or nocturnal? The answer was, this child has fever throughout, which is, and then on prodding and probing, sometimes, I can see Gandhiji there if I'm thinking of a Gandhiji. So as Ratri Jasta Dukto ka. I mean, I'm not biasing the patient, but sometimes when you're living with pain for 2-3 weeks, the history becomes a bit muddled. So this patient has Ratri त्याला भरपूर झोपायला त्रास होतो. And then when I examine the joint, I'll show you the picture in the next slide. So that's a term that we will take home from today called periarticular swelling. We know what is articular. I'll show you how a periarticular swelling will look like, right? And this child actually came with 4 CBCs. The 4th one was obviously ordered by me. What's the difference in the 3 and the 4th? Thank you. I think my job is done. Right. But what's unique about the 3 CBCs prior to meeting me was everything looks okay. To the eye that sees 100 OPDs, it looks pretty okay. Right. But then if after 4 weeks, then you start looking at abnormalities, you see that all of them have a slight lymphopredominant, right? And then platelets, remember, around 2 lakhs from a rheumatologist's eyes start getting concerned because you won't get a low platelet overnight, right? And then the ESR, which was sent for the first time, came back as 110. So 3-digit ESR is a problem. A child who doesn't want to weight bear is a problem. Swimming doesn't cause that much of weight bearing. So probably the child was happy doing the swimming. And then elbow and feet is a very, very unusual joint. So you put together all of them, straightforward, you know that this is not JIA. And to top it up, we said oligoarthritis ESR is 10, not 110. So, and then the final clue was no response to naproxen as far as pain is concerned. So what's the diagnosis? It's a no-brainer. It turned out to be a Luke, right? But then this picture is something that I want all of you to remember. This is how an articular, this is an ankle joint disease, which will show a nice prominent synovial thickening or a swelling. Whereas this is the whole feet looks puffy and swollen. That's that marrow related story or proliferating blast. That's from malignancy point of view. This is a periarticular, and the only differential in inflammatory arthritis is probably a B27 disease, which can come with enthesitis. But again, in this short history, I think when you look at an articular problem, you think of JIA, but when the pain looks periarticular, you will probably see leukemia and rule it out as a priority, right? So what happened to this boy was I put him on naproxen and nothing worked. And this father sends me a video from some vineyard close to Sula, probably. But then the child looks too sick. I said, please give him Ultraset for the night. And I referred him to Mumbai. And sure enough, Dr. Nitin Shah called up and said, this is leukemia. You see the pain. I just want you to listen to what happens when I squeeze his feet. This is not JI, right? And please don't use steroids, because it just takes one phone call to come from Nasik to here, and the diagnosis is done. The patient forgets you after that is a different story. But then I can see a smile on someone's face, means he's in the right hand. So even my job at times is not diagnosing, and it's just referring him to the right specialty earlier. That's all that matters. So remember the clue: more of pain. This child is sick and more of pain, and wearing a t-shirt, giving a diagnosis. But it turned out not like, you will never see a t-shirt like this again, but you will see a child like this for sure. So it's not JRA, it is probably a leukemia, right? The next situation is a very practical situation which figures in all my talks, because I still keep getting such cases. So these are 3 situations where the patient might end up in your OPD. How many of you are happy with the first scenario? How many with the second? And how many with the third? Perfect. No surprises in that. But I want patients not to come to the third, right? Most of the problem with the pediatric practice is many of them will come to you in the second situation, But remember, the report looks okay, but it is 15th day of fever. 15 days, if someone is coming with this, it makes a lot of sense to revisit the history. So the way of analyzing this is HB is universally low in rheumatology, as far as my thinking, whether it's chronic inflammation, etc., whatever is the problem. But remember, WBC and platelet should always go in one direction. It's like driving a highway. In a highway, if I am driving at 300, बाजू वाला भी 400 पे है, फर्क नहीं पड़ता. The minute you start seeing someone coming from the other side, so that second situation, counts are high, but platelets are coming in the opposite direction. That's the trend I want all of you to start looking for at least. You will see definitely that A 25,000 counts coming to 15,000 is a 50% drop. So if I can quote our Dr. Amdekar always, it's a falsely normal or falsely high count. There has to be a reason. If the counts are dropping, child has to be getting better. This is the same fever which started off with inflammation. 25,000 counts, platelets 7 lakhs, 8 lakhs, 10 lakhs. I am very happy because it's pro-inflammatory. The minute one of them starts dropping, yeah, then you start smelling trouble. And remember, I'm not blessed like the oncologist or hematologist where my baseline CBC is leukopenic. I deal with conditions which are leukocytosis. So a count from 25,000 to drop to 2,500 will not take, 3 days or 2 days. That's the issue that I mentioned as evolution. These are things which will evolve. And if you miss the bus on day 15, viral ahe, antibiotic step up kara, etc., then you will end up with the last situation. Is there any way we could have caught this on day 1 or day 2? I have a pen which I have left at the registration counter as a souvenir. That pen doesn't stop with CBC alone. Your wish is my command. Does now life make a difference? The first time, everything is pro-inflammatory. So at least I may not have a diagnosis, but I know that I have time on my hand to get the diagnosis. The second slide, if someone would have done an ESR, it's 40. So that 80 has become 40. These are subtle clues that there is something amiss. CRP is change, lab change ho gaya, doctor change ho gaya, but still high. But the third one is a problem for me. ESR 15 this is proper MAS or HLH, call it whatever you may. But the first condition is what I call it as inflammatory phase, or it's an occult macrophage activation. You may not have obvious mass or HLH on a marrow because rheumatology happens in all places where there are macrophages. So the marrow might be clean. The second one is more of a subclinical because this child is kind of worsening slowly, but yet not worsened completely. And the last situation, I would not want to manage this because it's obviously a headache for all of us. So again, no disclosures remains the same, no royalties, but they all look the same. Every conference we keep asking the same question, HLH and MA same ahe ka? And this is my rescue slide. Just an easy way to understand is H for hemat, H for HLH. So think of HLH as something which follows leukemia. Life becomes easy. And that's the clue, to answer all the questions is marrow killer, HLH decel, most likely in a luke. But in a systemic GIA or a lupus who presents with a mass, the chances are very few. You may not see HLH which counts of 25,000 in the peripheral smear. So that's the subtle difference. And the rest of the things, I guess people can read up aram se. Right? The other message is please do not stick to only ferritin. The bad habit that many of us will have is only ferritin. If ferritin normal hai to HLH nahi hai. Please remember, you are dealing with a potentially life-threatening condition. You will do the full HLH workup. Ferritin, fibrinogen, ESR, CRP, CBC, LFT, and fasting triglycerides. Hypertriglyceridemia more than 160 and hypofibrinogenemia less than 360 are enough clues to give you some sort of a resolution. And remember, bone marrow is not diagnostic of a macrophage activation syndrome because the mass might be happening wherever there are macrophages. You may call it as glial cells, mesangial cells, Kupffer cells, osteoclasts, etc., as we know. I can't have a talk without this slide of mine. No political affiliations, but what's going to follow next? Two things you should be writing every single day, at least 4 times. That's my prescription. 2 CRP-ESRs 4 times a day for the next 3 months. I think we all will be wiser. And this is, I have used Tom and Jerry, Dhania and Kadipata, Laurel and Hardy. This is yesterday's. So this is CRP, orange juice. Jaldi se sugar बढ़ जाता है. Nothing happens. But the other one is something which kicks in a bit late, but more gratifying eventually. So please do not separate an ESR from a CRP. I just need 7 or was that for me? Okay, thanks. So most of us know this slide. Remember that only 4 combinations are possible. ESR low, CRP high is the most crucial one, right? And the child is sick. So remember, 3-digit ESRs, you will probably worry. A normal ESR in a sick child, you will definitely worry. But please start doing an ESR. Most of us have started doing that ESR, right? What's this? There will be 2 answers. One is based on what you think it is, and one is disto tasa nasto. So when you are stuck in such a situation, start looking at the t-shirt. So both these kids very uniquely were wearing a t-shirt which said probably the coolest and the cool one. What is this? Spot 1 diagnosis only. You can't be wrong with this. NX only purpura, right? And fits in with the t-shirt also. It's one of those conditions where the lesions look angry, but ESRs are seldom very high. But then this boy and this girl came with CRP of 20 and ESR of 100 and 120. Is it still HSP? Probably no. There is something going wrong. So when you see a rash like that, you will think it's a vasculitic rash. What vasculitis? It's not large, it's not medium, it is a small vessel disease. And then you start digging into the history. 5-year-old girl on the left side, and she was from Gujarat. And my parents said, "वो जरी का allergy है उसको, वो जरी का कपड़ा पहनेगा तो ऐसा होता है." And the dermatologist was smart only because he sent an ESR. And then ESR was 120, and the counts were, there's something wrong. What's wrong in the count? Remember the highway. One going in one direction and the other coming in other direction is a problem. So the white cells are lowish, and the platelets are high. So there is inflammation, but she looks happy to be HLH also, doesn't look malignancy. But then she's a girl. So you obviously think, is it something like an SLE, etc. The other kid was 10-year-old boy from Jalgaon, recurrent rashes since 4 years of age, and then now has joint pains and this kind of, he reaches a teaching hospital where the skin lesions get biopsied, and it's said it's small vessel disease, mostly HSP, will get better. But again, and this patient came to me saying, "कोई तो मिल जाएगा, मुंबई पर्यंत जाता है तर एकदा ज्युपिटरला जाऊन दाखवून द्या, कोणीतरी भेटेल." And then I saw this boy, right? And then some wise person had told me that problem Kanyakumari mein hai to Kashmir mein dhoondho solution, which was his nice way of telling head to toe examine karo. So when I saw the rash on the leg and you start examining, the kid on the left was being labeled as allergic conjunctivitis for the last 6, 7, 8 years. Whereas the kid on the right, you open the mouth, a 10-year-old has got dental caries. Right? Now dental caries and this you start connecting. So the next pattern I want you to remember is a 10-year-old should not get dental caries. Dental caries in a 10-year-old means there is deficiency of production of saliva. That's one that a dentist had taught me some time back. And then this is lack of saliva and lack of tears. And now you start connecting the dots. You have leukopenia, you have a platelet which is inflammatory, you have dry eyes, you have dry mouth as a dental caries, and then you have HSP-like lesions. And then this boy had recurrent parotitis since 4 years of age, which the history was missed. And then you start connecting all of them, and we come across a term called Waldenstrom's hypergamma-globulinemic purpura, which is a fancy word for nothing but high proteins and purpuric lesion. This turned out to be, what's the diagnosis? Primary Sjogren in a 55-year-old will come with Sika syndrome. In a 5-year-old, you will have to look out for subtle clues. So next time, dental caries, I'm not saying all of them will end up having Sjogren syndrome, but the pattern fits in nicely. ANA came as 1 in 1,000, anti-Rho positive, diagnosis done, right? The last few slides, these were 2 kids. So one of my students is doing her DNB in Northeast. Every 15 days, she keeps on sending me such patients. हमारे पास एक 12-year-old girl आई है, And now I have recognized patterns. I ask her, gynac se aayi hai kya? Because many of them will enter gynac with menorrhagia. And one kid had a diagnosis of chronic ITP and assured that you will have to be living with platelets of 20,000 and she will never bleed in life. And ANA was done, which was 1 in 320. Now, when you do something and you find something positive, just spend that extra 5-10 minutes to understand why it may be positive. And this girl, sure enough, did not bleed, but ended up with a clot. She had a sagittal venous sinus thrombosis. And then, can you bleed and clot at the same time? And then she evolved. I think we started 10 minutes late, no? Sorry. So the pattern recognition in this slide is what's common to both of them. One kid will end with the hematologist with a diagnosis of Evan syndrome. And then Evan syndrome with an AN of 1 in 1000 is a problem for me. You rule out lupus because lupus is more common than Evan syndrome, which is idiopathic. And then what is the diagnosis? Apply is a very good thought, but what's the primary cause is probably rule out lupus as a primary. When you have autoimmunity shouting this at like this, low platelets, counts are low, and remember this pattern, CRP negative, ESR high. You have to have lupus as the topmost differential, and then we screen and diagnose lupus, right? The last case, the last inflammatory case. This was a child who presented with bilateral upper eyelid swelling. Any clues? Low grade fever since a month, severely constipated. Obviously, this is not cellulitis because you can't have bilateral cellulitis, etc. And the same CBC will come back and hit you. Low counts, platelets are low this time, a negative CRP and a positive ESR. All you need to do is open the mouth and you see hard palate ulcers. And what came to the rescue was the CSR CRP again for the pediatrician, and open the mouth is very easy to do. And if you examine, IV line dalne ke time this child has dactylitis or arthritis also, right? So low counts, low platelets, normal CRP, high ESR, please rule out lupus, right? And then obviously this girl ended up with a TSH of 100, which was causing the constipation, which is an autoimmune thyroid as a part of lupus. And sure enough, they do extremely well. So when do I think of lupus? You will always think of lupus to diagnose lupus. Most of us know all the things I have mentioned. I'll run through this for want of time. I'll just show a few interesting cases and then I'll finish. This was a 12-year-old girl who presented to my OPD with slow progressive deforming digits without any stiffness. So the rheumatoid arthritis, remember, takes years and years of inflammation to become stiff and damaged. This girl was tightening up even without stiffness. And in my waiting room, which is a central AC room, this child suddenly, by the time I finished my rounds and came, she was showing up what? What's there on the right side? In a cold room, can you spot some duskiness? So that's Raynaud's. And then when you look at the girl, you start seeing that there is a pinched nose. This child is stiffening. So she's probably got sclerodactyly with Raynaud's phenomenon. And then you obviously know that you are dealing with a systemic scleroderma. How do I prove it? You just do an anti-ACL70 and you will diagnose systemic scleroderma. So one slide, which is an important slide, when do I send ENA? What is an ANA and what is an ENA or an ANA blot? ANA will diagnose if you have anti-nuclear antibodies by immunofluorescence. And the minute you come with a positive ANA, you find out which antigen are the ANAs directed against. Those are your antibodies to extractable nuclear antigens. And depending on which antigen the child picks up, you can label the disease, right? The last, I have 5 minutes, 2.5. Because this last 3 slides are important from day-to-day pediatric practice. When you start thinking of systemic arthritis less than 1 year, this was a very nice pickup by a pediatric department. The child was referred to me as a, now the child is 5, but the bogginess of the joint was what got the This is, I think, Dr. Sane's patient. So he said, this is definitely synovial, articular, and this child, but he's unique because this child has got fever since infancy. And then this joint is very boggy. Remember, when you see such boggy joints, start thinking is the synovium infiltrated. So boggy joints equals sarcoidosis. Rule out sarcoid. But what was very unique was infantile onset of fevers. This child has been running fever. And then same problem Kashmir, Kanyakumari mein hai to Kashmir mein dekho. You observe what's happening in the leg. This child has a very rough ichthyosiform rash. You flash a torch in the eye, you start seeing a pupil which is festooned. So you don't need to be an ophthalmologist to say that this child has chronic uveitis. And then you start connecting the dots. The eye doctor comes into picture and says, "Arey, isko to mutton fat KPs hai." So job done. The boggy joint suggested sarcoid, the arthritis. The torch told me the uveitis, and the opthal confirmed me sarcoidosis. So this is a condition called Blau syndrome or infantile onset sarcoid, where you will have and all of them can be grouped under one group, which is called autoinflammatory disorder. So the take home pattern from this slide is when you see infantile onset of fever, rashes. So I call it SSC examination: synovitis, serositis, cutaneous, and ice. Any combination of this less than 1 year, please start thinking autoinflammatory, which is a disordered immune or innate immune system problems, right? This is promised. Last few slides, 2 or 3 of them. Very practical issues in the OPD. एग्जाम के लिए राइटर चाहिए, 5 दिन में बताने का है कि राइटर है कि बच्चे से लिखवाओ. So remember, I hope, sorry, this video plays. I mean, no prizes for guessing. What is all this? Mechanical problems or hypermobility. But I'll show you a kid who came to me with a genuine problem. SSC exam, this child doesn't have enough speed. Look at the way how this child holds the pen. So she doesn't have enough of grip. The muscles are hypotonic, and it's not life-threatening or any glamorous disease that we would expect. I won't send an ESR with the same pen in the same girl. It's a spot diagnosis. This child doesn't have enough strength, and that's why she can't hold her pen. Add to it a flat bench and cursive writing. Enough reasons for her to decide writer versus, this is one more kid, and there are quite a few kids like this floating around. Just ask them to write their name and see how पांचों उंगलियों से pen पकड़ेंगे, and see how they keep on writing and writing and writing. And all you need to do is counsel them there is a problem, and this is a package: bad handwriting, poor speed, recurrent abdominal pain, leg pains, headaches, all used to be clubbed into growing pains probably. But remember, growing pains is beyond growing. It's something we can offer a possible scientific diagnosis. Most of us know what is this Gorlin's sign. Kids with hypermobility can do crazy things. The next photograph that I'm going to show, nobody will click because that's a super copyrighted. I don't even know how did she manage to do this. आम्हाला हे नाही जमत, तुम्ही हे काय सांगता, आम्ही हे करून दाखवतो. This was a 12-year-old who showed me I can show you better than Gorlin's sign, right? So hypermobility can behave interestingly, but if you give a foolproof solution to parents, and it's a spectrum. The youngest pediatrician will see growing pains, and probably someone who's into 20, 30 years of practice will start seeing premature osteoarthritis, low back aches, etc., etc. So remember the spectrum, right? The last kid, again, t-shirt clue, 12-year-old female with a hip joint disease. But then what struck you was more than the hips. And hip is never the first joint to get involved in JI. This t-shirt actually had Angry Birds written on it. Unlike the previous, this child's ESR was 10, but her t-shirt was more angrier than her story. So what's this? It's children who are hypermobile, flexible, loose collagen, and she was a trained dancer. So by virtue of hypermobility, the bones were protruding inside. This is a condition which we've seen before. It's called protrusio acetabuli. It's a mechanical impingement of the head of the femur. behaving like arthritis. So I'll conclude with these two kids, these kid, everyone agreed that was sick, and it turned out that with 1 hour of hearing out what the patient said and seeing what this child was doing outside my room, this child had learning disabilities. There were marital rifts in the family. Grandmother had died. A lot of psychosocial issues. Had only pain amplification syndrome. And the only place where this child could find solace was the hospital. So he started from the western suburb, ended up in Navi Mumbai. Every hospital, 4 days, 5 nights, complimentary bill of discharge. But he was having a gala time. I listened to him and I put him in the gym. This is the same boy. He loses weight. Everything is happy. And life just changes because he showed a lot, but there was hardly anything to be seen. So again, less is more or more is less. You guys can take your pick, but it's one way of understanding when you're hitting a roadblock. There's nothing that I could see in this child with so much of, he ended up getting ganglion injections, solumedrol, EMGs, NCVs, and then JI. This is not JI for sure, right? So what's the take home message? Everything is there on the wall to be seen, right? Rule number one, less is more is less. With a little bit of practice, you can make out. Stop looking, start seeing. Stop listening, start hearing. I met a friend of mine who said, I have stopped reading, Manun, I am listening, which was a third thing which I couldn't add due to want of time. But that's whoever comes to MAHAPEDICON, I have stopped reading. So I come to listen. And then once you start seeing and hearing, you can actually slot them in the right chapter of the book, which is where we started on. And then once you are in the textbook, it's easy to select a few tests if needed. You will zero in on the paragraph, sentence, and the word follows. And remember, pray and watch for resolution while I wait for evolution. Pattern recognition. Most of us have recognized the pattern. How many of you can name the names quickly? Of the movies, not of the person in the middle. Starting from the right up, what's this? Dostana is good. Very good. Shah, Googly, very good. No prizes. नहीं. Visual नहीं है. हाँ, काला पत्थर. So thoda gadbad hai, but then with the practice and pattern recognition, most of us can remember this even at the best of the banquets, right? So think of Vijay, you will think of Amitabh, and think of Amitabh Bachchan. It's just a matter of putting it into the right brackets. I thought that this applause will come after this slide, but that's fine. There's a warning for all the male spouses. You have left your residence in Mumbai with this slide, ना? इथे जातोय मी महापेडिकॉनला आणि मग असं डीपी असेल तुमच्या घरी, असं पण डीपी असू शकते. Change the date, please. महाबलेश्वर का change कर देंगे. And then your wife will be thinking you are in London or Tokyo or Dubai. But then थोडं erroneous pattern मध्ये गेलात ना, तर हे पण दिसेल. आणि one thing which was interesting was this was what we got to know yesterday. वो end में एक सूला भी दिखाई देता है उसका. And then this could be your DP. We will say Dr. Ramakant Patil sent this to thank us for visiting us and come back soon. But do not go overboard with that also. So this is, your wives are very smart in recognizing these patterns also. ही कोण होती आणि हे सूला सारखं का दिसतोय. Chalo, thank you very much. I can take questions.
Thank you, sir. Thank you for the very informative lecture. So please be on the dais. Now I request our chairpersons, Dr. J.S. Patel and Dr. Sanjay Paviskar, to felicitate our speaker, Dr. Vijay Vishwanath.
एक थोडीशी कॉमेंट करायची आहे मला. यांचं नाव आईवडिलांनी विश्वनाथन आहे. मीनिंग देअर बाय विश्व मीन्स युनिवर्स, नाथ मीन्स मास्टर. हे जगाचे मास्टर आहेत. And the same way he has masterly explained us everything in rheumatology. Thank you, sir.
Now I request Dr. Nitin Shah to felicitate our chairpersons, Dr. Jayas Patel and Dr. Sanjay Bhatt. Sir, we are on the group photo. You are.
The next topic is best office practices in vaccinology. Each one of us have our own interpretation of the word best practices. One might think complete vaccination of a child from BCG to Japanese encephalitis and a make bag full of profits out of it is the best part of his practice. Another person might think that giving appropriate vaccine at appropriate age, covering the vaccine preventable diseases as they appear, is the best part of his practice. And I'm sure Dr. Nitin Shah today will give us a rational and academic opinion of best office practices in vaccinology by each one of us, either we are working at a government institute or at the swankiest clinics of South Bombay. Dr. Nitin Shah, please. I ask moderators Dr. Anil Kasliwal sir and Dr. Ramakant Patil sir to be on the dais.
So friends, first of all, I'm very happy to be here and I really thank the organizers for this wonderful opportunity. I thought vaccines are best discussed in the form of question answer rather than a monologue. So I took the liberty of making this into a dialogue rather than a monologue. So I would request the chairperson, I think Ramakant is going to do the honors of asking question. I'll answer the questions. So whatever question you want to know, yes, sure, I will sit and do it, no problem.
हेलो हेलो गुड मॉर्निंग कल की उतर गई क्या ठीक है सो ओके या आई नो
मैं तो रात को उतरा लेकिन टैक्सी से
चलो ठीक है सर ये वैक्सीनोलॉजी सेशन है एंड वी वांट आंसर्स फ्रॉम द डॉन ऑफ वैक्सीनोलॉजी डॉक्टर नितिन शाह I begin the match with the first question. What are the significant points mentioned in new WHO position paper 2021 regarding PCV?
So as you know, WHO has a position paper which is being renewed every few years when new data emerges. And we had to start with PCV 13, then came GSK's PCV 10. So the original position paper mentioned about these two vaccines. And as you know, and I think all of us should be very proud that an Indian vaccine made locally for global use, that is Serum's PCV 10, was pre-qualified in 2019, just before pandemic started of COVID. So WHO then took a position on inclusion of this new vaccine in its position paper. So that is essentially the additional paper in 2021 to its original PCV position paper. And that's where it took cognizance of the data set that was presented on this new serums vaccine, starting with a very small study in the adults for the phase 1, what we call for the immediate safety in 35 adults, went on to phase 1 to Gambian data on PCV, new PCV from serum. And then based on the Gambian data, the proof of concept that the vaccine works, the vaccine is improvised and then enters phase 3. That's the typical story of any new vaccine. So two phase 3 data very important. One in again Gambia, where it was compared with GSK Synflorix. And then second, an Indian phase 3 data where it was compared not only with Synflorix, but also with Prevnar 13. And there was a data set on toddler use, which means if you give this vaccine in the second year of life in naive children, how it compares with Prevnar 30. So these three important data sets were available and presented to the WHO's committee. And based on those the data, it made recommendation to say that number one, this new PCV10 is as safe as the existing PCV10 of GSK and the PCV13 of Pfizer. So safety is not an issue. And two, it said that based on the immunogenicity trials, which look at the non-inferiority, because as you understand, when a new vaccine comes, it's very difficult to do a double-blind randomized control field efficacy trial because it's expensive, and the countries which can do it already have PCV in the program, so they cannot do a placebo control trial. So to the rescue comes the WHO recommendation of allowing any new PCV to be licensed based on immunogenicity non-inferiority. So the immunogenic non-inferiority was established in these two phase 3 trial, one in Gambia and one in India. So based on it says that looking at the immunogenicity data, it has passed the non-inferiority set, which was set up as the cutoff compared to the existing vaccine. So it will do as good as the existing vaccine. And I think that is the bottom line, that this vaccine is as good as the other two existing vaccines. Remember, we pediatrician may dissect small data set, 1 point here, 1 point there to decide our choice. At public health, they do not do that. Like say in public health, they will say Synflorix is as good as Prevnar 13. Though we dissect over years so many differences between these two vaccines. Same way, they say now all the three vaccines are same. So once the WHO pre-qualified, it means it can be used by UNICEF for purchase for Gavi funding. You know, Gavi is one source of funding for poor countries. So it's the Global Alliance for Vaccines and Immunization, which gives this life-saving vaccine at free or at throwaway part. Like say, PCV is available for $1 or $1.50 a dose, even when the commercial cost may be $100. So once it's WHO pre-qualified, Gavi can purchase it. And it's very happy to note that the Gavi has made an advanced market commitment of 10 million doses of new PCV of serum per year for the next 10 years, which means 100 million doses will be used all over the world. And there are several countries where this vaccine is also marketed in the private market, and it's gradually replacing the existing vaccine because it is cost effective. So this WHO additional position paper gives you that impetus or that what you call confidence in prescribing this new vaccine because the WHO says that is as good and as safe as the existing vaccine.
Thank you, sir. Please bear with my voice because this camaraderie and banquet takes off the load from gray cells, but it has got its effect on your lungs, heart, and liver, and even meninges too.
It is said that if the organizing security team do not lose their voice, they have not conducted the conference well. And this is, I'm saying, out of the experience of doing 3 pedicons. And every pedicon on the first or second day, I have a completely, not speechless, but voiceless.
Speechless, of course, because of the people like you who are on the dais and on the giving us imparting knowledge. Sir, to toe the line of PCV, new PCV 10 and old PCV 10. And I have heard you so many times for
Yes.
AC, BCs,
Yes.
and Josna et al. And all these people,
Yes.
tiles. So how does this 6A and 19A really makes a difference
Correct.
for this new PCV 10 and what is old PCV 10? And I think that is the difference particularly. How does it make the difference?
Right. So today you have the highest valency PCV, PCV 20 from Pfizer, which is licensed for use for adults in USA already. The studies are being conducted for its use in children world over. So till that vaccine comes, the only existing PCV with highest valency is PCV 13. The difference between the PCV 13 and the 2 PCV 10 is that in the old PCV 10 of GSK, 6A 19 is not there and the type 3 is not there. The new PCV 10, 6A 19 are retained. 4 and 18C are dropped and type 3 is not there. Now type 3 is not there in other two vaccines. Why? Because as you know, not 1 but 6 or 7 different countries have looked at the impact on type 3 disease with PCV 13, and it has showed that there is hardly any meaningful decrease in the type 3 disease because type 3 is a very large serotype with a huge capsule. Antibodies just cannot enter and kill it. So even the additional WHO position paper and the original position paper, WHO very clearly said that as on today, we have very limited evidence to say that type 3 works in any vaccine. So let's keep type 3 away. So now we're comparing the 12 serotype versus the remaining 10. So the old GSK vaccine doesn't have 6 and 19A. The new vaccine doesn't have 4 and 18C. Now 4 and 18C together are around 1 to 2% in the Latin American countries. In our country, they are around 2 to 3%. And most of these serotypes, both 4 and 18C are more of like an outbreak serotype. So they come in sometime in very huge numbers and they'll disappear for 5-10 years. So while Serum was making this new vaccine, it was not for India alone. It was making vaccine for the global use. Remember, the genesis behind the new Serum vaccine is not a commercial venture. It's the path, the program for appropriate technology in health, and the WHO and Melinda Gates Foundation, which have said that one third world country should make PCV so that it will make it very cost effective for the world. And I think that is the genesis of this third world country manufacturer being encouraged by the international agencies to bring out vaccines, because they know once they make it, it will be like dirt cheap. So they took the 10 serotype, which are the commonest 10 serotype in children in the entire world. So you may have some country where the coverage may be 60, one country where 80, somewhere is 75. I wish we could make a country specific vaccine. That's not possible because making vaccine is not a joke. So they took the 10 commonest, in which 4 and 18C, because they were so number less, that they were dropped. Now you'll say, why not keep 4 and 18C? Now remember, if you compare PCV 20 and PCV 7 historically, for the 7 common serotype, the titers in PCV 20 for those 7 serotype are at half the level as compared to PCV 7, because there are additional serotypes which are fighting for the immune system to respond. Same which we knew that between PCV 13 and PCV 7 for the common serotype, the titers are lower in PCV 13 compared to PCV 7. So you keep on adding more serotype in a PCV, it's going to happen at the expense of lesser immune response per serotype. So if you can avoid adding too many serotypes which are not that important and yet maintain the best 10 serotype of the world, you make a good vaccine. And that's exactly what it is. Now coming to 6 and 19A, why they're important. 19A, after use of Prevnar 7 in USA, went up from 2 per 100,000 to 8 per 100,000. That was 4-fold rise. In fact, of the remaining 15 per 100,000 disease burden in USA, say in 2003, 2004, 50% was 19A. So there was no cross protection between 19F and 19A. It was thought that 6B will cross protect 6A. It does cross protect, but not to the level that it will lead to herd immunity. Now we know after use of PCV7 in the United States that for one child who benefits because of direct vaccine effect, 2 more adults do not get IPD, invasive pneumococcal disease, as a part of herd effect. So you also want to use a vaccine which will also give you good herd effect. So for that reason also 6A is important. So that's why 6A and 19A are important to be retained in a vaccine. And very recently I heard in one of the seminars that 19A is going up even in our country to as much as 8 to 10% of the serotypes seen in children with IPD. And 19A is one parapneumonia, very drug resistant it can become, and it can be very difficult. In fact, I heard Dr. Balasubramaniam that in Kanchikamatchi, Chennai, their hospital, they have such huge number of 19A which are drug resistant that they use upfront vancomycin plus ceftriaxone in a patient with bacterial meningitis, something what Western countries were doing for years. So I think we are pushed to that. So if you cover 19A and 6A, probably that disease will not happen, and you will do much better to the children when you give this PCV vaccine.
So I take it that the valency should be less and less, better sero response as far as possible.
Valence should be optimum and cover the optimum serotype which are seen in children. Now, suppose tomorrow there's a paradigm shift in the serotype distribution, surely we will need a different vaccine. But fortunately, the PCVs are in use from 2000. We are in 2022. 22 years of use of PCV7 followed by 13 and also GSK 10 has not shown that any serotype has gone out of hand as a replacement serotype. So I think I'm very reassured that the existing vaccines are good enough, going to be continued for the next few decades.
And 6A and 19A constitute nearly 10 to 15% across the globe. Some variation is
Correct.
there.
So if you look at the serotype coverage with the PCV 13 and serum's PCV 10 is around 75%. Difference between the two being 2%, which is that 4 and 18C. That vis-a-vis the one without 6 and 19 as GSK's vaccine is around 8 to 10% gap. So that gap is because of 6A and 19. I think Jitu wants to ask a question.
So question is, sir,
Correct. So the serotype replacement
repeat his
is
question.
a serious issue. But as I said, in 22 years, there is not a single serotype which has come as a massive replacement serotype consistently. So you will have one serotype going out of hand in one country, but suddenly would disappear without any vaccination against that serotype. So these are not an outbreak serotype. There is no way. Ideal would be to make a 90-valent PCV. Impossible. Better will be to make a protein-based vaccine. Very difficult. So you have to live with what is the best today. And the best today is not the best of future. The future we will decide when it happens. You cannot wait for an ideal vaccine to come. And that's why I will not use the current vaccine for the fear of replacement and let children die. I think that is not correct. Public health works on what is available. Use it, keep on improving.
So I have got a question. How long we are going to chase these various serotypes? Because 90 plus are there.
Correct.
So how to do it? Because somebody will say, I am again new with new variants and those.
So
So
the
what is
problem-
the solution?
Yeah, so the additional serotypes are not a problem in children. And I think the focus of saving lives is in children below the age of 5 years, because under 5 mortality, number one cause today is pneumonia. And pneumonia, number one cause, which is fatal pneumonia, is pneumococcus. Adults have a variety of serotypes. I will ask you a question. Why PCV20 came when PCV13 was already doing so well, say in the United States? Because after use of infant program, these 13 serotypes disappeared from the community, including from adults. So much so that they say there is no need to give PCV13 to healthy adults in USA because they are already protected by a herd effect. So what was the remaining disease burden on pneumococcus in them is focus on them. And that's how the focus came on the additional 7 serotypes, which are common in adults there. So they included the vaccine. So there are two choices, either make another 7-valent vaccine only for adult or make a 20-valent and give it across. And for logistic purpose, they decided to make it 20-valent. So these additional serotypes are more important for us adults. But in our country, where there is no infant program so far, now we have just started PCV in the national program, all of us are not protected against these common 13 serotypes. So let's focus on those and then get away. And then when the PCV20 will come, maybe in India it will come in next few years, we will decide about that, how best to use it in adults.
Why ST3 is not included in PCV2?
So as I said, that ST3 is very difficult to make into a vaccine, except for 2 studies, one from US and one from Germany, which showed there is some decrease, meaningful decrease in the type 3 disease with 13-valent vaccine. There are 7 or 8 different countries which are using PCV13 and have shown that there is no much decrease in type 3. So type 3 is a large organism with a huge capsule. So even if you make a lot of antibodies, it will not enter and kill that organism. So you may develop antibodies, but they will not be protective. The same is the story with PCV15, which is from the MSD. It is going to come very soon. That 15-valent vaccine has type 3. Now, their titers are a little higher than with PCV13, but not enough to lead to impact on the disease burden. So my gut feeling is that unless you improve the antigenicity of type 3 or fool around the immune system to make a better antibody against type 3 is going to be difficult to control.
Sir, is it so that the load or of this pneumococcal disease load because of serotype 3 is less than 1%? Is it the cause also?
No, that's not the reason. Type 3 is a dreaded dreaded serotype. So if you can make a good vaccine against type 3, for sure you include it, because type 3 is also important from otitis media point of view. So-
Various studies that said that it is less than 1% the content.
Yeah, so it may be less than 1%, but once it is seen in children and it is going to be multi-drug resistant and dangerous, if you possible include in the vaccine. But as on today, it's not a good, there is no good vaccine against type 3.
Audience can definitely interrupt us and ask the
Sir,
question.
please.
They are encouraged to ask
Sathe,
their question.
I want it as a dialogue between us.
mic to Dr.
please
Sathe,
pass the
please.
mic. Or
And then
Take the mic.
we can hear, why not?
Why not insist on serotype independent wholesale inactivated vaccine in
Correct. So that is what you call protein-based vaccine, what you're discussing. And as for like pneumococcus exists for more than decades and decades with the human mankind. So it has learned to be in the nasopharynx such a way that a protein-based vaccine is not immunogenic. Like you have very difficult to make a type B meningococcal vaccine. We have 40-valent type ACYW. Why B was not there for so many years? Just now they have been able to fool around the immune system to make the immune system to develop antibody against type B meningococcus. So same way, it is not possible, it's not easy to make a protein-based vaccine. A lot of research is going on. I'm sure someday a protein-based vaccine will come, which will take away entire this session and say just one single vaccine against all serotypes. But that is a dream come true for scientists.
so soon,
Sir,
since we are on
yes,
PCV, Yeah,
Sir,
please.
I want to know whether those subtypes like A, B, C will protect against each other because
Correct. So that you are doing cross protection. So the only cross protection which was thought was 6B versus 6A and 19F versus 19A. And it has been proven that 6B does cross protect 6A and also 6C to some extent. But 19F does not cross protect against 19A. Other serogroups, there is hardly any cross protection which is demonstrated enough to make them as an advantage of any vaccine.
so this 15 strain what we are getting is 15C and vaccine PCV20 is 15B.
Correct. So when 20 will come and use in the adult market and an impact study will be seen, you will know whether it does decrease and cross protect against the other 15 serotypes from a serogroup perspective. But that's far-fetched because PCV20 is just being introduced in the United States for use in adults.
Government
Nani,
is, yeah.
don't ask
government is-
difficult question.
No. Government is going to, is using 2 doses plus 1 for PCV.
That's right.
And same applies for the polio also. We are going on the first and the third dose. So do we need to add on a dose as in a
Correct.
private?
So this abbreviated PCV use in public health is a very interesting phenomenon. UK started first with PCV7, where they gave 2 primary and a booster, but a booster early at 12 months. So their schedule was 2, 4, and 12, and they found that it works wonderful, provided it's in public health with more than 75% coverage, because type 6B and 23C, the antibody responses are poor with 2 plus 1, but when you have mass vaccination, that doesn't matter because the disease disappears. So for individual practice, you cannot do it, but for public health, you can do. And the path which was paved for 2 plus 1 in using EPI schedule was by South African trial by Dr. Sabir Madi's group using PCV9, which was an like an inventional vaccine or one before it became PCV13, where they use 6, 14, and 9 months. Because in developing countries, the maximum disease burden is in the first 2 years. So you want to give early booster. Okay. And they showed that for 6 years, the disease remained flat for those serotypes. That paved the pathway of using 6, 14, and 9 months. So UK today then made it 1 plus 1. They give only 1 primary and 1 booster after having achieved a consistently high level of coverage for last 22 years. And with 1 plus 1, they are happy. When you use 1 less dose for India, you're going to save 25 million doses. When you use 2 less doses, you're saving 50 million doses. As you know, I hope all of you know that we add 1 Australia every year in India. So it's a huge birth code where even 1 dose less means saving a lot of money. So now question coming to you that in today's time where the vaccine coverage is not that great in India, say in Maharashtra, PCV started recently, I would give them an additional PCV if they can afford, if they come to my practice. But if they cannot afford, I will not force them.
And what about the polio?
So we are digressing from PCV to polio, but good we can take because this is an immunization dialogue. So in fractional dose is the least that you do. It's a is the risk mitigation strategy, not risk avoidance strategy. What is the difference? Risk avoidance means you are given IPV to the child and he will never get wild polio, or he will never get even CVDPV, vaccine to red polio. That will only happen when you give 3 primary IPV at 1 month interval starting from 6 weeks of age, or 2 primary IPV 2 months apart from 2 months of age. Now, because we are not going to use 2 months apart, 2 months of age like schedule, we have to use necessarily 3 dose, 1 month apart schedule starting from 6 weeks. That is the risk avoidance, and that has to be followed by a booster at 15 months and at 5 years to maintain a long-term immunity, because we know adult polio is a reality. 2010, there was a huge outbreak of polio in Tajikistan, just above us in the erstwhile Russia, and there were 480 cases of wild polio, 10% of them in adults. When I was president in 2006, Namibia had an outbreak of polio, 67 confirmed cases, all in adults. So there was a funny sight of all adults receiving an oral polio vaccine as a pulse campaign. So many of us may not be protected. Now we got scot-free because the wild polio is not existing. Lo and behold, some mishap should happen, we can get afflicted. The story of IPV being made is going back to 1950s, when President Roosevelt, who himself was an afflicted person because of adult polio. So he told his lawyer partner, Francis, did you bloody get someone to invent a vaccine against this bloody damn infant paralysis, as it was known that time. And he brought Sal from Russia to USA, gave him free hand. He made IPV, rest is the story. So adult polio is possible. So we must give as many doses as possible for the ideal situation. In public health, you want to immediately have impact. So WHO said give 1 or 2 doses. We have said, okay, we will first give 1 intramuscular at 14 months, 14 weeks. That was not that good. So we said, okay, we'll give 2 intradermal at 6 and 14. Now, if same question, if the patient comes to you, the IIP does say that 1 or 2 full dose IPV must be given to such children 8 weeks apart as an early as possible when they come to you in contact. That may be a standalone IPV or it may be part of the boosters if the child is already due for the booster.
So there is no need of additional pneumococcal dose, but there is definitely need of full dose IPV.
Yes, because pneumococcal 2+1 is good enough, whereas 2 intradermal IPV are not good enough from long-term point of view.
So now coming to the pneumococcal vaccine again, can we give this new PCV10 to immunocompromised? What is your
No,
take on the
so
immunocompromised?
as on today, there's no data on immune compromise. As on today, there's no data on anyone above 2 years of age. So in such conditions, please do not use. I mean, Government of India does not discriminate that you should not use in public health 2+1 in immune compromise because we don't test people. But in a non-immune compromise, I would not give a vaccine which is not tested in that particular group of children.
Can pneumocil or Synflorix or Prevnar 13 be used interchangeably?
Correct. So ideally, it's not good to interchange vaccines because once you know the brand, you interchange only if you don't know the brand or if you don't have that brand. Now, that's not a question that the brand is not available because all brands are available. But many times pediatricians do not write which PCV they've given. So that time you will use whatever is best according to you. So I would probably interchange between 6 and 19A containing vaccines because I know they are very similar. But I would not interchange between old PCV10 and the new PCV10 or the PCV13. So for say cost reason, someone says, I have heard there's a very cost-effective vaccine now available. You had given 2 doses of PCV13. Can I take the remaining doses of PCV10 of serum? Yes, you can do it. Can I take 2 doses of PCV10 of GSK? No, you cannot do it because 6 and 19A will not be covered as good. Now, other way, someone has taken PCV10 of GSK. Now want to switch to PCV13 or new PCV10? Yes, they can do because there will be additional benefit of 6 and 19A. In fact, there was a trial done where primarily children who had received Synflorix, 3 primary, were randomized to receive either Synflorix as booster or Prevnar 13 as booster. And they showed that even with that 1 dose of Prevnar 13 in the second year was enough to give more than 90% protection against 6 and 19A. So you can do that way, but not the reverse.
Not the reverse. So now 4 and 18C you already elucidated very this thing in detailed manner. Now please decode for us what is this PCV 15, 20, 21 and why it is only being tested or being given to adults only.
Correct.
Why extrapolation is not there in children or why not being?
So PCV 15 is PCV 13 plus 2 additional serotype by MSD and PCV 20 is PCV 13 plus 7 additional serotype by Pfizer. Now, MSD's 15-valent vaccine is tried both in adults and children, and the phase 3 trials are already over and the data is available. I have the preview of even having the data on file, and it looks very promising. It's very similar to PCV 13. So in children, there'll be hardly any difference of using PCV 13 or PCV 15 because the 2 additional serotypes which are there in PCV 15, they take care of less than 1% of serotype coverage. So in children, it will not matter. In children, it will be just that you have 1 more vaccine available. For in adults, the remaining 2 serotypes almost are 5 to 6%. So PCV15 is very good for adults in United States and in Europe, where PCV13 is already in use for last more than 10 years. And PCV20 is another additional 5 serotype, so that it will cover more and more that gap which is there between PCV13 and the serotype which are prevalent in adults in the countries using PCV13 in the national program. So that is why, if you see, the recommendation by the United States ACIP is that if you are using PCV20 in an adult, you need not give PPSV23 anymore because the additional benefit is not there. But if you are giving PCV15 of MSD to an adult in United States, you have to give him 1 more dose of PPSV23 because there is additional 5 to 6% serotype coverage by the additional serotype in 23 versus 15. So that's the difference between using 15 and 20 in adults in United States, that if you use MSD vaccine, you have to give PPSV23. If you use the Pfizer's 20-valent vaccine, you don't have to give PPSV23.
But still they are giving PPSV23 after PCV20 after 1 year.
No. that recommendation is after PCV 13 or PCV 15. Today, when PCV 20 will be available for adults in United States, and if they've taken PCV 20, they don't have to take PPSV 23, even if they are immune compromised.
Okay, thank you.
Is there any data on the use of new PCV10 in children over 1 year of age for catch-up vaccination?
So as I said, there's a toddler study done in India with 4 sites. KM Pune was one of them. Children who were naive to any PCV received 2 doses of either Prevnar 13 or Pneumocil 8 weeks apart, and they were compared for safety and immunogenicity. And it was shown that on safety and immunity, both the vaccines were the same. So there is data of using PCV, new PCV in second year of life. And of course, there's data of using the new PCV in second year of life as a booster in the phase 1-2 Gambian study. So there are 2 data sets where it has been used in the second year of life, but not beyond second year. So between 2 to 5 years, you can use old PCV10 or PCV13, but you cannot use this new PCV about 2 years of age.
So we had enough of PCV now.
Yes,
We'll shift to MMR.
sure.
How safe is
So first of
MMR?
all, I must tell you, there is a huge outbreak of measles going on in Mumbai. There are at least 600 cases which are known, 3 deaths or 4 deaths. 3 of them were unimmunized. One was a completely immunized child. Fortunately or unfortunately, all of them are from slums. The epicenter is in Govandi, which is near Chembur. There's something known as Shivaji Nagar, SN, and that's where all the cases have happened. And most of them are not immunized. In fact, 2 children of the same family died. That family has 10 children, and 2 died, and none of the 10 children were vaccinated. And the parents blame that no one in the public health facility where they went to deliver told them about tubal ligation, and no one told about vaccination. Imagine how much blame can be put on something absurd like this for something which is entirely the family's fault. In any case, there is also an epicenter in Dharavi. There's also an epicenter in the Entofil in Vadala area. So I had one family of 2 children having measles at the age of 5 years, both of them unimmunized. And when I said I have to report this patient to the public health, they just ran away from my clinic because they get very worried that something will happen. So what has been done so far is that blood samples are collected from all the suspect cases. They have proven that they are measles by doing an IgM antibody. And then when they are proven, they are given appropriate treatment. Because of the hue and cry and treat deaths, now if any child is suspected measles is admitted in Kasturba Hospital. Fortunately, most of them have recovered, except those 4 children. And they are doing how we used to do ring immunization for polio. They are doing a ring immunization against measles in this area. I think more than some 3,000 or 4,000 children have been immunized around that epicenter. And hopefully, the whole outbreak will come down very drastically. So 3-4 questions which come. Number 1, do you start giving measles vaccine at 6 months in your practice? The answer is no, unless someone is coming from that area which is affected. Do you give an extra dose of measles because there is an outbreak? No, measles is not flying in the air of Mumbai. It is only in those areas. So fortunately, it will not go out of hand. So there's no need of giving additional doses. Just give them the age appropriate doses of measles. And the measles is of course part of the MMR.
What is
Coming back to the MMR question, I
Yeah,
thought this
I
was
mean,
important for people.
my question is very simple. How safe is MMR vaccine containing Hoshino mumps strain?
So that you're talking about is the Zydus vaccine, which is going to come soon, or I don't know, it's available already in Nashik. It's already available in Mumbai. So billing has started. So it's a Hoshino strain. Hoshino strain was used in many countries, including Japan. It is still being used in Iran. The other mumps strain which we use is, of course, the Geraldine strain in the GSK's vaccine and the Edmonton Zagreb strain, which we are using in the serum's vaccine. Hoshino strain is safe to use, except that there is increased incidence of parotitis, almost to the tune of 2 to 3%. Of course, this is benign. It disappears with or without any medication. And the other thing is the long-term data with Hoshino strain is not very promising. With the seroconversion to the antigens drop to around 80-85% by 2 or 3 years after the last dose. So necessitating a booster must in these children. And the third thing is, I think today Iran is the only country which is using Hoshino strain. Most of the countries are using either Edmonton Zagreb strain or are using the Geraldine strain.
So I
In fact,
think
Japan has stopped using Hoshino strain. So I have yet to see the data on this Zydus vaccine. The next month, there is a Gujarat State PANCHAVATI where I'm going, and there is going to be a session on their MMR vaccine, and there is also an ad board by the company on so telling us about the data. But whatever phase 2, phase 3 data which is already published in 2018, you'll be surprised. This is one vaccine which has come 4 years after the publication of phase 3 data. Normally it's the other way. Like the Indian phase 3 data of pneumococcal is still not published, but the vaccine is available and we are discussing for half an hour. But this is one vaccine which was already tested, published, everything, but somehow I think they could not come out with a commercial vaccine. So now it's being made available. In any case, my gut feeling is any vaccine which is licensed, and I am saying this is absolutely an off bias of all, remove all my bias of conflict of interest, etc. Whether I'm a consultant to one company or other company, all licensed vaccines are good. All licensed vaccine can be used. All licensed vaccines will help children protect against diseases which they are there. Use a vaccine rather than breaking your head about a brand. Now, brand is something you will choose personally based on the nitty-gritties of this vaccine dialogue that keep on happening every conference. But at least use some vaccine. Imagine children dying of measles in today's time in Mumbai because they are not vaccinated, and we fight Oceanomos strain and this strain and that strain. I think it's absurd. So for individual, yes, you can make your choice based on the scientific data, but practically please use some vaccine and save lives of children. Because remember, vaccines don't save life. Vaccination saves lives.
So I think this will be the last question,
sir.
and please, sir.
Unavailability of MR vaccine. Where? In public health. So please write to the Chief Minister, because there was a meeting held with IIP office bearers about the task to control measles outbreak. And one of the ways that we must quickly cover up and jack up the MR coverage in public health and MMR coverage in private market. So I'm sure it's just one of that for few days it may not be available. Same thing happened with pneumococcal in public health in Maharashtra. It was there in Times of India. Malti Ayer, who is the reporter, had talked to me also. So I says one of that for 15 days, 20 days vaccine may not be available. But otherwise, there is absolutely no shortage of MR or MMR. If MR is not available, I think it's our duty to give MMR free to those patients. We have earned enough from the society. Let's give it back. So maybe the branch can do it. You say in your area, Dr. Gangolia, MR is not available in public health. You will donate MMR as a branch or as individual and see that those children are covered so they don't have an outbreak like in Mumbai, somewhere else in the country.
One last question, please.
Udani sir.
Arey sir, vaccine mein puch raha kuch.
No, actually, I learned a lot from you,
Thank you.
but I wanted to actually ask you in the last this pandemic,
Hmm.
I've told you this before, there's been a substantial increase in SSPE.
SSP, yes.
In fact, in Badia Hospital where I work, it's gone up almost fourfold in the last 2 years. So the question was that when we analyze the cases, 70% were actually immunized.
Correct.
And yet this happened. So can you give me what do you think is the...
Generally, we know that COVID has been an immunocompromising conditions very subtly. They're not acutely like steroids, but definitely blunting the immune response. So one of the reasons, which I think probably maybe there is a immunosuppression overall, allowing these live viruses to enter areas like brain in children who have little susceptibility because of the genetic reason. So I think you may be doing the research more than me, but my gut feeling would be the same, that there might be some subtle immunosuppression with or without treatment. And we know even children have suffered long COVID, and people who suffer long COVID have dramatic symptomatology, including recurrent infections, etc. So that may be one of the reasons. But the measles outbreak is not because of immunosuppression, because of COVID, but because of lack of coverage of the vaccine. 5 lakh children are born in India every week. And imagine 5 months of lockdown and another 4-5 months of semi-lockdown. You're talking about 12 months. Crores of children have missed their vaccines. And that is the reason why measles needs 95% plus immunity community, which means 95% children in an area should be having antibody. Then only the virus will not spread. Moment it drops below 95%, there will occur outbreak. And that is what is exactly happening.
The session will go on and on when Dr. Nitin Shah is speaking, and the questions will be going on. But we have to abide by the time. Thank you, Shah sir. And it was mesmerizing. Again, time and again, it is always mesmerizing.
Thank you, RD sir. I request RD sir and Anil Kasliwal sir to felicitate our speaker. I request Dr. Atul Dashputre sir to come out dais and felicitate our speaker today.
So while they are doing the felicitation, I must tell you here that I was in Chennai yesterday for the NCPID, got down at 10:30 at the Bombay airport, and the bridge was closed at Thane. It took 5.5 hours to reach. I reached at 4 in the morning. But I think looking at the crowd and the response, everything was worth it.
Moving towards next lecture, localizing neurological science. I request our chairpersons, Dr. Mahesh Ahirao, Dr. Jayan Shah, and speaker, Dr. Vrajesh Udani, please come on stage. Although the bedside clinical examination of the patients with CNS problem is the most systematic and methodical amongst other systems, yet we need to have more than just good knowledge about anatomy and the pathology of the ailing condition to come closer to the diagnosis. Clinical science, whereby the exact address of location of the lesions in central nervous system, in short, the localizing science have to be mastered to make an accurate diagnosis. What may take us, the so-called general pediatricians, 3 hours to localize lesion, our mentor today, Dr. Vrajesh Udani, would do it in minutes. Let's learn from him within the next 25 minutes on this issue. Dr. Vrajesh Udani, please.
Thank you very much. At the outset, let me thank Anil. He has been a close friend for the last so many years. We used to be co-residents together in JJ Hospital. And he's always interested in neurology, clinical neurology. He gave me this talk. The problem is that, you have to understand, it took me many years to learn localization, and usually not in a lecture, but in a clinic with a patient. And there are some other issues which occur in pediatrics, which makes it a little different, that infants and children have more generalized, so-called generalized disease rather than localized disorders. And we call them, for example, a patient with cerebral palsy. But I'll show you that even there is some localization possible. Lack of detailed examination, as you all know, is a big problem, sensory examination, visual fields. And finally, the most important thing, do we need localization in this day and age of neuroimaging? And I think we do, because you may have incidental lesions on the MRI, which don't explain your disease, and vice versa. So you may don't have an MRI lesion to help you. So I thought, how do we approach this in a kind of a lecture situation? So I thought I'd show you cases. I hope it is interactive. I've made some simple questions. I'm sure most of you will find it pretty easy, but let's just go through the cases first. So first, I'll just talk a little bit about motor deficits. So this is a 14-month-old boy referred for acute right upper limb paresis. The right hand essentially was hypertonic, and the reflexes were more or less present. They were slightly less in the hand as compared to the leg. The leg had normal reflexes. And the boy walks. Now I'll just put it on. So he's using left hand very nicely. When I give it to the right hand, he gets angry. So you notice it's hypertonic. In fact, the hypertonia is slightly more on the right side, even in the shoulder. Okay, I think you got a little irritated over here. And as you can see, the jerks are just normal in the lower limbs. Remember, jerks generally are much more easy to get in the lower limbs in infants as compared to the upper limbs. So it's always difficult to be sure. Okay. I think I'll stop here. So where is the lesion? Right brachial plexus, cervical spinal cord, left motor cortex. Remember, you have hypertonia, somewhat depressed jerks, but not very much. Normal upper lower limb jerks, cervical spinal cord, left motor cortex, right ulnar nerve, and left capsule. You can just shout out the answers. Internal capsule. Anybody else has a different opinion? So, number one. Okay. Anybody? Second. So 1, 2, 5. Okay. So let's look at it. The actual answer is the left motor cortex. And the reason is this, I'm giving you exact reasons now. This is the actual patient. He came to me with a EMG nerve conduction, spinal MRI, everything was normal. And the lesion we actually was in the brain. This is the area of the hand knob, which is the area which controls hand movements, and fingers and palms are maximally represented. And there was a little involvement of the white matter below as well. So why does this happen? Whenever you have cortical lesions, you have very localized deficits. So capsule is very difficult to believe because there's nothing else, no other lesion is there, and there's no weakness of the lower limb or anything. And whenever it's convexity, you mainly get upper limb and maybe face. And if it is interhemispheric, you get mainly foot. And remember, if you have seizures, if you have aphasia, apraxia, cortical sensory loss, that will help you to localize further. But this is often not possible in children because it's very difficult to test. Looking at the subcortical lesion, the same, this lesion is cortex and subcortex. The fibers from the leg, see, they are here. So they're going in the medial part next to the ventricle. And the fibers, the hand, are a bit lower down. So this is where the fibers are. So any lateral lesion will give rise to more of arm. The medial lesion will give rise to leg. Now, one thing is important. If you have bilateral lesions, then both your bulbar, your corticobulbar tracts are involved, and therefore you will get pseudobulbar palsy. So explanation now, if you didn't notice it, the finger was like this, the thumb. You want to see it again? I can show you, but throughout the hand, the cortical thumb was there, which is basically a flexion of the metacarpopharyngeal joint and is by the median nerve at C8T1. So in the right brachial plexus, the thumb flexion is not explained because the flexors are working, and C8T1 is where the hand is. So that is probably not the case. Cervical spinal cord, again, thumb flexion not explained, and upper motor neuron in the lower limbs is not there at all. However, this can happen in enteroviral myelitis, where you may get pure motor weakness from the anterior horn cells. I've already mentioned left motor cortex, cortical thumb is characteristic, and this is important. When you cut only the corticospinal tract, you only get hypotonia. If you cut other tracts along with it, this is experimental animals, you get spasticity. So remember, corticospinal tract by itself will give hypotonia. Right ulnar nerve cannot explain wrist extensors. Wrist extensors is radial nerve. And, obviously cannot explain the, that's a radial level. This is ulnar nerve, so obviously not. And like somebody was saying, internal capsules, dense hemiparesis. In the second area, which is involved with the motor deficits come, is from the gangliocapsula. Ganglio means the basal ganglia and the capsule. And as you can see, this is the basal ganglia. This is the basal ganglia over here. This is the capsule. This white part is where the corticospinal tract is, and the medial side is the thalamus. So that's why you, of course, get a small lesion over here is enough to involve everything. You get a dense hemiparesis. Because the sensory fibers are just anterior, you get hemisensory loss. Because the red part over here, the optic radiation is very close, you also may get hemianopia. And because the basal ganglia are often involved, like in this picture, you also get dystonia. So subcortical basal gangliocapsular lesion, you get all these other deficits. Now let's look at the second case. This is a 7-year-old boy, global delay, severe dysarthria, difficulty in speaking. He drools, he has chewing difficulty, his comprehension is normal, he understands. He's got a mild left upper motor neuron facial palsy. His gag reflex is preserved and his jaw jerk is brisk. I'm asking.
बाहर निकाल ऐसे बाहर भाई जीभ हिला
He cannot move it fully, it only goes to the right.
नहीं जल्दी हिला
I'm asking him to move it right and left and very fast, which he can't do.
ऐसा कर नहीं किसिंग करता है ऐसा कर
I'm asking him to kiss.
नहीं किस
He can't do that.
ऐसे कर मुंह ऐसा फुल
I'm asking him to
देखो
blow his cheeks.
करो करो करो
Can't do that.
जीभ दिखाओ नहीं जीभ नहीं वो किसिंग करो नहीं ये थूक गिरता रहता है क्या तेरा नाम क्या है
You can see the facial. The right side is little better. The left side is slightly less nasolabial fold.
कहाँ रहता है यश यश बोल
He cannot speak very well.
घर में कौन रहता है घर में कौन रहता है
He's,
ये कौन है बोलो बोलना
So he
अच्छा
has
ऐसा
lot
कर
of-
हाथ बाहर रख
and hands are
Dono
pretty
barak.
good. Hands are pretty
Dono.
good, which I'm showing you over here. Hand
के
function is
दिखा।
good. Legs also are pretty good.
चल Yeah.
Okay. So where is the region? Broca's area, where language is. Bulbar region, which is the bulb, is the medullary, all those lower cranial nerves. Perisylvian area or Wernicke's area, which is basically the cow. Bulbar region. Anybody else? Any ideas? Absolutely correct. So it is the perisylvian region, and this is what is called the congenital, usually congenital perisylvian syndrome. So this area over here, look at the bottom thing over here, is the mouth and tongue and all those areas, swallowing areas. If it is damaged on one side, it won't cause a problem because it is bilaterally innervated. But if it is bilaterally damaged, now this is clearly a patient who has gliosis from HIE, and this patient is born with this malformation, polymicrogyria, in the same region. So these patients have perisylvian syndrome. And because next to it, might be because of hand is nearby, you might get some hand weakness and facial weakness. Broca's, you cannot explain weakness over motor muscles. Bulbar region, like somebody said, you can't explain the jaw jerk, which is brisk. It's upper motor neuron, it's a pseudobulbar kind of thing. Penicillin, of course, I explained to you, and Wernicke's, of course, intact comprehension is not possible. Let's come to this. Basically, you do a lot of speech therapy, you try and exercise the oromotor muscles and stuff like that. Unfortunately, in much of neurology, there is no vaccine or medication. Anyway, this is a patient who came to me with this quadriplegia. Diagnosed as cerebral palsy, delayed motor milestones, never walked. I'm checking her eye movements, which are full. I mean, I just have to make this full. She's taking out her tongue. She's moving it fine, unlike the last patient, remember? She's pursing her lips. She has a little difficulty in blowing her cheeks. She's very normal. You can see how interactive she is. And she's very weak. She's like hypertonic trunk. She's falling. She's like a rag doll, so to speak. Hardly can move her hands up. Very weak. The jerks are not hyporeflexia. They're in fact he used to come to you in free OPD first.
No, once he came.
No, that's why he came first in 2014. He came to see me in March.
Because I.
Very brisk jerks. Okay. Good eye. So I'll stop here. Where is the lesion? Where is the lesion? Everybody knows now. So it is obviously cervical cord and not anything else. So motor cortex, internal capsule, periventricular wide matter is not the case. And this patient actually had an atlantoaxial dislocation. Now, just to explain to you why it looks like the cervical cord. Cervical cord will obviously give rise to quadriplegia, but everything about that, the corticobulbar tracts, which are involved in speech and all this, and the brain, which is involved in etc., IQ and all that kind of thing, those are normal. So whenever you have a patient who is, quadriplegia with everything like this, remember most spastic quadriplegic CP are very down and they can't speak very well. In fact, they don't speak often. So this is unlikely to be in the motor cortex, in the capsule, or in the periventricular white matter. This unfortunate child, we operated over here, so there was some treatment. We operated on her and she started improving, but she's still not walking. But she's now, she was operated at 7 when this thing actually happened at birth. So spinal cord weaknesses, all of you know, when it is a complete spinal cord disorder, you get everything involved: lateral spinal thalamic corticospinal tract, ventral corticospinal tract, the ascending tracts, which is dorsal columns, proprioception, vibration, lateral spinal for pain and temperature. So everything below that. Oh, sorry. I'm going backwards or forward, I'm not sure. Sorry. So this is a patient who had come to us, 16-year-old boy, sudden backache, weakness of the hand and the wrist, transient walking difficulty, but basically it was mainly in the hand. This is Dr. Niru Desai's patient, and touch, pain and temperature were reduced below T2, which is just above the nipple, left more than right. The vibration and position sense were normal. and the reflexes were 3+, but he had normal gait. He didn't have any weakness. I'll just show you the, oh God, this, there it comes.
और हिला पूरा ऐसे ऐसे करके दिखा ऐसे ऐसे ओके
He can't move his
नहीं
hands
हो रहा
at
है
all.
नहीं हो रहा है पैर हिला पैर अच्छे से ये वाला भी पैर
Legs
हिला
are fine.
दोनों उठ के बैठ
Trunk is
ठीक है
fine.
हाथ ऊपर ले दोनों हाथ पूरा जितना ऊपर
Proximally
ले
is
सकता है
not bad at all.
और ऊपर कर धक्का देके ऊपर कर ये वाला जोर लगा के और जोर लगा ये वाला
So the deltoid is normal. So this is what segment? C81. This is what segment? C5. Correct? C5. So obviously he's got significant weakness. We can't move his fingers at all. So the C81 is a low motor neuron lesion. And the mild brisk reflexes and the walking difficulty which he had for a few minutes, for a few days, appears to be because of the corticospinal tract involved. And therefore, this patient had what you call a vascular injury. This is the anterior cord syndrome. So if you look at the cord, this looks like these are the anterior cord and the lesion is in the anterior horn cells at C81. This is exactly what you see in poliomyelitis or non-polio viruses, but you also see it in patients with acute vascular insults of the spinal cord. Now, why do you think it's vascular? It's extremely acute. And most importantly, there was a dissociated sensory loss. So pain, touch, temperature, because the lateral spinal thalamic is anterior, were involved, the posterior column were spared. And he had some sickle cell and elevated homocysteine, etc., to explain this. And this is the anterior cord syndrome. Whatever is colored, this is the anterior horn cells, the spinal thalamic tracts. Your corticospinal tracts may be minimally involved, and the posterior columns. So you get position, vibration preserved, and loss of pain and temperature. And then there are others also. Of course, Brown sequoia, all of you know, is ipsilateral weakness, ipsilateral posterior column, contralateral pain and temperature because it crosses over. And the central cord syndrome, which occurs, is basically more upper limb than lower limb weakness. Why? Because this is the corticospinal tract. The upper limb fibers are more medial, the lower limb fibers are more lateral. So they get caught. And therefore, even the sacral sensations are spared because the sacral sensations are more lateral. And this, of course, occurs in bladders, usually early in patients with this kind of lesion. Few more cases. Tell me if I have to stop. Huh? This is a girl who had acute febrile encephalopathy and then lost sitting, standing, speech. Recognizes parents, however, reaches out for toys, reflexes are brisk. So she's trying to reach out for the toy, but she has great difficulty, almost like she's weak and hypertonic. Okay, I just see, I'll make her sit a little forward. Oh God. We make her sit a little forward and see what happens to her. You just put her like this, there she falls. No postural reflexes at all. Her face is, anybody can tell me what her face looks like? She can't stand, mask-like face, yes. So what do you think this is? Parkinsonism. And after acute febrile encephalopathy, what could it be? Post-encephalitic, correct? So, I hope I get the right one now. Where is the lesion? Bilateral white matter, midbrain, cervical cord, or is it a neuropathy? Where? Why? Yeah, so midbrain is where the substantia nigra is. You can see the substantia nigra in this patient, which is the white. Let me just, I can't get the, you see those white things on both sides, they should be actually dark. Can I just show it to you? Here it is. This is actually normally iron containing, so it's dark. These two are the substantia nigra just behind the corticospinal tract. So this is where dopamine is produced. And this dopamine just produces the substantia nigra, then goes into the basal ganglia, it goes into the anterior frontal lobe, it goes into the pituitary, and has a lot of functions. The most important functions, of course, motor functions. And that's why midbrain is the answer. Now, even in children, you say CP, how does it matter? Well, it does matter if you look at the CPS to train yourselves. If you have dystonic and spastic quadriplegia, no speech, but preserved comprehension, this is what it could be. This is the patient who has central HIE. So damage is mainly in the sub, and you have this basal ganglia being impaired as well as this. Spastic quad, profound MR is this, because the cortex is damaged, you get profound MR. So they both are spastic. This one is a little less of a mental problem. Dystonic quadriparesis, upward gaze palsy, hearing loss, connectress. So when you have dystonia and hearing loss along with globus pallidus lesions, because globus pallidus is very important in basal, in movement disorders. That's why you get movement disorders. Hemiparesis, of course, all of you are familiar with. The only point in hemiparesis, the face is spared in congenital hemiplegia. So you don't get upper motor neuron palsy because the face is fully bilaterally innervated. And in spastic diplegia, because the medial fibers are involved, of the white matter over here, you get spastic diplegia with normal intellect and visual impairment. And this is, of course, usual because there is no motor areas involved, only the visual areas are involved. You get visual impairment and other things without any motor symptoms, neonatal hypoglycemic brain injuries. You see a patient with cerebral palsy, so to speak, you can guess where the pathology is. I think I just, one more case, we have time. So this is the little bit of eye movements I tell you. When we move our eyes to the left or the right, we use our frontal eye fields, which is, oh God, which is this. Okay, so the right, this left frontal eye field will move the eyes to the right, but through the pons. The pons over here, the red area, is also called the prepontine reticular formation. That's the pontine gaze center. So this is the upper motor neuron of the of eye movements. And this is the vertical gaze center, which is mainly in the midbrain to make your eyes move up and down. So look at this patient. He has weakness of the right side.
Make him do this thing.
I'm asking him to look to the left. After this, they'll ask him to look to the left. He can't look to the left. He keeps looking to the right because his eyes are not moving at all to the left. See there, I'm showing his weakness is mainly on the right side. I'll go a little forward. He has a little weakness. Now I'm asking him to move his eyes to the left. He can't do it. So he's got a gaze palsy to the left. Okay. So he's following my movements to the right. He's not following to the left. I'm asking him to converge now. And when he's looking up, the left eyebrow is not going up. See? He's converging fine. Convergence comes from the midbrain center. So there's no problem. There's a mild facial palsy on the left side. Okay. See, the eyebrows are going up very nicely on the right, not on the left. So where is this problem? Here. A pontine lesion where you have crossed hemiparesis. I'm sure all of you remember your MBBS days. But this patient has not only a sixth and seventh, which is clearly there, and a hemiparesis, which is clearly there. He doesn't, why does he have a gaze palsy? So gaze palsy is he cannot move the other eye also. It's not just a nerve palsy. So in these three are the three crossed hemiparesis syndrome in the brainstem. I won't go into that. I'm just going to talk on the pontine lesion. And the patient had a pontine infarct, which explains his left sixth, left seventh, also explains his left gaze center problem and the right side hemiparesis. And the reason is because the PPRF, which is the gaze center, horizontal gaze center, the sixth nerve are almost very close to each other. And this actually passes to the sixth. So you almost never get a sixth alone. You always get sixth and a gaze palsy along with the seventh and the hemiparesis. And convergence is maintained because that comes from the midbrain. And this is just a last one, show you. This is a Niemann-Pick disease. And he has a problem in looking up and down. So when they come look at you, they keep moving their heads. So whenever you see that, you always think of a vertical gaze palsy. Just one question. Most common cause of vertical gaze palsy is what? Most common cause? Anybody? Anybody can tell me? What do you see all the time? Hydrocephalus. Sunset sign is the most common. Okay, I think I'll stop over here. Thank you very much for your attention.
Please be, sir, please be on the dais. Thank you for the wonderful lecture, sir. Now I request Dr. Mahesh Ahirao to felicitate our speaker, Dr. Brijesh Udani. Dr. Shama Kulkarni, please. Ma'am. Now I request Dr. Shama Kulkarni to felicitate our chairperson, Dr. Mahesh Ahirao. Thank you so much, ma'am. Thank you, sir.
Moving ahead to our next lecture, I request Dr. Rajesh Shokhani, Dr. Prakash Vaidya, Dr. Jayant Upadhyay, Dr. Pramod Kulkarni, and Dr. Sudhir Sane to be here on the dais. Common presentations of a rare disease on the one hand, and knowing the rare presentations of a common disease on the other will be trivializing the entire issue. But for the learned panel here today with us and tutor-in-chief of IAP, Dr. Rajesh Shokhani, it's just a piece of cake. So let us have the cake and eat it too. I request Dr. Rajesh Shokhani to take over. Yes, yes.
A very good morning to one and all. Our panel consists of Dr. Prakash Vaidya, who's at Fortis Hospital, Mumbai, who's a very well-known pediatrician with special interest in pediatric pulmonology. Then we have Dr. Pramod Kulkarni, who's from Pune at various hospitals like Dinanath Mangeshkar, etc., and interested in pediatric infectious diseases. Dr. Sudhir Sane has always been Sane Guruji for me right from my residency days and continues to be the Sane Guruji. He is at Jupiter Hospital, Thane. Friends, in this session, I start with our undergraduate days, and you'll all remember our journey. So we used to start with Harrison very ideally, and then as time passed, we came to Golwala. Just before the exams, it was previous year's question papers, and finally Hanuman Chalisa. But then, as soon as we pass out, we are here. So our confidence is very high, and we seem to know just 2-3 causes of almost everything, our undergraduate knowledge, and we have super confidence. As we start seeing more and more patients, we realize, "Arey yaar, aisa bhi hota hai." Then at this point, we are in a state of frustration. So many causes of everything, how to separate out common from rare? That becomes our dilemma. And then this is the rest of our journey of our whole pediatric career. So friends, let's look at 2 or 3 cases today and let's see how we should be thinking. We start with the first case. 9-year-old girl complains of cough for 5 days more at night, past history of reactive airway disease, abdominal pain since last 2 days, which is progressively severe, localized to right hypochondriac and right iliac region, fever of just about 100 for a day, vomited once, non-bilious, no loose stools, and no history of trauma or anything. On examination, temperature normal, heart rate 120, respiration normal, SpO2 98, BP 90/66, peripheral pulse is feeble, CRT 4 seconds, periphery is cold, periorbital puffiness, pallor, and no icterus. So at this stage, let me ask our panelists, what are your initial thoughts? Anyone can take it up.
So this child is having some history suggestive of hyperreactive airway disease. And in patients with hyperreactive airway disease, right now seems to be in a phase of compensated shock. So I have a feeling that pneumonia is not uncommon in these patients. However, the sequence of event is very odd. If it is pneumonia, I would have expected fever and then cough and abdominal pain coming in rapid sequence. So I think that's my thought. Some infective etiology, compensated shock, abdominal pain, and puffiness of the face, you are saying, I really don't know what it is. I need to look more into the clip.
Prakash, the chief complaint is abdominal pain, which overrides the other complaints. So what would be your thoughts on that? And Pramod, you can later tell me that this child is in shock. How do I correlate that to the rest of the picture?
Rajesh, if you don't mind, you have seen this child in shock. Now, this is a child who has had some abdominal pain, but who has come in shock, and there is periorbital puffiness, which might suggest third spacing. So I think dengue is the first thing that I will think of, given this clinical scenario.
Sure. You want to add anything, Pramod?
Looking at the cough, which is there for 5 days, and the other thing is I will keep back of mind, toxic shock syndrome kind of thing. If there is primary bacterial infection somewhere and the secondary shock coming up.
Are there some things that are unusual for dengue? I mean, we all are thinking of dengue, but something that bothers us. Sudhir?
So classically in dengue, the shock comes on 3rd, 4th, 5th day when the fever is, when there is a period of defervescence. So this looks little odd that And if I have to really think that third spacing in dengue rarely comes with puffiness of eyes. Third spacing is more silent. Initially, it starts in pleural and peritoneal cavity. So I would keep that little low because history of fever. If it's, of course, I would ask reliability of the history. If history is reliable, I will keep little low on the curve.
Sure. So I think we make a point that we are surprised that this child has come in shock. We look at third spacing as a strong possibility, but then there's no big background of fever. So all those unusual things, we keep it in mind. Let's go ahead. On systemic examination per abdomen, soft, mild gaseous distension, some guarding and tenderness, marked tenderness over right hypochondriac and right iliac region. Bowel sounds are normal and other systems are normal. So at this stage now, what are we thinking of? Can we differentiate a surgical abdomen from a medical cause of abdominal pain in this child?
I think when you have such a lot of abdominal distension, guarding, severe abdominal pain, and a child who is very sick, then an intra-abdominal catastrophe like say a peritonitis or a perforation is on the cards. So I definitely would keep that as a possibility here.
Yeah, so Prakash, point taken, but my point is that it seems to be a little localized. It's only on the right side. So when it is peritonitis, I would have expected a generalized thing. So what else would you think of?
The other thing that would cross our mind is a pancreatitis, a child who is sick like this. But again, it's too local for that. So just to keep it on the...
In a child who has got past history of cough, again hyperreactive, right-sided pneumonia with pleural effusion, empyema can come like this. And pain can be referred in the right hypochondrium, right iliac fossa also, but having guarding and tenderness there looks little odd.
So, Rajesh, right at the beginning, I think the child was not tachypneic.
Absolutely. I was about to make that point.
Was not
That Sudhir, your thought process
Agreed.
is excellent, but this
Agreed.
child was not tachypneic,
Agreed.
no respiratory distress.
Agreed.
What I would like to say, see, there is abdominal distension, irritation, localized tenderness, guarding. But the bowel sounds are normal. That is not fitting with a bowel pathology. It's around that. And the distribution of right hypochondriac and right iliac, very unusual. There are three possible sources of abdominal pain. One is the bowel cirrhosis, second is the solid organ capsule, and third is the mesentery. As this is localized, it could be a peritoneum which is localized without bowel involvement or a mesentery.
So the point is that at this point, I mean, to me, it looked that, I mean, you look at it as surgical, but then the anatomy was a little funny. It was one half of the abdomen, not the whole half. So the generalized causes seemed less likely. And if you look at anatomical structures, it didn't correspond to the liver. It was on right hypochondrium plus right iliac region. So it looked like whether the intestine is something which is an organ which would be there in these areas. Anyway, the child was resuscitated, perfusion improved, kept NBM, surgeon was obviously called in. Surgeon said to rule out acute pancreatitis or mesenteric ischemia, so advised CT scan. Meanwhile, by the time the USG was mobilized, it was about 6 hours post-admission. And at this time, there is bilateral pleural effusion, mild to moderate ascites. Appendix is filled with fluid and thick edematous bowel loops in right lumbar and right iliac fossa region. So now these fluids in the abdomen, they can sometimes be non-specific and reactive to other pathologies. So now are we a little wiser, or can we, what are your thoughts?
So definitely there is a capillary leak. There is no question about that. Bilateral pleural effusion. And again, there is a localization of the infective disease on the right side of abdomen, which we can very well see on the ultrasound. So definitely it's a toxic shock syndrome kind of.
Sure.
Now I'm looking at a bilateral pleural effusion as well as ascites. So it's a systemic, there is some sort of fluid loss going on a systemic basis. As you said, capillary leak, but here, for some reason, is there any hypoproteinemia? That is one thought that will cross my mind. Why should there be so much fluid accumulation? Or is there a hepatic pathology? But the picture is not really like that. So
we started with dengue. Can this be dengue, Sudhir?
I mean, yes, now with this, one can think whether it is dengue, but the sequence of events is not really correct. So I would like to say whether it is whether it is polyserositis, whether it is transudate or exudate. And one way to do is, as Prakash was saying, to estimate serum albumin, because if it's transudate, then we will get something, or exudate, then do a tapping and see it's moderate pleural effusion and whether we can tap.
Just tell us about the urine output of this child.
So urine output improved after the fluid resuscitation. So meanwhile, because of the suspicion of pancreatitis by the surgeon, amylase lipase was normal, CBC normal, dengue negative, and urine proteins 3+. So that is the first time when, the pieces started falling into place. So we started with puffiness of eyes. We were thinking of a capillary leak kind of a situation. We said it doesn't fit into dengue because the fever was not too high and it was suddenly on day 1. And then it went on to serum albumin low. And finally, it was proved that cholesterol was high, protein creat ratio was no high, and it was a nephrotic syndrome. Why the pain? What was the reason for the pain?
I think now it becomes obvious that it was because of shock. The pain can be a manifestation of hypovolemia. However, the fever is still not explained. I mean, I would just see why the fever came in this child.
So, I mean, the fever was just 100 and just for a day. So we don't know the reason, but yeah. Now, surgeon was still uncomfortable to explain on nephrotic and insisted on CT. So would you agree that we could explain all this on nephrotic and intestinal ischemia, and we have almost ruled out all surgical
Another
causes?
possibility in nephrotic is that they are known to have primary peritonitis. So again, that possibility cannot be excluded, I feel.
Okay. And what about other intra-abdominal catastrophes like renal vein thrombosis, etc.?
Hypercoagulable state, that is also possible. But
So
I
would
think
you
for that,
would you think that is on the card in this child, Sudhir?
I personally don't think so, because hypercoagulable states presenting with renal vein thrombosis I've seen in non-responding nephrotic syndrome. It would be extremely rare. I mean, it might fit the title of this discussion topic, that rare presentation of common disease, but it would be extremely rare to think that a nephrotic syndrome would present with renal vein thrombosis.
Absolutely. So I think this point is very important, that some of the consequences or complications of nephrotic syndrome happen over a period of time once those changes have happened in the body for a certain duration of time, and therefore those complications will not come in as presenting features. Child was started on steroids, settled gradually, and is now doing well. Would you like to talk of any other examples of a nephrotic syndrome presenting differently or unusually? We always talk of a nephrotic as a happy child. Can sometimes it present as a sick child in some situation?
So unusual presentation of nephrotic syndrome, occasionally we have seen patients who have edema-like nephrotic syndrome but don't have proteinuria, obviously, on clinical examination. And when you, routine examination doesn't reveal proteinuria. But beyond that, typically minimum check.
nephritic onset of nephrotic syndrome would not be a happy child, I think. A child who may be sick, who may be having vomiting, headache, maybe, if there is a hypertension.
Sure. So those are few other examples. Fine. We move on to a second case. 13-year-old girl complains of multiple soft tissue swellings in different parts of the body since the last 18 months. Some not painful, some minimally tender. Started with right scapular region, then another swelling on the left elbow, then behind the left elbow, then right distal foot, then left arm medial aspect. Over time, some of these swellings ulcerated and started discharging serous or mucoid material, while some others healed. And of late, this child has now a left knee pain medially while walking and has minimal swelling around that area and left-sided back pain. There is no fever, but there's loss of appetite, and there has been approximately 5 kg weight loss in this period. There is no history of raw milk or contact with animals. History of maternal uncle with pulmonary tuberculosis 4 years back, contact with him for about 8 days. What are your initial thoughts? Anyone?
So when I see a child with such a bizarre picture of multiple soft tissue discharging swellings, ulcers, I think the first thing that will cross my mind is this child immunodeficient in some way? So that would be my initial thoughts, and then we would go ahead from there.
So, I mean, we usually ask for past history of repeated illnesses, which were none. But what kind of immunodeficiency would come for the first time at 13 years? I mean, some can come, but which
Yeah.
ones?
Rajesh, one more thing that occurred to me, doesn't fit the title of your case, is common diseases, is that I have seen a child with absence of pain who would present just like this with multiple discharging ulcers and sinuses all along, and it might have just started later on in life, or something like a dystrophy, neurodystrophy. Maybe we are not talking of leprosy today, but just an out of the box thought.
Absolutely justified, Prakash. We would probably start thinking of all weird things when the presentation is weird.
So I think some generalized process, multiple swellings, and there seems to be some inflammation there. Some of these processes are minimally tender, there is discharge, and there is ulceration. With this, I think, and there is knee joint involvement with limping, I would feel generalized inflammatory process. What it might be, whether it's a auto-inflammatory disease of some kind, which comes with multiple ulcerations, or whether it's infection and then immunocompromised state, as Prakash said, some of the late presenting immunocompromised state like common variable immunodeficiency, something that is happening in this child. We need further investigations and clinical examination. Pramod?
If we
No
were
fever
to,
at all, you're saying, right?
no fever at all. So if we were to, look at the big three, so infections, malignancy, and rheumatological disorders, considering that there is inflammation, as you said, and 5 kg weight loss, how would you rank them as 1, 2, 3 at this stage? Anybody?
So this seems to be typically a thing going on for 1.5 years. So I won't think of any malignancy without making the child serious. I will think of a typical organism infection, which is smoldering, going on, recovering, coming up again at different sites. I won't go with malignancy at all, but because apart from the weight loss, which can happen with any of these three, and I can't see the movements being affected except the latest complaint of limping due to the left thigh lesion. Musculoskeletal, muscular, it seems to be skeletal, it could be, but not joint.
Well, indolent infection too in our country has to be TB, so that crosses, but it's a very unusual presentation, but that fits in with your thing. The other possibility, just absolutely bizarre, is whether there is something like a histiocytosis process going on involving the bones, but they are not really known to have discharging skin sinuses. So, but again, that's...
Sure. On examination, the child looked cachectic and pale. Height was 140, weight was 24.7. Pre-illness weight, there was a record of 30 kg. Right scapula and right foot, there is a healed scar. And left elbow, there is a soft tissue swelling, but the joint movements are normal. These are the scapular scar and the foot scar. And this is the swelling around the elbow. It's not at the joint. The joint is not involved. There is a soft tissue swelling near the elbow. And there is a left knee distal femur swelling, left hip swelling. Joint movements are normal. Lower thoracic spine, there is tenderness. Livers 3 centimeters. RS is clear. Does this add to our information or our thought process?
So I think generalized inflammation is one thing, is for sure. And some of these ulcers are kind of superficial ulcers, not much discharge there.
Which
So
means that the original swelling was not very deep. It was
correct. Chronic indolating ulcers. So generalized disease, chronic indolating ulcers, again, tuberculosis, I think we should think of.
Now, not only have indolent ulcers, you also have involvement of the femur as well as the hip. So I think tuberculosis now becomes a higher possibility.
So ESR 86 tuberculin test positive, and that's the X-ray chest. The pulmonary parenchyma is normal, but obviously there is a paraspinal abscess shadow. So now, how do we go about proving the diagnosis? Pramod?
So with this picture, it seems to be tuberculosis. And the final answer to tuberculosis is the microbiology. Here we will go for, look, we have got localized lesions. We'll get a tissue, subject it to AFB, gene expert, and depending on the results, next. So microbiological control.
Sure. So at this point, Prakash, can you just revise for everyone what is the current way to diagnose tuberculosis in general? Because we are talking of rare and common, and I wouldn't say rare, but it is uncommon to now correctly ask for diagnosis of tuberculosis, meaning I mean that most of us make a lot of mistakes when we are trying to diagnose tuberculosis and send investigations. So,
So
Prakash.
if you pardon me, tuberculin test today is not advised as far as the ICMR guidelines are concerned. They are unequivocally saying don't do tuberculin test. Now, what is the way of diagnosing? Microbiology is the way to go. We have wonderful gene expert and even gene expert ultra, where the specificity and sensitivity are extremely high. So as Pramod said, the first thing we would do is do a discharge from that, send the sample for culture, even if the gene expert is negative, because culture would have MGIT culture would have a higher chance of picking up a organism than that. So these two tests, and of course, histopathology here is accessible, and you look for tuberculomas you look for caseating lesions. So I think here we have absolute access. Microbiology is a must, and multiple samples for microbiology.
Sudhir, whenever we are clinically discussing such cases which span over a year or so, when we talk of tuberculosis and or malignancy, we often use this statement that it has gone on for too long without the child worsening. And many times the child is actually worsened, but we keep saying this sentence that, the child should have worsened. So two questions here. One is, what worsening do we pick up or miss, which is actually happening? And the second is there an explanation how these things can still go on for a long period without coming to light?
So to answer first question, I think what we should look at is the general appearance, appetite, and playfulness of the child. Is it going down gradually? And of course, weight and not increasing in height over a period of time would be another indicator in a particular age. I think these are the things that we should look for. If we look for at grossly, whether the fever is not worsening, whether the symptoms are not worsening, then many times we might be misled. So we should look at this fine thing. What was your second question?
Second question is, how do, for this child, 1.5 year symptoms, how do we explain that it is tuberculosis drug sensitive and this child has pulled on for 1.5 years?
So adolescent tuberculosis can behave. Adolescent is an age which is a relatively immunodeficient state. And that's why we can see hematogenous spread in patients in two age groups, infants and adolescents. Tuberculous meningitis, two age groups, infant and adolescent. So we should keep in mind that adolescent is an immunodeficient phase. Adding to Prakash's algorithm previously, we should also do retroviral test for this. And this is must now in current guidelines.
Sure. Move on to the third case. 7-month-old boy, previously healthy, brought with complaints of fever for 20 days, moderately high, responding to antipyretics with intermittent afebrile periods. Last 2 days, vomiting 3-4 times, decreased oral intake and reduced activity. No history of loose motions or seizures. Some treatment from family physician, details not known. On examination, febrile, lethargic, refusing to feed, marked pallor, AF bulging, erythematous rash on the face, other systems, nothing significant. So what is your thought process at this stage? Pramod?
So basically this is a 20 days fever and intermittent febrile periods, as you have said. So this doesn't look like any infection. This seems to be inflammatory process which is coming up and going on. Vomiting little doesn't matter much. Loose motions and seizures are there, so no intestinal or brain involvement. And on examination, the child is lethargic, refusal to feed. Pallor, AF is bulging, that's okay. AF bulging, definitely significant, a 7-month baby. But the marked pallor is a problem again. So some inflammation going on for a long time, with anemia, with a bulging and rash. May I know when did the rash come up?
Rash was seen in these last 2-3 days.
So it's a recent development, probably latter half of the evolution of disease.
Well, I beg to differ a little, Pramod. So I wouldn't say this is not an infection because one, even if it is fever off and on, I mean, tuberculosis is classically fever off and on. So that is one possibility. Secondary, for inflammatory diseases, for the first 20 days, nothing is happening is a bit unusual for me. And even in 20 days of inflammation, this is a previously healthy child. So in 20 days of inflammation, this child couldn't have become seriously pale, I thought. So that was also a bit of a thing which didn't fit in.
Rajesh, regarding afebrile periods, when you're saying you're giving antibiotics on the one hand, then how do those afebrile periods really matter?
Absolutely. And secondly, there was some treatment from family physician. We don't know whether it was antibiotics or what, we don't know. So that becomes quite complex. So no infection is not a
TBM is definitely is a possibility here.
TBM.
With a bulging fontanelle, 20 days of fever, intermittent, child not doing well.
Okay, so one
I would like to keep it in mind as well.
One thought process is that a infection which started as fever for whatever 20 days and is now getting localized to the brain, so or to the CNS. So one possibility is TBM. Sudhir, any more comments, any additions?
I mean, such complex cases often come in our practice, and we need to know, we try to kind of club them into a single cause, but pallor might be something else. It might be related
Absolutely.
to feeding, and we should take this into account. That try not to link everything, try to think that whether it is fever, late onset bulging fontanelle, some bacterial meningitis, and pallor can be of some other origin. I think that might make more probable, because 7 months old is a classical age where pallor can present, especially if the child was born with a low birth weight.
Pallor could have been pre-existing iron deficiency anemia.
Right. Sudhir, we've learned from Udani sir many times that a meningitis which is treated very early with oral antibiotics can sometimes land up with intracranial abscesses. Do you think that's a possibility in this child?
I think lethargy, refusal to feed. We have not mentioned anything about any localization here, but yes, I think we should keep that in our mind. Some localizing intracranial disease like meningitis, subdural abscesses, and brain abscesses.
Sudhir, what is your comment on inflammatory disorders in this child? How do you explain that rash, and what are your thoughts about that rash?
I think inflammatory disorders should be kept in mind, especially we have had just recovering from large COVID epidemic and pandemic. And if this child would have come during that time, I would have thought whether it was some kind of post-COVID inflammatory disorders. This child had fever 20 days back, and now he is having fever again, 2 separate episodes of fever. That fever could have been COVID, and this is post-COVID complications. We start exactly after 15 days. And I would keep then inflammatory disorders if these 2 fevers are not of a similar kind.
Okay. So I think here the history, if we can get and the parents can give properly, is very important, because if we can establish a clear gap between the two, then we can call first as the primary illness and second as a complication of the illness.
So how was this child interfebrile? Was he active or very, very irritable all the time?
In the beginning, active. It is just that in the last 3 days, this child has become lethargic, refusing to feed, vomiting, etc. So to our what we gathered so far is that this is a febrile disease, possibly infectious only, which has localized to the CNS after a lag, after 20 days. And at the back of our mind, as Sudhir said, we keep one primary disease and a second recent disease as a complication of the primary disease. Hemoglobin 5.7, WBC 53,000, platelets 9.6 lakhs, CRP-ESR high, NT-proBNP high, IL-6 high, 2D echo dilated coronaries with a Z score which is high for 2 of the 3 vessels, and CSF protein 94, sugar 5, cells 9,600, 90% polys. How do we interpret this? Pramod?
Obviously, it is clear this is MISC, number one. Inflammation is very much there with dilated coronary. I will like to know about the antibody, COVID antibody in this case to confirm it. And CSF with little raised proteins, low sugar and neutrophilic phagocytosis. Definitely there is a pyogenic component because the systemic inflammation won't go. It typically comes as a sterile aseptic meningitis. This seems to be a septic.
Yeah, so then how can we say this is MISC? This is bacterial meningitis.
Coronary dilatation, I know in these days with all the inflammatory features, I will keep MISC as the association and I will look at that CSF changes. It is giving me some other.
So we're talking of two illnesses.
Yeah. Yes.
Or we are talking of a pyogenic illness driving an MISC. The only thing MISC doesn't explain is such a dramatically low sugar. I mean, that is for sure.
Yeah, I thought that 5 sugar is like a stamp or to call it bacterial meningitis. So, Sudhir?
Yeah, I think pyogenic meningitis is without doubt it is there. Occasionally, we have seen Kawasaki disease presenting after with associated with pyogenic illnesses. Like we have seen liver abscess with Kawasaki with dilated Z. And there have been, so we take Kawasaki, dilated coronaries as a diagnostic test for Kawasaki. It may not be. Dilated coronaries might have other explanations. And of course, the host association with pyogenic infections are known. So I would think whether it is a pyogenic infection with dilated coronaries and Kawasaki disease. MIC, I should keep it in.
Two questions. Is TBM ruled out? And why, if it is bacterial meningitis, why did it happen after 20 days?
So I think Dr. Brajesh is here, but no, he is not here. But we although we are classically, we know that pyogenic meningitis occurs as an acute clinical case. In fact, many a times there is an indolent fever 5 to 7 days back before, if you take a detailed history, and these patients are treated. And H influenza B meningitis is classical like that patients have some past history of treatment, some low-grade fever which is going on, because the bacteria cause initially upper respiratory illness, then can go migrate to the meningitis. I think that might be the next.
If you're really looking at a MISC or a KD-like picture, there is a lot of literature coming on today, especially from Asian countries also, where there are some drivers for this inflammation, like viruses and including non-typhi salmonella. So just a thought process, whether you're looking at a combined problem because of both. The other thing is that we are actually associating coronary dilatation only with KD. We actually do not look at coronaries in any other disease. So how do we really know that that this is not happening in across the board so many diseases? We are just doing it in a particular scenario. That's it.
Okay. So I think we are now all realizing that all the inflammatory markers could be seen in various situations, and we are saying that there is just an inflammatory state. Probably over time, we'll get more knowledge about the coronary dilatation as well. This child was initially treated with ceftriaxone, IVIG, steroids, aspirin, and PRBC transfusion, and blood culture and CSF culture grew Salmonella typhi. Steroids were stopped, fever responded in 72 hours, baby recovered completely. Sudhir, bacterial meningitis would have responded anyway to ceftriaxone. So what is the importance of knowing that it was Salmonella typhi?
I think, first of all, reading literature about Salmonella typhi meningitis, way back, 30 years back, we had Salmonella meningitis epidemic. And Salmonella, not typhi, non-typhoid Salmonella, have a kind of meningitic kind of manifestation. And they need really long-term treatment. Some of these patients need treatment for even 1 month, even after the culture and CSF culture is clear. So when we get such unusual organism, I think proving that CSF is now culture free of the bacteria and continue antibiotics beyond that is what actually matters when we want to know the diagnosis.
But my question is this Salmonella type, because we have read about non-typhoid Salmonella being responsible for this kind of manifestation. I have not come across
Yeah, so
Salmonella typhi. I
Prakash,
may be
you are
wrong.
right
I may be
that
wrong.
neurological manifestations in typhoid are mentioned in both non-salmonella as well as in salmonella, albeit very uncommon. So, I mean, here Amdekar sir often teaches us that if I was the treating doctor before the last 3 days, so if I was the treating doctor at 17th day or 16th day of this baby's illness, when it was just fever and nothing else by then, what would I have thought of? So that time I would have possibly thought of an infection only, an infection which is non-localizing, and in a non-localizing infection, tuberculosis, and in an older child, typhoid does stand out. At 7 months, I would have been hesitant to think of typhoid, and even without hepatosplenomegaly. So this is just retrospective thinking whether we could have thought of this earlier. Have you seen any other uncommon manifestations of typhoid?
Just
if
for
you
the
want to
record,
share?
I would have sent gene expert as well as MGIT culture of that CSF in any
Absolutely.
case.
Any other uncommon manifestations of typhoid?
A septic meningitis as a complication of typhoid fever. That was paratyphi A in a young child, that infant, 12 to 13 months, I have seen.
Sure. So friends, in these last 3 cases, we were again reminded of Sir William Osler's quote, which said, medicine is a science of uncertainty and an art of probability. But as we said in that curve in the second slide, we always have this dilemma. We have so many causes for so many things. How do I learn the balancing act of rare versus common? So I want the panelists to tell me, how do I balance aimless aggression with dogmatic conservatism? And all of you or any of you?
I think we are accustomed to asking for too many tests. We should all question ourselves, what is the pre-test probability of getting what I want before I really order a test? I think that will help in curbing the aggressive investigations at least.
Sudhir?
I think in clinical medicine, we learned that, especially as a general practitioner, I learned that diagnosis often evolve over a period of time. And sometimes we are in hurry to give diagnostic label to the child. So waiting and allowing, not in such a serious ill child, but for the patient to the symptoms to evolve sometimes plays much better. Another thing that in in patients with, say, I think that's all I wanted.
Pramod, you want to add anything?
Basically, again, good history taking, giving time to your patients is number one. But I will say a personal urge to hunt the final diagnosis. If it is there, then the process of diagnosis goes very well.
So friends, what did we relearn? Diseases usually have common presenting features, and they all have a list of manifestations that can occur. When the can occur manifestations come first, we start thinking differently. Let's try to explain whatever doesn't fit. The key may lie there. We must ask ourselves, is this a distraction or is this the real issue? And let's all remember that common diseases will present commonly. Common diseases will then present uncommonly occasionally, and very occasionally rare diseases will present. So with this kind of experience that we gather over our years of practice, we talk of horses, mules, and zebras. So horses are the things which we diagnose every day, mules uncommonly, and zebras rarely. Probably we will learn to identify horses every day, and the painted horses which come as zebras also once in a while. And then we won't be surprised if we see this kind of a notice on the road, ki saavdhan, aage sadak hai, because potholes are very common. Thank you very much. In addition to the excellent discussion, Dr. Sudhir Sane and Dr. Pramod Kulkarni also contributed a case each in this session. Thank you very much.
Thank you so much, sir, for such eye-opening session. I ask Dr. Pramod Kulkarni sir to facilitate Rajesh sir. Dr. Anand Makharia sir to facilitate all our moderators.
Good afternoon, everyone. Now let's proceed for Honorable PM Udani sir's oration. May I request the speaker, Dr. Satish Dev Pujari sir, to please please come up on stage. And the topic for today's oration is getting off the beaten track.
I request Dr. Hemant Gangolia, President MAHAPEDICON, and Dr. Amol Pawar, Honorary Secretary General MAHAPEDICON, to come on the dais.
Good morning, everyone. Now, we'll start our most awaited, prestigious Dr. PM Udani oration. I request respected President Dr. Hemant Gangolia sir to tell about Dr. PM Udani oration. Thank you.
Hello, audiovisual, please share this PPT. Good morning, each and everyone. Rather, we, each and everyone feels proud to be associated with this prestigious oration, and I feel myself very fortunate to share the dais with such big stalwarts and get associated with Dr. PM Udani orations. So it's the days, all these years, we went on learning from these stalwarts, Dr. Satish Dev Pujari sir, as well as VC. I acknowledge the presence of Dr. Rajesh Udani as well as Madam Sunu Udani. So we proceed with this presentation. Sir was an astute clinician. On many occasions, he would be able to spot a clinical diagnosis which had baffled many clinicians. Dr. Udani was always invited at many centers in India and abroad, and it used to be a feast of clinical rounds on his joining back, as he would unveil hidden physical findings that were missed by other faculty members. His wards rounds would go for several hours and used to be attended by many postgraduate students from other institutions. He was a born teacher of a kind that is rare. Dr. Udani sir was a voracious reader. He was always surrounded by books and journals in his office, and his personal library at home had just enough room for him to sit in between the loads of reference material spread all over. At every scientific meeting and conference, he would attend every lectures and make the notes. His personal books had equal number of words scribbled by him on every vacant space on the page, as many as those printed. He was a prolific researcher and had several original contributions which have been often quoted internationally. Especially his work on tuberculous meningitis has been a pioneering effort of many years of clinical and neuropathological correlation. Enthusiasm and devotion to science was a stronghold that would be impossible to match. He was a work alcoholic and continued to put in 14 to 16 hours of active work every day. He was a full-time professor with very busy private practice. As a full-time professor, he was required to work for 8 hours. But Dr. Udani sir never left the department till late in the evening, only to reach his private office at odd hours and still attended to large number of patients who would throng his private office coming from far and wide. He seemed never to get tired of work. He always said jokingly that he was not a full-time professor but a whole-timer. I am sure every cell in his body survived on science, and he breathed pediatrics till the end. While he was a taskmaster, he was very loving to his students and always stood for them. His colleagues recall social evening in his house every year, where one could see different colors and hues of the person as he played harmonium and made everyone at ease. As a typical scientist, he lived in scientific mess, oblivious of the surroundings, and one could read a caption in his drawing room that said, "If you feel my house is untidy, this is the best shape at present. Sometimes the imperfections look much more brighter." Neuroscientists felicitated with the Dr. R.D. Birla Award. The ceremony for the giving of Birla Award has been a prominent function at Bombay Hospital, and this picture shows two awardees, Dr. Bala Subramaniam, neurosurgeon, and Dr. P.M. Udani, sir, pediatrician, along with Dr. Dolokia, Dr. B.S. Singhal. So this is a photograph of that. And we pay our humble tribute to a man who was an extraordinary person, as he excelled as a scientist, clinician, teacher, medical practitioner, above all, an excellent and good human being. Thank you very much.
Tape.
लैपटॉप दे देना कल।
Now, uh, now I will introduce Dr. Satish Devpujari, sir. Sir's topic is getting off the beaten track. Sir is a professor emeritus, Government Medical College, Nagpur, IGMC. Then sir is adjunct professor in mechanical engineering at VNIT Nagpur. Sir is chairman academics at Nelson Hospital, Nagpur. Then sir is founder chairperson at national level of pediatric intensive care chapter from 1998 to 2000. And sir is president of Society of Pediatric Cardiac Critical Care, Chandigarh. Now I invite sir to start delivering his oration. Thank you. Yes.
At the outset, am I audible to you? At the outset, I'm humbled to be delivering this oration. And in fact, I was just thinking whether I'm worth all this. But all the same, I'll make some efforts. And to speak on an oration for a person like Dr. Udani, it is quite a pressure on the person who presents it. So in fact, we have heard so much about him. We've seen so much of his articles on neurotuberculosis, vascular involvement, and things like this, and also heard his interest in academics. So even when he was not well, for about last few months, I was told every day he would be reading and making notes of what is new in pediatrics. So much to learn from him. And as I've said, I'm humbled to be speaking for this oration. I thank Maharashtra IIP, Dr. Hemant Gangulia, Dr. Amol Pawar, Nashik IIP, Dr. Ramakant Patil, Dr. Milind Bhardia, and Dr. Sharmila Kulkarni, and my close friend in Nashik, Dr. Kasliwal, and Sanjay, who is my associate in my OPD practice. Now, the topic I chose was getting off the beaten track. So when I started as a pediatrician somewhere around 1981, I was thinking, what next? Like I started the practice of pediatrics. One thing I did was I never practiced alone. So someone who would be MD pediatrics would be sitting in and with me for whatever I did right from day one. It did help me on some of these areas of learning and trying to be in touch with pediatrics. So the question was, after having practiced for some years and going through the usual turmoil and the problems of a budding pediatrician, what next was an issue? Then I realized that, good that I'm going to practice pediatrics. I was blessed to be taught by some of the very good teachers. But I asked a question to myself as to how I could be different. And one thing which kept on coming to my mind was that I have one strong point, and that is technology and mathematics. And I was a physician by accident. So every time that change of mind kept on coming to me, should I get into technology full time? Should I continue pediatrics? But I loved pediatrics. I was loved by my friends in Nagpur. And in a way, I was a blue-eyed boy of Nagpur for varieties of reasons, and I consider myself blessed on that ground. So I thought, how do I use this strong point of mine? And at some point, I realized, as someone in a country like India, though I had a US citizenship at some point, I decided not to go to that country and be in our country and try and match the technology, what the world has. The challenge is reaching technology where it matters most is an art, and that too in time. Time is extremely important, and that we saw during COVID times. So I bought one of the first computers in Nagpur and started learning software, and then started doing some small little things with hardware and realized we are not students of some subject matter, but we are students of problem. So if there's a problem, I need to solve this. This could be software, this could be hardware, this could be metallurgy, this could be embedded technology, or whatever. The question is, I need to solve the problem and try and learn if it comes to learning software, if it comes to learning hardware. And I was extremely blessed and thankful to varieties of people in and outside the country who helped me in every possible way to try and see as to how we could do this. So as I said, we are not students of some subject matter. We have to cross the boundaries of that and define the problem statement. Now this is typical language and technology. They would say, Satish, tell me what is the problem statement that you're facing with? And how do we then go around solving that problem? Now, some of these areas which I've worked, I developed some apps, and there was interesting steps like planning, trying to develop a perfect algorithm, trying to develop a structure, and trying to see the app is user-friendly, and to begin with this project. Then develop some simulators, develop a sensor, which was my unique project with Bits Pilani, and some indigenized products. And lately we developed the Lung Museum, which is one of its kind in the country and almost globally. And then how would I pay back to whatever society has helped me in getting to society? But all that, one thing which was my weak point was teaching. I would not leave a single chance to teach anywhere. So when I started my practice, I was not one of the very social persons. Even now, I'm not very social. So people told me, why don't you join Rotary or a JC and things like this so that your name goes? But that was not my cup of tea. Literally, at some point, I would teach biochemistry, microbiology, even humanities and 10th standard students. But whenever there was a point to teach, I would teach, and that would be no financial burden on the institute or no post that I would ask for. And this really helped me. So in AIMS Nagpur and varieties of institutes in the city, I taught physiology almost from day one of my practice. And every time a lot of people laughed at me, Satish, kya physiology mein time waste kar raha hai? They sometimes mocked at me, yaar, pediatrics mein dhyan dein. But I loved physiology, and even now I teach physiology as hobby. Then taught in Jabalpur Medical College. I would go about 6-8 hours there on my own cost, almost once a month. And for about 15-20 years, I would go and teach the postgraduates. And the strength and the knowledge that I got from young students, I owe a lot that I learned from them to what I am today. Physiology was always my strong point, so taught physiology every 2 lectures. And again, as I've said, every interaction made me strong. So another thing that I enjoyed was teaching in the corporation school. What wonderful students they were. And every such lecture energized me. I still go to this school and teach the students. Now let's come back to what a little contribution I made. So apps were one of the important things. At some point I realized that smartphones are indeed very smart, and we need to go at them and learn from them. Every time, but when I started this, It was always this कि सतीश ये apps पे कुछ नहीं होने वाला है. चलिए तुम इतना time spend कर रहा है and you're spending some money, but I wonder whether this would be really used. But one thing which I'm made of, which comes to me from my father, who was an ardent army man, that there's no question. If you feel this is good, do it. And I'm happy that we could do that. So today, I possibly have the largest number of apps anywhere in the world by any physician. And about more than 2 lakhs apps are used across the world. There are about 380 countries in the world which use smartphone apps, and 378 countries have touched the apps at some or the other time. I was very happy when I met some Japanese friends, when they told me, Satish, we are using your ABG app. I felt happy and proud of this software industry which helped me. And believe me, they were ready, absolutely ready. So some of the Indian software industries, one very large RG Blossom American Industries, and one of the European industry helped me without asking anything. In fact, they were looking for a physician who would take me into that track. So of these apps go on from environment to mitochondria. So ROX score, which was an adult score for HFNC, was the last app we developed. This was used again most places. And every of this app is fully transparent. So what decision you are getting from the ABG app, what algorithm is the background strategy working is shown there. And this is the only app in the world which is disease specific. You'll have app metabolic acidosis, metabolic alkalosis, but nobody would say RTA type 4 or laxative abuse. So our app is one of those which would, one, confirm your ABG report is correct or not, would give you a disease specific diagnosis, and the graphics that we have, I'm very proud to say nobody has copied it for last 7 years. It's a fantastic software, and Persistence Systems helped me, RG Blossoms helped me. RG Blossoms, an American company which helped me in developing world's first app on iWatch, which still continues to be the only point of care app. And this was in Johns Hopkins, where we had first demonstrated the app about 6 years back. Now, one thing I learned of this is we all have to learn Microsoft Excel. I would have never developed this without learning Microsoft Excel. And I feel as young students entering in medicine, this is something, if we have to do something beyond what is shown to us, we need to know mathematics. I must thank Dr. Vivek Shivare. This boy is in Nagpur. I mean, the kind of Excel graphics that he develops is amazing. So then we started working on Excel, transferring Excel into software for the smartphones. As you can see here, the dynamics of Excel graphics is shown. You'll see the red pointer moving, and then the same getting transferred on a smartphone. This is about 80 years old medical mathematics, which was made playable. You know what, when I was in second MBBS, Satish, ABG छोड़ दो, कोई इसमें पूछने वाला नहीं है और कोई मतलब नहीं है. That time I realized that whatever it is, I would be the world's last man in ABG. Believe me, I said, no, there's nothing that I cannot learn. And that was my definite pointer. I said, no, I need to know ABG. And believe it's nothing big, it's nothing rocket science. We have always create a phobia. It was a class example of academic terrorism. No, don't touch that. And I'm happy that I made it playable. You play and learn was the pointer. Now this was converted to hardware. So you see this hardware, I must thank our intensive care group. Sonu is here and we grow so well, understanding each other. And we had India's first workshop on simulation in one of national conferences in Mahabedicon. So we created India's first simulator ventilator. And all was in Nagpur. So Dr. Zimmerman, in fact, Satish, I can't believe that you could create this. It was not a very high-end simulator, but all the same, at that moment, it was relevant and we could convey some simple principles of mechanical ventilation. Now, these apps are now a part of one of the most read book on universal ventilation by Edward. And they are, I was told, are being used extensively by the readers who use these books. As everybody, a lot of people would look into their phones कि आज ये इसका share कैसा चल रहा है, Raymond's का share कैसा चल रहा है. Just every day I would spend time कि मेरा app कहाँ चल रहा है. So about few months back, China, US, and in fact about 80% users are not Indians. USA and Japan are the largest users of these apps. So some of the extremely so-called complex equations were made playable by creating apps. Like this alveolar gas tutor simplifies alveolar gas equation, simplifies the variables involved, gives you the occasion to play and see how the two variables would interact with each other. And I wrote an article in our ISCCM book on hardcore mathematics on alveolar gas equation. One equation runs over 3 pages. In fact, the editor was not ready to, Satish, no, ये medical नहीं है यार, ये नहीं डाल तो इसमें, कुछ तो भी engineering काम है. But medicine is a lot of mathematics. What little thing I did was to make the mathematics playable. Next month, our app on DK would be available, and we'll have some assistance from European experts in doing that. So this is the app on iWatch. This is the only, if you go on an iWatch and see the apps, you'll be surprised. The most complex app on iWatch is calculated menstrual period. उसके ऊपर वो गए नहीं है. आज 15 अगस्त को आपके पीरियड तो कब आने वाला है? Okay, no medical brain has gone into things like iWatch. This could be the most complex app on iWatch, and which honestly, very honest, is nothing, is peanuts. So all of us have tremendous potential. And brilliant people, like one of our partners in Pune, Rashmi is sitting here, her brother Tejas, like name, this fellow would have about 50 patents in US, brilliant characters. Unfortunately, we don't open up to them, but they would definitely help us in getting things. Then I developed some simulators, and please don't misunderstand कि मैं I बोल रहा हूँ कि मेरे बारे में ऐसा नहीं है. I want this psych to get into all of us. So when I'm saying I believe so many of friends, colleagues have helped me. So this I is a misnomer. So we made simulators. They simulate lung functions. They simulate ODC. They simulate some aspects of ventilation. They simulate some of ABG. And these have been donated to some of the good institutes. And all this, I never had a single paisa grant or asked for any of them. But my friends have always been there. I mean, there are friends who gave a blank check. Satish, a blank check hai? Whatever you want to do. And I'm very humbled to say they have always, and they don't want to be named. So we have developed these apps, these simulators, which are India's first such effort. And mind you, they're not the complete solution to the problem, but they are a beginning of the path to solving an issue. One of my first research was with Beats Pilani. So we developed world's first sensor at the tip of the endotracheal tube. And I was fortunate to be presenting this in ASME, which is the world's largest conference of mechanical engineers. Every engineer would be proud to present this. And so I was the only physician that time presenting about 6 years back this research of ours. Again, a lot of thanks to Beats Pilani for having invested in this project, which is a nano sensor, barely visible to the naked eye, and it will be sitting at the tip of the ET tube. Short of some grants, it would be a reality soon. So there are certain mathematical areas as to if the thickness of the sensor, how would it respond to the stimuli and things like this. So this, in fact, was one of my first intro to kind of hardcore engineering. And today I really enjoy. I'm happy VNIT Nagpur is like IIT Bombay. I have a small little office. I spend about 2 hours there. वो 2 घंटे में ही है कि I have about 10 cups of tea. Because engineers means nothing will work without a cup of tea. Okay, वो थोड़ी आदत लगी है. So, but seriously, I kind of enjoy that. So, this was appreciated a lot at then presentation of mine in Texas Engineering College, 2 of them in fact. Then on, we went on to make devices. And this was inaugurated about when the COVID came in. I said, हम चांद पे जा सकते, ऐसा कौन सा चीज यार हम नहीं बना सकते. So those 2 years were one of my best years. Abhay is there. 24/7 रोज कुछ ना कुछ होना है. फर्स्ट थिंग है 10 पुराने वेंटर्स लेके आए, पूरा तोड़े, पूरा फोड़े, अंदर की एक एक चीज क्या है, कैसे ब्लेंडर काम करता है. It was fantastic. And then so Devi Shetty
eventually the heart can fail.
audio.
Now for this we need left ventricular assist device. We believe the number of LVAD implantation will far exceed the pacemaker implantation.
Audio.
But with this kind of a price tag, how many Indians can afford? If Dr. Dev Pujari and his team can come up with these devices, we are very happy to work with them to evaluate, give the suggestions, give the feedback, and support them in whatever way is required, so that we can develop the Indian-made artificial heart.
So we made India's first oxygen helmet. This was my project with IIT Bombay, funded by Thermax. You see, a lot of people try and make a helmet or hood, but nobody studies how the gases flow inside. You know, it could really happen that you have a hood, you're giving 5 liters of oxygen through that hood on an X point. In fact, we have a paper with VNIT where an abnormally placed inflow can actually suck air from the oropharynx. So it looks clear and easy. Oxygen, क्या है, hood लगा है, यहाँ oxygen दे दिए, air oxygen mix कर दिए, but that is not what is expected. And sometimes a lot of interesting things could happen this way. So this was a project funded by Thermax and with IIT Bombay. I did a lot of interesting things with IIT. Also, I tell you, of the 100 things I do, only 20 might see the world. 80 would fail. They do fail. It's only when you work, you fail. And I'm happy to say I've failed more often than succeeded. So what I'm just showing you is just an iceberg of what a success is. I've failed many more times in trying to do this, but that only made things happen. So we made India's first ICU NIV ventilator. And let me tell you, I put my engineering team to their back to their walls. ऐसे नहीं तो होना ही है, ऐसा ही करना है, there is no question. And graphics मेरे को ऐसा होना है, and they were very, very happy. The graphics that you this seen in IV, I mean, I don't want to use words like challenge, but I can tell you, you'll not see such graphics, you'll not see triggers in any NIV machine. And this is the only NIV which has all the modes of NIV in one machine, which is humidifier as a part of machine. Now, why the humidifier part? Because the microprocessor that you need for humidifier is now shared with the machine. So you reduce the cost. This is a kind of machine where without an oxygen sensor, we are able to achieve FiO2 by streaming the two oxygen air inputs through the solenoid valves to get an FiO2. So a lot of things technologically which went into making this. Now, at this moment, I said, every time we are blindfolded. मेरे पास एक वेंटिलेटर है, अंदर क्या चल रहा है मालूम नहीं. Engineers को यदि मेरे को सिखाना है, I want them to see inside working model. And this is where the brief period when I was in the US and I had a bit of citizenship there, which I declared, I saw every US state would have more than 10 museums. And museum is a class example of self-learning process. And I said, let's make everything transfer. Let's make a ventilator transfer. So when I told my colleague, yaar ye ventilator transfer karo, pura transparent karo. Right word sometimes people use a skeleton karo or naked karo. They said, क्या बात कर सकते हैं, ऐसा थोड़ी होता है कि इसको आप ट्रांसपेरेंट कर दे, इतने गैसेस फ्लो होते हैं उसमें से, इतना प्रेशर अंदर है. मेरे नहीं, वो तो होना है बस जो भी है. अब इसका करेंगे, एक मशीन बनाने के 6 लाख रखेंगे, लेने वाला कौन है? मैं जो भी यार कुछ नहीं, वो करना है. And they made this machine transparent. And believe me, this is the world's first transparent machine. And you know what? जैसे अपना किचन, ओपन किचन करना है, तो आसान नहीं है ना. It has to be good, it has to be clean, it has to be streamlined, it has to be properly functioning. And I'm proud I have a look at this machine. Anyone will not believe that India में बना है. So we have this strength and the capability, but sometimes we lack the trust in our own people. And I think it's time that we need to start building that. When I presented this in ICCM National Conference, there were stalls of multinationals. Everyone said, "Worry, Satish, transfer machine." Has ever Siemens tried to make transfer machine? But they're afraid कि अंदर क्या दिख जाएगा, कोई चोरी कर लेगा. I tell my group, या देख करेंगे, नहीं हुआ ना, we'll open the code to entire world. Doesn't matter. Let everyone copy our whatever we have done. We are not here to just make money. And we have been fooled for years together. जिस मशीन के लिए हम 16, 18, 20 लाख स्पेंड कर रहे हैं, वो मशीन 3 लाख का भी नहीं है. And for years we never ask questions. चाइनीज से कोई थर्ड रेट मशीन अपने आए इंडिया में, किसी ने ये नहीं सोचा कि इसको कोई सवाल पूछे. तो ऐसे देख, यदि हम इंडिया में बनाए, लोग तो पूछने वाले. ऐसे मेक इंडिया फर्स्ट कैलिब्रेटिंग डिवाइस. देयर वाज नो सच डिवाइस. हम लोग मशीन यूज करते, कभी सोचते कि 200 ml दिखा, 200 डिलीवर कर रहा है कि नहीं, बिकॉज हम बिलीव करते 200 ml है तो पक्का डिलीवर हो रहा होगा. So we made India's first calibrating device, which calibrates the ventilator. Then was the time to go ahead further. So this is an extremely small little cute device. This could be the smallest ventilator that is available. And again, these are all working machines. This small little machine, I forgot to get it there, is this small. And it's not just a ventilator. It is a lung function test. It has a device for sleep apnea syndrome. It is on Wi-Fi. It can be on battery. And it has on my own mode called pranayama mode. So this will be just a small little machine. It's a part of a lung museum now. But I will try and make it available. Our industry team will try and make it available to market at a very low cost for sleep apnea syndromes. All this is possible. And not because of me standing here, because of the technology and the kind of people we have in our country. It's a beautiful transparent machine. Then, as it's time, if the world is talking of augmented reality, why not we?
By Satish Metanova. You are witnessing how the state-of-the-art infrastructure of this medical device has been designed to perform and deliver efficient respiratory support. The device runs with two parallel fluid circuits of air and oxygen, which mixes in the Y junction. Both circuits are equipped with respective flow sensors and a safety valve, ensuring the pressure is in the safety band. Transitu's ventilatory support comes with an internally packaged source of air supply in the form of blower, which can be tuned to cater precise control for critical respiratory therapies. Whereas for oxygen, it's taken care by pressure regulator and proportional solenoid valve. Thus, Prancetu fuels the Made in India motive and offers a complete, reliant and cost-effective solution in respiratory support for the human race.
Now, have you ever seen an AR video of any of the multinational machines? Because everybody is afraid. And common is going to ask me, Satish, patent kiya? And I have never patented any of those things. I said, let them copy. And we want to make it transparent. We want the world to know what goes inside. And we have the capability and strength to go on further. So then again, heart in heart, I always felt, we need to develop in India, in Nagpur. That small little machine, Prancetu Mini, is totally developed in Nagpur. Imagine the potential that we have in our country. So itne chote cheez mein bhi ho sakta hai, it is possible. So as a Making Lung Museum is a museum for MBBS students, is a museum for lay public, is a museum for engineers, is museum for people who want to know what goes inside human and man interface. So we created 100 years of moving, playable history of respiratory support. So so-called frightening equations, frightening algorithms are now visible to your eyes. And a lot of these things are very well presented. I must say I'm happy that our mega group supported me on this project of more than about 60 plus lakhs in making this museum world class. And it really is world class. Come and have a look. So we have the 4 dynamic videos on this. And what's the cost of this video? You'll be shocked. 1.5 second of video cost about 8 lakhs of rupees. Again, these technologies are not that costly. I'm sure someday we'll be able to teach medical science by looking at every organ by not from 5 sides. It could be 6 sides. That would be the side of our country. So this is the museum, a small little video of how it looks. This is a COVID ball. So the celebrities were occasion to see this. And this is negative pressure ventilator. Working machine with a higher technology. About 100 years back, these ventilators didn't have the sensors, didn't have the graphics. So we made it this way. And now my idea is to work on cruisers. And I believe someday cruisers would be a fairly applicable device at some point. So this is the transparent machine getting attached to our calibrating device. Now look at this. One machine is showing you medicine. You have a patient connected. That you see here got an international award for an AMBU bag ventilator. See the engineering that has gone into it. Fantastic engineering has gone into making this. When the COVID started, this machine got a fairly good international award. It is an operable AMBU bag machine. And this is the mini vent. And as I've said, I must thank the Mega Group for having supported that. Then these are certain of the things that I always felt obliged to give something to the society. As I've said, that way I was an extremely loved boy in Nagpur. For whatever little I did, people have always been helping me in every possible. So this was the Nagpur's first stage performance by our trust on drugs. Darkness to Dawn. It was very interesting. Then this is an interesting project I did starting from this is the Darkness to Dawn. It was a drama created by young students.
चैरिटेबल ट्रस्ट ने ये कौन सी विडंबना है? स्वस्थ बच्चे राष्ट्र की संपत्ति है, ऐसा केवल दीवारों पर लिखा जाता है। इन संदेशों को अमल में लाने का बीड़ा उठाया है आर्य चैरिटेबल ट्रस्ट ने। शुरुआत में दातेवाड़ी नामक गांव चुना गया। इसके लिए आवश्यक व्यायाम और अनुशासन को इन्होंने जाना। संवाद और गीत संगीत के माध्यम से लोक कला का उपयोग कर प्रस्तुत नाटक ने बच्चों के माता पिता, अभिभावक और गांव के बड़े बुजुर्गों को स्वास्थ्य के बारे में बहुत कुछ जानकारी दी।
अहो जुलाब किंवा उलट्यांनी आपल्या शरीरातील पाणी कमी होतं, मग त्यानं काय होतं, जीवाला धोका संभवतो. म्हणून घरगुती सोपा बिना खर्चाचा जीवन रक्षक घोळ जर आपण आजारी माणसाला दिला तर त्यानं काय होतं, आजारी माणसाच्या रक्तातील साखर कमी होत नाही.
मीठ साखर पाणी यांचा घोळ करू बाई घोळ करू, घोळ करू घोळ करू जीवन रक्षक घोळ.
So the challenges in the villages was, we feel कि उन लोग देखने आएंगे कोई प्रोग्राम, कोई नहीं आता है. So we did this first and nobody turned up. So ऐसा एक काम करते हैं, स्कूल के बच्चों को स्टेज पे लाते हैं और उनसे प्रोग्राम करते हैं. So in the moment these fellows came on the stage and they performed, entire village was there. So we replicated this about 60 villages. Abhi COVID में we stopped. We're going to start again from next month. It was a wonderful emotional experience. There are few scenes from the program on drugs. It was again an extremely very good event. One of my students, who is a brilliant psychiatrist in child psychology in Australia, he came all the way only for this. Satish, sir, अपन करेंगे. And excellent counseling sessions were done. And then with my association BNIT, we had a wonderful program of summer internship. So MUHS posted about 5 students from Bombay to our unit. We trained them into ventilation. And in fact, I have made them as a faculty in one of the NIV workshops. Sometimes we feel that ये बच्चों क्या सिखाना है यार, but their grasping strength could be so much. So at least the beginning can be made to let them generate an interest. So, but transparency has been a part. Our apps are transparent, teaching models are transparent, the machine for respiration is transparent. As I've said, I was always blessed to have support all across the world. You can see Mark Rogers here. Mark is ready to help anytime. Satish, tell me how much you want. I will do that. So you see his wife, and they would, you know, he kind of managed to take care of transfer the whole Boston children team, about 6 of them, to Nagpur. They stayed, went back, all Mark Rogers. So there have been people outside who have been, another friend of mine, Edward, Professor of Neonatology in Norfolk. Tell me, kya karna hai? Okay, we will do that. So there have been people, and as again and again, I am blessed to have friends. I have friends in and around Nagpur. They will not like to be named. For example, there is Dr. Heman Murke in Amravati. Hey, Satish, kya karna hai? I will help. And if somebody tells I took his name, he'll feel very bad. But there's so many who would help in any of the projects. The entire team from Nelson editorial board were in Nagpur. All of them were always, so this is Nina Shore from Manchester. I owe a lot to my father, who was an ardent army man. Entire earning of his went to national defense. And when I say entire means, every pie that he earned in one of his companies. And this is our team, Dr. Deshmukh, Abhay Santoshmar, and Rashmi, she is here. Tejas is from Pune, and this young team from Pune. And they have been a big help. There's nothing like no. So getting off the beaten track has some disadvantages and problems. Sometimes you may be isolated or quiet, some might feel deserted, detached, hidden, lonely. Some might feel, you know, this fellow is egoistic, yaar, baatein nahi karta. You could be away from the usual things. So all these labels are a part of the unfamiliar charted path that sometimes you take. But then, as I've said, you fail 80% of times. And people will tell you, yaar, Satish, tu bol raha tha na wo to kuch hua hi nahi. So they'll ask more of, nahi, wo tu bol raha tha, kuch nahi jama hai. Right? But then, one will have to be strong because you have chosen a difficult path. So I'm happy to have Abhay Santoshwar here. Abhay, can you just stand up? And Rashmi, she is Tejas' sister, and others could not come here for today. So I'm grateful, thankful, and blessed. Thank you.
Thank you, sir. Now I will read the citation. Dr. P.M. Udani सन्मान पत्र, डॉक्टर सतीश देवपुजारी, वरिष्ठ बालरोग तज्ञ, नागपूर. आदरणीय महोदय, आपल्यासारख्या एका अत्यंत ज्येष्ठ, श्रेष्ठ व चतुरस्र बालरोग तज्ञास बालरोग तज्ञांच्या या राष्ट्रीय अधिवेशनात हे सन्मानपत्र प्रदान करताना आम्हाला अत्यंत आनंद होत आहे. नागपूरमध्ये वैद्यकीय पदवी व पदव्युत्तर शिक्षण पूर्ण केल्यानंतर आपण वैद्यकीय व्यवसाय सुरू केला, पण त्याबरोबरच वैद्यकीय क्षेत्रात अध्यापन करण्याचे आपले स्वप्न अनेक वैद्यकीय महाविद्यालयात प्राध्यापक राहून आपण पूर्ण केले. लर्न व्हॉट इज न्यू अँड अर्न व्हॉट इज ड्यू या आपल्या जीवन मंत्राप्रमाणे आपण नवीन नवीन तंत्र शिकत गेलात आणि त्या तंत्रांचा मंत्र आपण या वैद्यकीय क्षेत्रात असणाऱ्या सर्वांना शिकवलात. वैद्यकीय विषयाबरोबरच गणित विषयात आपणास कमालीची आवड असल्यामुळे आपण गेली 40 वर्ष सातत्याने वैद्यकीय शास्त्र व अभियांत्रिकी शास्त्र यांची सांगड घालत यशस्वी संशोधन केले आहे, याचे आम्ही साक्षीदार आहोत. एंडोट्रकियल ट्यूबवरचा नॅनो सेन्सर ज्याची जागतिक अभियांत्रिकी अधिवेशनात दखल घेतली गेली, ऑक्सिजन हेल्मेटची संकल्पना आणि निर्मिती, अंबुबॅग प्रोजेक्ट, भारतात प्रथमच सिम्युलेशन टेक्नॉलॉजी विकसित करणे, संपूर्ण जगात कदाचित पहिलाच ठरेल असा लंग म्युझियम प्रकल्प आणि दैनंदिन व्यवहारात उपयुक्त ठरतील अशा 14 वैद्यकीय ॲप्सची निर्मिती करणे हे सर्वच थक्क करणारे प्रकल्प आहेत. पण या तंत्रज्ञानात व संशोधनात कळस चढवला तो आपण संपूर्ण स्वदेशी बनावटीचा प्राण सेतू नावाचा नॉन इन्व्हेसिव्ह व्हेंटिलेटर तयार केला, ज्याची संकल्पना, रचना आणि उत्पादन स्थानिक पातळीवरच करून वैद्यकीय अभियांत्रिकी शास्त्रात एक इतिहास घडवला आहे. पण सर, आपण भारतातील व भारताबाहेरील असंख्य बालरोगतज्ञांना परिचित आहात. ते ज्येष्ठ आणि श्रेष्ठ पिडियाट्रिक इंटेन्सिव्हिस्ट म्हणून आपण पिडियाट्रिक इंटेन्सिव्ह केअर या शाखेचे भारतातील संस्थापक व अर्धव्य आहात. अनेक राष्ट्रीय व आंतरराष्ट्रीय अधिवेशनात आपण पिडियाट्रिक इंटेन्सिव्ह केअर या विषयावर व्याख्याने दिलीत. असंख्य चर्चासत्रात सहभागी होऊन आपले ज्ञान जगाच्या कानाकोपऱ्यात आपण पोहोचवलेत. हे संशोधनात्मक व शैक्षणिक काम करतानाच आपण लोक आरोग्य प्रशिक्षणाकरता आर्य चॅरिटेबल ट्रस्ट या संस्थेमार्फत केलेले कार्य लोकविलक्षणच म्हणावे लागेल. यातील आरोग्याची दिंडी या आरोग्य शिक्षण नाटकाची कल्पना व त्याला विदर्भात मिळालेला ग्रामस्थांचा प्रतिसाद आश्चर्यजनक आहे. सर, आंतरराष्ट्रीय ख्यातीचा एक बालरोगतज्ञ, इंटेन्सिव्हिस्ट, हाडाचा शिक्षक, एक संशोधक, नवीन नवीन तंत्रज्ञान शोधणारा शास्त्रज्ञ आणि अनेक सामाजिक संस्थांचा आधार अशा व्यक्तिमत्वाचे चित्र या मानपत्रात करणे अवघडच नव्हे तर अशक्यच आहे, याची आम्हास कल्पना आहे. तो दयाघन परमेश्वर आपणास दीर्घ आयुरारोग्य देवो व आपण अंगीकृत केलेल्या वैद्यकीय अभियांत्रिकी संशोधनास तसेच शैक्षणिक, सामाजिक व समाजकार्यास उदंड यश देवो ही प्रार्थना. आपले नम्र डॉक्टर हेमंत गंगोलिया, अध्यक्ष महाएपी, डॉक्टर अमोल पवार, सेक्रेटरी जनरल महाएपी, दिनांक 20 नोव्हेंबर 2022, स्थळ नाशिक, शब्दांकन डॉक्टर शेखर दाभाडकर, महाड, रायगड. We acknowledge the presence of Dr. Vrajesh Udani sir and Dr. Sunu Udani madam, and I invite them to join us on stage as well. Sir, I invite engineer Mr. Abhay sir and Mrs. Rashmi. Both are from Satej Group. They are associates with sir in Satej Group, as sir rightly told. And then team Maha AP, Dr. Vinayak Patil sir, Dr. Mohan Warke, then Nasik IAP organizing team of this MAHAPEDICON, Dr. Ramakant Patil chairperson, Dr. Milind Bharadia sir, organizing secretary, Dr. Sharmila Kulkarni madam, scientific organizing chairperson, and Nasik IAP president, Dr. Kedar Malhotkar sir, to join us on stage. I invite Vrajesh sir to say few words.
You know, Satish, you've shown us a new side. I mean, And I think there is no better person to get this award than you. Because as I was listening to your talk, two things came out. One was you were trying to solve problems in India, in the sense making affordable devices which we could use rather than from abroad. And that's exactly what my father used to do. Intensely nationalistic. And I think the second thing was you're an original thinker. I mean, you have the, creativity, obviously you have the talent, but you used it constructively in the phenomenal ways. And I wish you success in everything you do.
His honor to say some few words for not easy.
So, friends, thank you. I'm really humbled. And I always feel that this kind of honor should go to all of the friends which surround you and who keep encouraging you. Please encourage young students who want to do something new in your country. And I think that would be a very good side from our side. Thank you. Thanks a lot.
There's one important announcement for all our delegates. Checkout time of Hotel Taj was at 12. Please check all your belongings before leaving.
There's one more. There is one more important announcement. We have found some notes of 200 rupees in the second row of the audience. We have found some 1,000 rupees lying on the floor from the second row of the audience. Please, if it belongs to someone, please come to the desk and please collect it.
A very good afternoon to all our delegates. Once again, I, Dr. Prachi Kiran Birari, welcome all of you in this hall. Let us move on to our next session. I request Dr. Parmarth Sandane to come on the dais as the moderator. I request Dr. Abhishek Madhura, Dr. Indu Khosla, Dr. Pratibha Patil, and Dr. Prakash Vaidya to come on the dais as the speaker. The topic would be difficult cases in pulmonology. Even though it is one of the oldest ailment of mankind, we've now given it a nomenclature called pulmonology. And rightly so, if you look at the names of the faculty we have with us today, what may be to us just a patch on the X-ray is looked upon by them as a mysterious lesion ranging from non-resolving pneumonia or tuberculosis, hemochromatosis to disorders of pulmonary vasculature to a primary malignancy or secondaries. Let us know more about this from the gods of pulmonology who descended on our stage today. Thank you.
So welcome back from the to the reality from the science fiction session. Okay, so we will start with some interesting cases in pulmonology. I won't call these are difficult cases, but these are really interesting cases, and they somehow had challenged, during the course of the illnesses for the diagnosis. And I welcome all the three speakers, Indu Khosla Madam, Dr. Prakash Vaidya sir, and Dr. Pratibha Patil. So without wasting much of time, we'll move on to the cases. Yes, sir.
I'll just make a disclaimer here
Yes, sir.
that in this elite panel, I'm actually an outcast because I'm not a hardcore pulmonologist, but I will bring the general pediatrician's perspective to this interesting discussion.
That is all what we are here for. We want how we should all think, and we may be wrong in thinking process, but finally what matters is whether we have actually covered all the common things first. So coming to the first case, this is a 6-month-old boy, is a firstborn of non-consanguineous marriage, and is brought with complaints of cough for 10 days, increased respiratory activity, and lethargy and poor feeding since 2 to 3 days. This child is firstborn, no prior admissions, normal in ICU phase. There is no history of any oil installation in the nose. There is no history of any fever as well. For these complaints, the child was admitted outside, has received injections cefuroxime, azithromycin syrup, and oseltamivir. There, after 4 days of admission, the child had persistent oxygen requirement, and that's why the child was referred. So we'll start with some questions to the panelists as well. So, Dr. Indu, is this a common scenario? Next is, what is the typical course of a bronchiolitis, and when we should start worrying and start investigating further?
Can we go back to the first one, your case? Okay, so 6-month-old typically coming with cough, increased respiratory activity. In the last 4 to 6 months, I think we have all seen a lot of children coming like this with cough and increased respiratory activity. What is missing here is there is no fever, there is no rhinorrhea. I don't know if there is a sick contact. And typically the children that we see with respiratory infections, viral most often than not, RSV, metapneumo, or the regular viruses, very occasionally adeno also. But they tend to start with cough, and almost similar time they would start with increased respiratory activity. They start getting breathless almost at the same time. So this is something which is going on for more than 10 days. And now just please go back to your next slide, please. And now this child has required oxygen. So I am a little concerned, though respiratory bronchiolitis in this age group is a common scenario, there are some gaps here. This is going on for a little more prolonged period of time. A typical viral LRI bronchiolitis, RSV especially, can go on for 10 to 14 days. And then the child starts settling down. It doesn't start worsening then. So there is something which is bothering me here, that this is not the run-of-the-mill bronchiolitis.
Absolutely, but many of us are like practicing or seen that the typical viral bronchiolitis, what we used to see before the COVID. Isn't there a change in the scenario that we are seeing more severe infections, which are not typically following a typical course of bronchiolitis which they used to follow before the COVID?
I completely agree with you. We know we are facing a phenomena called as immune debt. At least the hypothesis says that our kids did not get exposed to any infections, and now that they're getting exposed to infections, they're getting more fulminant and more severe. Yes, post-COVID scenario, I would keep it in mind, but I would be a little more cautious with this child than a routine bronchiolitis is what I want to say.
May I add something? That
Yes,
this
please go.
concept of worsening bronchiolitis and more severe and less easy to manage has been predicted way back in US as well as in Europe by their models. And that is what we are actually seeing. Bronchiolitis don't get well fast, they keep on lingering, and they have worse outcomes compared to what was in the pre-COVID age.
If this would have been a high-risk case, say a preterm or non-breastfed, or the child with a congenital heart, exposure to tobacco, the usual high-risk criteria for bronchiolitis, I would quietly accept it.
Absolutely, absolutely. So this child, when had come to us, the child was actually playful, non-sick. Heart rate was 134 per minute. Respiratory rate was 48. That was on oxygen, and the saturation was 98 to 100% on oxygen with nasal prongs. The respiratory rate used to increase to 70 without oxygen, and the saturation used to drop around 84 to 88 when the oxygen was removed. The child's birth weight was 2.6 kilos, and currently the child is weighing 5.8 kilos. Otherwise, the child is developmentally normal. The child has achieved a rollover. So this was the investigations that were done on admission. So Dr. Prakash, so this hemoglobin was around 10.4, total counts were 29,000, and rest all that you can see on the screen, sir.
So looking at the total counts, initially it does look like it's some sort of an infection. Now, what infection will cause a WBC count to be so high with a total more of a lymphocytes? So I think it's either a viral or even a pertussis can cause this kind of picture where you get a high count. Now, so it's definitely an improving story. The infective element seems to have gone down and the child is improving over time. But when I look at the ABGs, now let me confess that I'm not good at ABGs. So what I do is I use Dr. Devpujari's app, which is such a wonderful gift to all pediatricians. So if I would put this in Dr. this looks like clinically like a compensated respiratory alkalosis, which I would actually like to confirm by using the app. And let me just put in the figures very quickly, because it just takes a minute job. So here I find that by putting on these figures, the alveolar arterial gradient is also high. That means there is some problem with the capillary permeability. There is some problem with the capillary alveolar unit. So this is basically a hypoxia, not so much a hypercapnia, indicating some alveolar problem, which is improving over time. That's all I can make out.
Absolutely correct, sir. This was the chest X-ray. Sir, interpretation.
Yeah, so here I would say that I'm looking at a very unusual kind of air bronchogram, because normally we do not follow the airways right till the end, but well, I don't know how important that is. There is also a diffuse bilateral shadows everywhere, and also there is a little hyperinflation at both bases. So to me, this is compatible with some sort of an infective respiratory virus at this point of time.
Yeah, we can say that diffuse parenchymal involvement is there with some air bronchogon that can be seen, with a problem with the alveolar gas exchange, isn't it, in the blood gas, with a high WBC count. That we'll keep it in mind. Okay. So this was the CT that was done before coming to us. Dr. Indu.
So what day of illness was this CT done?
This was just before the transfer, somewhere around day 15 of illness. So the child was like admitted for 5 to 6 days outside.
So when I look at this CT, there is no air trapping that I can see on this CT. I can't see a mosaic pattern. In a bronchiolitis like picture, I should see some kind of a bronchial spread, a bronchial thickening, a mosaic pattern, and hyperinflation. What I'm seeing here is there's a lot of ground glassing. Okay. And I do see prominent septate. I see prominent interlobular, intralobular septate. I can't really call it fibrosis of the septate, but I do see prominent septate and I see ground glassing. Now, if you ask me, how do I interpret this, whether I would call it bronchiolitis or something else, I would need more inputs on this child. So I definitely see ground glassing. So something unusual is happening here and the septate have become prominent.
Yeah. So what I can say here is there is definitely a pan lung involvement. Okay. So almost every part of the lung is involved. If we see some viral infection, many times we see some patchy involvement. That patchy involvement is not there. It is a pan lung involvement is there. First thing, septations are definitely, which the septors are there, they are definitely more prominent. Okay. And air trapping is not typically seen in this picture. What we see in bronchiolitis and all, that is definitely not seen here. So air trapping is also not seen. Okay. So our radiologist has actually reported this as diffuse ground glass opacity with in the bilateral lungs with smooth septal thickening, findings suggestive of diffuse childhood interstitial lung disease, possibilities of surfactant and chronic pneumonitis of infancy. This is what our radiologist had reported. And this is not we had initially had thought of because this is
Dr.
just a
Parmar,
2
may I
weeks
ask
history.
one question here?
Yeah.
If a multiplex PCR panel were available to you nasopharyngely, would you do it or not? Because I think I would in my setup.
Absolutely. So there are certain things when you do a multiplex PCR, you send a sample from the nasopharyngeal aspirate. If it's a viral etiology, you may get it positive. But if it is a bacterial or fungal or some uncommon organism you are thinking of, you may not get positive. More than that, you may get misled here. You may get misled here and you will start thinking, we'll wait for another few days, This is adenovirus, this is parainfluenza, this is RSV or something. And that important time frame you may lose for another week or so, thinking that this viral multiplex PCR is nasopharyngeal aspirate. So sometimes it is really helpful. Sometimes it may, it may be a waste of time and you may just relax and
In fact, that pneumonia plus panel that we do is it's specific for viruses.
Yeah.
Again, you get a lot of bacteria in that, and those are not reliable at all. I would like to leave a message here that in the pneumonia, please do not do a pneumonia plus panel when you are thinking of a bacterial infection. And the only thing which is specific in a pneumonia plus panel is a MRSA bug, which can be picked up with reasonable certainty. The other bugs that you see, you in any child who's in the hospital would be colonized with those bugs and you would see it. Yes, if you get an adenovirus in a bowel, a viral infection, an RSV, or even an influenza, I would definitely take it with
In the right context.
In the right context, in the clinical.
So what is
context.
important here is the sample from you are taking. Is it a nasopharyngeal aspirate versus is it a bronchoalveolar lavage? If it is a nasopharyngeal aspirate, you can get, you can have many bystanders also sitting there and you may get positive in that PCRs and you may take it as positive and start treating, or maybe not to start, you may take it as grossly positive and not do anything for and wait for a longer time. Okay, so sample is also very, very important. Nasopharyngeal aspirate versus bronchoalveolar lavage. And then you can really work on that. So, Dr. Pratibha, difficult questions for you.
Yes,
Because
Dr.
like
Parmar.
initially, now because we are reached a stage, basically because most of us have gone into a phase like almost like thought process is gone. Now, what further should be done? So,
Yes.
based on the radiologist report, she has said whether it's a surfactant deficiency versus something else, chronic pneumonitis. What next thing you want to do here?
Yes, Dr. Parmar, thank you for that question. Before going to the next step, I would like to go one step behind. And let me tell everyone that Parmar सरांनी असं दिलंय ना की directly Google काही cases सांगणार नाहीये. Yesterday I called, are you taking any meeting for us which cases we are going to discuss? He told no, वहीं पे लेके आओ. So I'm feeling Parmar कि आप हमारे वाइवा ले रहे हैं and you're a AP associate professor and I'm a student. Let me go like that only. So I have taken some points on that. You told this is a small 6-month-old baby, right? Cough and respiratory distress with lethargy and poor feeding. That means initially the baby was sick, but I think you have not mentioned about fever. Is baby had a fever?
No fever. No
Okay.
fever. Entire duration of illness, there is no fever.
So that is very about it. You have mentioned that baby has also received some antiviral and antibacterial things on the second slide, right? So they might have, and then again refer to you. And then so baby might have, it could be received antibody somebody has seen and then refer to you, means it might be infective. So it could be virus. Still, I want to stick to the viral even after seeing the radiologist opinion. Still, I want to stick. So we are discussing, let me remind everyone that we are discussing difficult pneumonia, isn't it? But I don't want to label or diagnose difficult pneumonia. मला difficult pneumonia हा diagnose करायचंच नाहीये. From the first day only, I want to suspect it so that I can give us some thought process की हे difficult pneumonia होणार आहे. तर मी prepared राहीन आणि parents ला convey करेन. See, we are discussing about viral. When we tell, even though I'm broncologist, बाल केलं तर खूपच छान होईल. Ball fluid is very absolutely right thing to do. Even nasopharyngeal swab we can do. But when we get after doing the bronchial lavage, if you get a viral pathology, adenovirus किंवा respiratory syncytial virus आला, RSV आला, तर it will anyhow going to take 14-15 days. then you are convincing power to the patients on the first day only when you suspect की हे व्हायरल आहे तर 50% हे लवकर कमी होईल आणि 50% कमी होणार पण नाहीये, 14 दिवस लागू शकते. हे जेव्हा तुम्ही पेरेंट्सला सांगता तेव्हा त्यांचं माइंडसेट तयार होऊन जातं. तेव्हा डिफिकल्ट न्यूमोनिया आपल्याला म्हणता येणार नाहीये. आपल्याला सुरुवातीलाच डिफिकल्ट न्यूमोनिया होऊ शकतो, त्यामुळे योग्य मार्गावर आपण चालू शकतो.
Yeah, so
that is, yeah.
next, so you will do genetics, lung biopsy.
No, sir. I would like to go first, even though BAL, as I'm doing bronchoscopy, but nasopharyngeal swab, viral panel is also equally good. Equally good in that.
You will do a nasopharyngeal aspirative test.
By myself, if it is a patient with me, I will go for the BAL. But if it is with the common pediatricians, because it's a common pediatric aspect se jayenge, so it's better go for the nasopharyngeal. Not everywhere it is available, right? If you get a viral pathology, so upgrading, third question you are putting us, upgrading antibiotics without getting any organism, I think it's a crime.
Without fever.
Yeah, without fever also, even is fever, तुम्ही आता antibiotic सुरू करता आणि रिस्पॉन्स नसेल तर अँटीबायोटिक लगेच हायर अँटीबायोटिक वरती आपण घेऊन जातो, बट दॅट इज नॉट करेक्ट. तेव्हा डिफिकल्ट न्यूमोनिया खरंच आपण फेस करतो, बिकॉज वी मे चूज अ रॉंग अँटीबायोटिक विच द बग इज नॉट सेन्सिटिव्ह ओनली. So if you start blindly the antibiotic, escalating it, we are abusing the antibiotics also, and we are, we are going to the land up ourselves into the difficult pneumonia.
Steroids.
Steroids, I would like to wait. I'd like to wait because even though radiologist is telling it's a surfactant deficiency, we should not accept it because 14 days only, 2 weeks झालेले. So I would like to get the ball culture. मग नंतर त्याच्यानंतर बाल जर गेलं असेल तर I would like to send that ball fluid for some organisms culture also, because bacterial also, secondary bacterial. Virus, meanwhile, we are discussing, sir, I will take 1.5 minute more. Virus oscillatory fluid आपण दिलेलं होतो, but fluid when it acts only acts in first few days.
We are going on time.
Yeah.
So
sir, I would.
So out of this, you want to do anything out of this 4?
Not like to jump lung biopsy, because lung biopsy just on the radiologist opinion is not good to do.
So just yes or no? No surfactant workup, no biopsy.
No, we can see as a pulmonologist.
No,
we
at
can
this
go
point
for
of
the
time,
genetics.
at this point of time, tell me whether you will do.
I will wait, and after BAL, I will go for the genetics.
So first,
studies.
you think you will want to do a BAL?
Yeah,
Dr.
so
Indu.
I would like to do a bronchoscopy on this child if the child is clinically stable. I'd like to look at the bowel fluid, whether there is a milky fluid or not. So if we are suspecting a surfactant protein metabolic disorder, these children have macrophages which are foamy in nature and pass positive macrophages. So I'd like to look at that. Having said that, children with alveoloproteinosis sometimes in the beginning of the course may not have a milky bowel.
Absolutely.
So that is one thing I
So
keep it in
even though
mind.
the CT favors the diagnosis of your
Sorry?
alveolar proteinosis,
Sorry.
your CT,
Huh.
it favors the diagnosis of your alveolar
Yeah.
proteinosis.
So I
It
would
looks
do a BAL first, and if it favors goes in the favor of alveolar proteinosis, then I would do a lavage for this child to see if it's better. The thing is, this child has improved on oxygen. I mean, if it would be an alveolar proteinosis, just an oxygen, I was wondering why this child has improved. So that is one thing. I would keep that.
you want to say the child should not have improved on oxygen.
No, would you come back to the previous ABGs serially? Yeah.
So he has improved on oxygen. If I have not done a lavage,
Why would
and
he?
this is alveolar proteinosis, why would he have improved with just oxygen? So that would be,
Sir.
that would be one thought. Secondly, we also seeing a lot of secondary alveolar proteinosis. You can have genetic, you could have congenital, and you can have secondary to viral infections. So whether it is one of those, so this would be my thought process. So I would first do a bronchoscopy. If that doesn't give me an idea, then I would do a genetic.
No,
but I would watch this.
Dr. Prakash, you have anything to add in apart from what they have said?
No, initially I would have thought more of a viral, but now the CT has made us wiser, right?
Okay.
So definitely one would do a BAL, look for any pathogens, as madam is saying. And
Dr.
also
Verma,
look for the kind
I agree, sir.
alveolar-
SPC1 surfactant, SPC gene deficiency may cause viral association.
The other
It's last studies have shown that surfactant C deficiency, jo bhi hai, it's very associated viral. So we may be having.
We
that
will move
code
on
to
and
get-
we'll see what we had done.
Can you just clarify one thing? Now, this improving ABGs are in the presence of oxygen or it's without oxygen? The last.
So the child is going home without oxygen, sir.
So
Discharge.
it's on room air.
Yes,
That means his capillary alveolar unit has improved
absolutely.
over time.
Yes,
So it's
yes.
a process of hypoxemia that has reversed.
Yes, yes, yes.
What has accounted for the reverse? I still am a little unclear on that.
Probably we have done something right. So as all three of you have agreed upon, we did a bronchoalveolar lavage here. Before that, I thought of giving a steroid trial to this child. Okay. So this is when a reference was sent from another unit to me, what should be done for this child? I whether we should give steroid or not. So I was actually planning to give steroid to this child, but then I said, okay, let me do a bronchoalveolar lavage in this child. Okay, so did a bronchoalveolar lavage, and there we sent a panel, and what we got here.
PCP was one thought which did come into my mind, because that can have a similar presentation and you could have a secondary alveoloproteinosis following PCP. So that is one of
So
the.
this child, everything else has come negative, no virus, no bacteria,
HIV
nothing,
negative,
nothing.
mother was-
Yes, we
What is
have.
an immunodeficient child, that means?
So
clearly
immunodeficiency, primary versus secondary, HIV versus primary immunodeficiency. So this child PCP had turned out to be positive. Child was started on Septran, weaned off of oxygen in 6 days. Then we planned for immunology workup. HIV was negative. Basic immunology workup, all the immunoglobulin assays, NBT and LSSA, everything was normal. A whole exome was sent, and this child has turned out to be a X-linked hyper IgM syndrome. Okay, so similar case has been reported multiple times, like many of these case reports are there. So pneumocystis carinii is presenting in infants because of some underlying immunodeficiency. You can see that X-ray is like us only, okay, almost like us, except the air bronchogram is there in the upper side and our side is the lower side. Okay, so final diagnosis is PCP pneumonia in a case of X-linked hyper IgM syndrome. So learning points from the first case: unusual site, unusual organism for our case, unusual duration or frequency, that is persistence and recurrence, and unusual course of antibiotics requiring long-term antibiotics. Think of primary immunodeficiency. This was the child at the time of discharge. He is our resident, not the father. Okay. So this child is been planned for HSCT, that is transplant. So coming to the second case, shall we go ahead? So this is a 12-year-old girl, and she's first by birth order, born of non-consanguineous marriage, came with complaints of fever and cough for 7 days, and there is a frank hemoptysis since 4 days. For complaints of fever and cough, she has received oral antibiotics, after which the fever and cough has settled. So there is no fever and cough. The child is completely normal till 12 years, never been admitted, no past history of TB and TB contact. She's going to school, 6th standard, and she's good in studies. On examination, she is thin built, afebrile, heart rate is 126, respiratory rate 34, blood pressure was 96/70, saturation on room air was 98%, and she was relatively well built. No clubbing and cyanosis. So she was admitted as an emergency case. 4 days of hemoptysis is there. So this is what she presented to us: gross hemoptysis. Dr. Prakash, your comments about the child is presenting this way, and how do you differentiate between hemoptysis and hematemesis and common causes of hemoptysis?
Hematemesis, you said.
Yeah.
So hematemesis, usually there will be altered blood, like a coffee ground because of exposure to acid, whereas hemoptysis would be actually very bright red.
Bright.
So that's one of the, though of course you can get aspirated hemoptysis and come out as hematemesis also. So it's not so simple always. Now the causes of, you already.
The causes are just put in, you can, these are
mentioned the causes. Now, when you see such a massive hemoptysis, probably you will not think of each of these causes, because if you see a little mild hemoptysis, you'll think of infection, like maybe a viral one or even a bacterial one, even tuberculosis or fungal. When you see massive, you're thinking something like a vascular problem possibly, or like maybe a AV malformation, or maybe something like maybe a cardiac cause, like you're thinking of a pulmonary edema, maybe you're thinking of trauma, you're thinking of a foreign body aspiration.
retained foreign body, absolutely. Yeah.
Bronchiectasis is another common cause of a massive hemoptysis, especially in cases with cystic fibrosis. And to complete the list, you will think of even pulmonary tumors, trauma, and coagulopathies, and a diffuse cause of alveolar hemorrhage, including idiopathic hemosiderosis. So actually, you have to think of a vast canvas of causes in a hematemesis. But in this particular child, it is massive. So some of these causes are much less likely.
Yeah. And even,
You would also differentiate between whether the bleed is from a pulmonary vasculature or a bronchial tree. So if it's from the bronchial tree, it is more quantity wise, and it could be fresh blood and it could be larger in volume. Generally, when there is a bleed from the pulmonary vasculature, the quantity is small. Say, like when you have your idiopathic pulmonary hemosiderosis, etc. So generally, the quantity is small. So that also once helps us to know from where the bleed is coming.
Absolutely. So even in, there was like recently we had a child, it was a cardiac case, known case of cyanotic heart disease who had a MAPCAS who presented with a massive bleed. So that also cardiac causes also should be kept in mind. So this we had discussed, and how do you differentiate between hemoptysis and hematemesis is pH. If you have a sample, send for pH, alkaline versus acidic pH, and the color also sometimes can tell you. Plus associated symptoms, maybe respiratory symptoms versus liver versus GI symptoms can be there. This was the X-ray on admission when she had come. Yes, Dr. Indu.
When I look at the X-ray, I find the chest of this child, the shape is a little barrel shape. So I don't know if something chronic is happening here. There is no loss of volume in the lungs. The lungs are good in volume. In fact, the right side of the diaphragm is really pushed down. So there is, if at all, there is increase in volume. Then if I look at the shadows, there are bilateral shadows. There is some amount of something like a reticular streaking. I'm not sure, but I think I can see some cystic changes in the left lower zone, similar to like a bronchiectasis, but I cannot be sure on a plain X-ray. That would need a CT to differentiate. So bilateral reticular shadows and some amount of, I would say, air trapping in the lung is what I could make out from this.
Okay. This opacity?
That is like a consolidation there. Sorry,
Can be a bleed
that.
as well, right?
Yeah, it is a small consolidation that I can see there.
Can be a bleed also?
So
can be a
blood will look white. Yes, it can be a bleed. Yes, yeah.
So this was the CT.
Oh, if I look at the CT, I see some kind of a consolidation both in the lingular lobe. I think that's a lingular, to some extent also in the right middle lobe. I'm not too sure if I'm seeing bronchiectatic changes lower down, but I see one or two. There is the bronchi are not as tapering as I may want them to be. So I would think there is some bronchiectasis there, and there is consolidation on both the sides.
Absolutely. So definitely there is something is happening in the left side as corroborating with the chest X-ray. Okay. So what next?
We have to manage the case. It's the basic management of the acute massive hemoptysis. Massive is more than 200 ml per episode is what we call as a massive hemoptysis. First three intervention include the three things. First goal is to prevent the normal lung from the bleed. Second is to clear out the airways and diagnose what is the site of that with the CT scan and CT angiography. And third one is to heal it, to prevent with the ligation, with the help of your cardiothoracic surgeon or interventional pulmonologist, to prevent it. Second, I would go like bronchoscopy. In bronchoscope, I would like to clear out the things in the airways. Second, I would like to see the mucosa, if it is a petechiae or purpura, something in the mucosa of bronchi. Third thing, we can see the commonly, you have rightly pointed out, tuberculosis, which is the most common thing in India. Tuberculosis, endobronchial carcinomas. We can see any mass which is leading to this. And we can see beautifully if lymph nodes are there, one side circle of a bronchus and second is elliptical bronchus. That time we can, elliptical means one-sided elliptical. We can diagnose as lymph nodes pressing over there. If petechiae and purpura there, as we have mentioned, vessels are invaded already, vessels are involved. Thus leads to your mindset that it's a vasculitis related things. And you have mentioned the 12 years old adolescent girl with the vasculitis. Hai to kya karenge aage? That is my thought process, basically. And again, investigations I would like to go at adolescent girl hai. Petici purpura and the bronchoscopy, then I would like to rule out any autoimmune disorders which is leading to the vasculitis, small vessels are involved, जिथून ब्लिडिंग झालं असेल ते फाइंड आउट करायचं वेसस साइड टू दी ब्रॉन्काय दॅट वॅस्क्युलायटिस कशामुळे झालं असेल तर ऑटोमिन डिसऑर्डर्स अँड SLE ANA and double stranded DNA I would like to send definitely if I won't find any mass inside.
So in this acute event of bleeding, will you still do a scopy?
So I think in such a child, I would first like to stabilize the child.
Absolutely.
hemodynamically.
Very, very
My
important.
first step here is to stabilize the child hemodynamically. I might want to give a blood transfusion. I want to look at the bleeding profile of the child. I would do a coagulation profile. If the child is on any NSAIDs or any anticoagulating drugs, I would like to stop that. I'd give some cough suppressants to this child if this child is coughing violently. If it's a case like a child with cystic fibrosis or who's on chest physiotherapy, I would stop that. And I would first protect the airway. I might have to intubate this child if the child is not breathing well. I might want to do that. And then I would think of doing a bronchoscopy to identify after stabilizing the child, where the bleeding is from, if I can do that. Sometimes it's very difficult. You do a scope, it is fully clouded with blood and you really cannot find out where the bleeding is coming from. And if it's a torrential bleed like this, it could be from a bronchial artery. Then maybe a CT angio, a bronchial artery angio might help me localize where the bleeding is. Sometimes I may want to do a rigid bronchoscope instead of using a flexible. It might give me a better vision and a better control of the child's ventilation. Cryo can also be used to stop bleeding if you have facilities for a cryo.
Yeah.
So this, my first step would be to stabilize the child.
Absolutely.
Then I would look at going to doing
Yes,
MS.
ABC we are following anyhow ABC for emergency case. This is airway, breathing and circulation for any child, like we have to follow strictly with this.
Absolutely.
Couple of things I would not do, just to emphasize. One is I would not use a BiPAP here. You can't, because that will actually worsen the bleeding. And secondly, if you ventilate, you would use a higher PEEP so that it will actually help to reduce the extent of massive hemoptysis.
Absolutely. So actually we had thought of doing a scopy in this child to localize the bleed, but then she was bleeding so much. We had thought that probably it will trigger more bleed. So we didn't do any scopy in this child. We can actually see that she's having so much of bleed, and through the scope is it's very difficult to do interventions as well. So on admission, the hemoglobin was 5.7 and total counts were 11,000. Platelets were normal 3.6 lakhs. INR was normal 1.2. Slightly high creat was noted 1.2. Urine routine was normal. ANA was 1+, and dsDNA was negative, and she turned out to be a MPO ANCA positive. This report came after little time, after 4-5 days. Then post transfusion, everything was normal, and this was the MPO ANCA positive report. Now, because she had presented in a very significant emergency situation, it is difficult for us to get this report in 3 to 4 days. And without having a report in hand, would you give steroids to this child?
After ruling out every other cause, like of course, in children, I would think bronchiectasis is the highest, bronchitis is the highest in my list where children will have bleeding. Of course, I'll look at other organ involvement, cardiac, renal. If renal is involved, okay, suppose this child, I do a urine and that urine shows me proteinuria, then I know I'm dealing with something like an autoimmune. Maybe if the bleeding does not come under control, I would give this child. Now, of course, TB we have to rule out, but in pediatrics, in my experience, your experience may be different, but we don't see so much of hemoptysis in children with tuberculosis, unlike adults. Adults, we see a lot of hemoptysis. So, and giving 1 or 2 doses of steroids, even if I'm thinking of TB, is not going to harm this child. It might really help this child. So I would definitely use it in this child, taking all the precautions.
But before going for the broncho, just for communication, before going for the BAL, is it okay to get a CT scan angio, which would rule out our AV malformation basically? After stabilizing, CT angio would be more better. Giving vitamin K and cryo, as madam said, and sending for the CT angio so that we can keep everything ready in the OT for the ligation if we get anything.
Point taken. Anything to add on, sir?
No, I would just add that tuberculosis is rather low on the list when you come to hemoptysis in India. I don't know whether in Vadia you're seeing a different spectrum, but we hardly see tuberculosis as a cause of hemoptysis.
Maybe adolescent girls, a near adult.
So this girl is an adolescent girl, massive hemoptysis. There is a slight higher creatinine. And So we had thought of autoimmune in this child, and that's why we had sent an autoimmune workup. But meanwhile, thinking of autoimmune, we had started this child on steroid as well. Say 2 doses of steroids, no improvement, persistent hemoptysis. What will you do?
Then I would like to do an angio. I would like to do a look at from where she's bleeding, and the way she's bleeding, we'll just lose her if you don't do aggressive work. So maybe I will do a bronchial artery embolization. I will do what is very important is that you should have a good person to do this, because while you are embolizing, you don't know where all the blood supply is going. It might go into the GI tract. The spinal arteries also can sometimes be connected with these arteries. So you have to be very careful, because you should not leave the child with a deficit while you're controlling the bleeding. Yes, I would consider a bronchial artery embolization for this child.
Yeah. So we did a cath in this child, and as you can see that left bronchial artery was little tortuous, and there was a good leash of vessels that can be seen there on the left side. Okay, when the dye is put, can you see this leash of vessels, and there is a slightly dilated and tortuous. Okay, so left bronchial artery embolization was done, and you can see that leash of vessel which was seen initially is not seen in the post embolization.
Bronchial artery bleed from the very common in children with cystic fibrosis because of the erosion of the airways and right through the bronchial tree. So we see that more commonly with children with CF.
Yeah. Okay. So this child was started on steroids. So the final diagnosis was an MPO associated vasculitis, and this child was planned for a renal biopsy as well because create was on a higher side. So we had discussed this. We are running short of time. Then we'll just go on to the last case. So this is a 2-year-old.
No, Parmat, can you tell the diagnosis for the people? I mean, why
case?
kidneys, vaginous vasculitis due to what?
MPO associated vasculitis, ANCA associated vasculitis.
That diagnosis we can take as a vaginous granulomatosis like thing.
Absolutely, yes, yes.
That diagnosis we need to tell, yeah.
So this is a 2.5-year-old child, and born of non-consanguineous marriage, came with fever for 2 months on and off, cough for 2 months, and loss of appetite, and weight loss is also there since 2 months. There is no history of tuberculosis contact. Child has received oral and IV antibiotics, admitted twice in different hospitals, received IV antibiotics there. But the child was not improving, so based on the chest X-ray and the symptoms, the history, the child was started on tuberculosis treatment. The child's gastric lavage was done, and it was negative for tuberculosis. So this was the chest X-ray for which, based on the symptoms and the chest X-ray, the child was started on AKT. So Dr. Pratibha, what is it?
Yes, in a short, as the time is very less, 3 minutes left, I will tell in short, 3 criteria you are given: cough more than 2 weeks, fever more than 2 weeks, and loss of weight more than 5%, or there is a weight loss or no weight gain. These 3 triads I want to tell fits into the tuberculosis. This is a triad given by the NTP: fever, cough, more than 2 weeks, and weight loss or no weight gain is a tuberculosis. I would try, even though there is no contact, I would like to still keep as a tuberculosis first in at least with this history.
Okay.
But if your gene expert is negative,
still I would like to go.
And gastric lavage gene expert was negative, I would dig deep. I'm not going to just kind of, with such a significant change in the lung. The yield of gene expert in gastric lavage is more than 50 to 60% if done properly. Yeah.
So the
Yeah,
keyword
only-
is done properly.
Done properly.
And
So
there is let's all follow the algorithm which says if one gene expert is negative in GL, we will do a second sample.
One.
Thirdly, if you are really suspecting and you want to start, you will not start blindly. You'd probably be more aggressive and look for a more aggressively taken sample, either from a lymph node or from a BAL.
Sir, there is a pyramid of a NTP given by the NTP where there is a tip is a microscopic evidence we have to find. If won't get into, because 68% is in culture positive असलेल्या babies मध्ये पण व्हायरल म्हणजे टीव्ही कल्चर पॉझिटिव्ह असेल त्याच्यामध्ये पण गॅस्ट्रिक लवाज केला तर तुम्हाला फक्त 68.55% पॉझिटिव्ह मिळणार. त्यामुळे बाकीचे 40% मध्ये काय?
Absolutely.
So I want to keep still tuberculosis in mind and then rule out.
So empirical AKT is completely confined to the dustbin of history. There is absolutely no reason today for empirical
So
AKT.
if this child would have come to you, would you have given AKT or not to this child?
No.
Sir, I would like to give because there is a presumptive suspect tuberculosis case. We should not use the word
I will
suspect tuberculosis.
investigate
Yeah.
more. So 3 opinions.
Because you will investigate more because you have a bronchoscopy setup. Sir doesn't have.
Presumptive.
Unless you follow all the algorithm completely,
I would
you
investigate
cannot
this
diagnose
child.
presumptive.
Sir, nahi, presumptive tuberculosis we can keep on the triad, sir. Actually, following the NTP, I would like to keep this as a presumptive tuberculosis case.
Sure,
But you're keeping us a Google, you'll tell
So
the
once,
answer.
once you're out of everything, like once you're done with all possible investigations, and still if you're not getting what you want, that microbiological isolation, then you can think of giving AKT. But
Yes.
here, so this was the child when he had come to us, the heart rate was 110, respiratory was 48, CRT was less than 3, blood pressure was normal. The child was icteric, child was pale, liver was 4 centimeters, spleen was 3 centimeters, and this was the X-ray on admission. Dr. Indu, is this still a TB with drug-induced liver injury? Are there any other differentials? In other way, what are the common causes of miliary pattern on chest X-ray?
Can I go back to the previous? I want to see the X-ray. Okay. Now, there is some amount of miliary shadows like thing that you can see, but I also see some cystic changes in the left lower lobe of the lung. So I'm not too sure that this is only miliary. I'm not really too sure. I would like to, and then you are telling me there is icterus which is present, liver of 4 centimeters spleen. Yes, miliary is my first diagnosis, but with this kind of a picture, I would investigate this child. First of all, I will do a BAL for sending for gene expert. And if that comes negative with such an X-ray, I am not going to think in terms of TB. And of course, you can get icterus when you like a drug-induced liver injury if you have started anti-tubercle. But I'd like to see the liver enzymes, the report of the liver enzyme, whether it has gone up by 5 times is in a symptomatic child more than 3 times. Then I would think, you know.
1 or 2 common causes of miliary patterns on chest X-ray.
Sorry.
1 or 2 common causes of miliary
Sir,
patterns.
sarcoidosis can give rise to some kind of miliary mottling.
Okay.
Then you can have
Pulmonary hemosiderosis, we can divide into the infective and non-infective.
Eosinophilic lung disease.
Yeah,
Even healed,
LCH.
even healed varicella pneumonia can also
In
cause
this Respicon coming Chennai, we are presenting a paper on miliary
Infective
but not TB.
Yes, yes, sir.
Miliary
So
but
many
not
causes
TB.
we can 8 to
So
10
there are like
causes.
17 or 19 cases we are presenting there.
Yes.
So this where diagnosis of miliary tuberculosis, possibly they have received AKT also, few of them, but finally they turn out to be not
Even
tuberculosis.
fungal can cause miliary mottling, and even healed varicella pneumonia can also cause, and non-infective pulmonary hemosiderosis, alveolar proteinosis can cause.
Absolutely, yeah.
Yeah.
So this was the investigation. The hemoglobin was 5.8, total counts were 27,000, ESR was 109. PTNR was grossly deranged, maybe because of the AKT the child had received. SGPT and SGOT were 172. Direct and indirect bilirubin was direct bilirubin was slightly at 2.2. Rest all were normal. So this child definitely had some liver involvement, whether it is a drug-induced liver injury, whether it is a primary disease which is affecting the liver, that we'll see further.
Not fulfilling the criteria of DILI.
Yeah, we don't do PT-PTTK in normally whatever the
you want
criteria.
more
We do SGOT, SGPT.
Absolutely.
We don't do coagulation profile when we are
But if the
suspecting-
child is absolutely icteric,
Yeah, so this is something else. This is some liver injury.
Sir,
I'm
one
not
back,
too sure
one
if it
slide.
is, see, I'm not ruling it out, but I'm not ruling it in either.
okay.
So I'm going to keep my options open here.
One slide back, the GTPP, no, most of the people, well, एक slide back.
Okay.
One slide
What
back.
next you will do here? Tell me.
That is GTP. In last GTP is gamma glutathione transferase. What he has done is for the liver damage, it is showing very high 30s and normally we are producing 400. That means definitely liver induced. I can say here it is also AKT induced liver injury.
So-
I would like to stop and see this given vitamin K cryo, and then I would stop
So
AKT.
AKT was withheld, vitamin K was given, the child was received, child had received FFP transfusion as well. As you said, we did a bronchoscopy, gene expert was negative, AB was negative, bacterial fungal cultures were negative, and spatial stains also were negative. What further?
So now I would think I would want to biopsy this child. A bone marrow, a biopsy, a lung biopsy, a liver
Bone marrow,
biopsy.
why bone marrow? There is no
So
CBC
if you go
involved.
back to your previous slide,
Miliary mottling.
There is no CBC apart from hemoglobin, which is low. There is no other involvement.
no, so lung biopsy or a liver biopsy, I would like to do on this child. Once I stabilize this child.
Yeah.
So we have 3 options to biopsy. You can do a bone marrow, liver or a lung. Which will you take?
Bone marrow, if I'm suspecting a hematological disease, which I'm not really, not like a leukemia. So bone marrow is not there. The other two, well,
Liver and lung.
yes.
Pratibha?
No, I would like to see even cellular morphology of a ball. I would like
How many
rely
of
on
you
myself.
still stop here and give AKT?
AKT stop करून बाल करेन आणि त्याच्यातलं सगळं cellular
Bal is
pattern.
negative. How many of you will still stop here and give AKT?
Still?
Not investigate further. Bal is negative. Okay. But still, will you give AKT to
We
this
don't have
child?
a diagnosis, so we need to investigate.
Bal tuberculosis comes negative, then we have to stop only. Because still it is not 88-90% only. Na? Still I would like to stick to that.
But presence of
I would do a
icterus
lung
means
biopsy.
straight away you will stop AKT.
Yeah,
Both
we have
have
to
said
stop.
lung biopsy and this is. So we investigate genetics based na hai, biopsy.
Of course, we
karna hai,
have to
sweat
go
test
for
karna hai.
sweat, I mean, genetics, not sweat test, but genetic studies for cystic fibrosis and immunological studies we would like to send. Primary immunological deficiency.
So this,
workup
I
I would
don't
like to
think
send.
this child fits into cystic fibrosis. I don't get liver involvement can occur, but I somehow, the way the history is starting at the age of 2 years, 7 months with 2 months history. First 2 years of life, this child was normal. Okay, so I would not think of cystic fibrosis in this child in the first place.
Absolutely.
So I would like to do a lung biopsy.
Yes. Alpha-1 antitrypsin.
Al-
The pattern is
Alpha-1.
more of an emphysema rather than this.
Yeah, and that's
In-
more in
reticular-
older kids
and
and
more
adults.
Before going lymph
Michael
biopsy,
Jackson.
non-invasive tests, sending blood for
I
genetic
think we are
tests.
running out of time. I'll give you the diagnosis. Any guesses from the audience? What is this? Anything seen before? What is this? Which tissue it is?
That looks like lung.
Bone marrow, liver, lung.
Some infiltrates are there, most likely to be. And these are some special stains here, some special histochemical stain here.
So I'll reveal what it is.
Why is it getting?
Yeah, pulmonary.
Okay,
Yeah,
so
so
which
you could
HNA
have
stain
the
and there
liver
is a S100
So
staining. and
histiocytes.
the final diagnosis pulmonary LCH.
Histiocytosis, Langerhans cell cyst.
Langerhans cell histiocytosis.
Langerhans cell histiocytosis. Okay, the learning points, miliary is a pattern and not does not always mean tuberculosis. More investigations like bronchoscopy and ball may establish or rule out diagnosis. In that, this child, we had done a ball spatial stains that were negative. Okay, so ball was sent for thinking of LCH in mind. We had sent ball for S100 staining, but that came negative. Okay.
Genetics
sometimes-
may not help you in all cases. The
Not help you,
problem
may
with-
help you. Yeah.
The problem with this is genetics may not help you. So special staining is the way to go for this child.
Lung
Yeah,
biopsy.
lung biopsy and special staining will
But
help you.
in pulmonology, genetics has helped to reduce the number of lung biopsies required. Would you agree there?
Yeah,
We can't go every time lung biopsy. It's a very invasive, but
Why
we are
did we
renewed.
do a liver biopsy in this child? We could have, it's an easier biopsy to do.
Absolutely. So thought process is why not liver biopsy and why lung biopsy? So whether this lung is involved because of the AKT, sorry, the liver was involved because of the AKT or liver was involved because there was a primary disease there. We are not sure. So how do we explain the parent that the liver injury, suppose if you do a liver biopsy, it comes negative and tomorrow you tell him to do a lung biopsy. Okay, it is a difficult situation. We thought of doing a liver biopsy, but then suppose if the liver biopsy comes normal, again, you will proceed for a lung biopsy. Might as well do from a place where you know where the primary pathology is there, rather than doing from, go from one place. Because both of them are invasive, I understand. One is less invasive, one is otherwise invasive, but still for them, it is invasive putting a needle into the liver. So we thought we'll do a lung biopsy and not a liver biopsy here. A lung biopsy, absolutely. So I thank all the panelists and we had a very steamy discussion and that's how it should be. Thank you so much.
थँक्यू परमात्मा. आम्ही पास झालो की नाही वाव्यामध्ये सांगायचं राहिलंय. Audience he has not given answers to us also, so आम्ही पास झालो की नाही.
So when
पास झालो की नाही? पास
when they
झालो
are-
की नाही?
when they, sir, when they allotted me the difficult cases in pulmonology session, no, many of the panelists left out. Okay.
Thank you, everyone.
Yeah, absolutely.
Thank you, everyone. I may now request Dr. Paramartha Chandane to please felicitate our panelists Dr. Indu Khosla, ma'am. Dr. Pratibha Patil, ma'am. And Dr. Prakash Vaidya, sir. Thank you, sir. I may now request our senior pediatrician, Dr. Shama Kulkarni, ma'am, to please come up on stage and felicitate our moderator, Dr. Paramartha Chandani, sir. Panel discussion on errors in parenting. I request our distinguished speakers, Dr. Renu Boralkar, Dr. Anil Raut, Dr. Shekhar Dabhadkar, and Dr. Sanjay Deshmukh to please come up on dais. I also request Dr. Jayant Pandharikar, sir, to please come on stage for moderating the session. Parenting is often overplayed than underplayed. I think most of us would agree on that. Children give us our first opportunity to prevail upon their conduct, their do's and don'ts, their social, intellectual, and emotional quotients. In short, we overpower them as if we are their rulers and they are our subjects. We do not even realize when we exceed our limits unless they turn a deaf ear to us. Let us learn these and other errors which we commit in parenting from my eminent panelist. Thank you.
Thank you, Doctor. Very warm good afternoon to one and all. At the outset, let me thank Scientific Committee of MAHAPEDICON 2023 and MAHAPE for inviting us to discuss on errors of parenting. When they asked me to speak on the parenting, I said parenting is too big topic to be covered even in 2-3 days conference. So why not limit it to the topic called errors in parenting? Then we had a topic named as errors in parenting. But later on we thought that the audience which we have, they are pediatricians. So why not to discuss the identifying errors in parenting in our day-to-day practice? So as a pediatricians, we should identify those errors and we should do counseling of those parents. So we have changed this topic that to identifying the errors in parenting. I have eminent panelists in the field of this parenting. We all know Dr. Shekhar Dabhadkar, who has conducted more than 700 programs in the Marathi, Salam Mulana Ghadauya, and he is a truly Baba of Maharashtra IAP, everyone knows. And I would say he's a grandparent in the field of parenting. Welcome, sir. Then we have another speaker, Dr. Anil Raut, who is practicing at Nagpur and EB member of, he was past EB member of Central IAP. We have Dr. Renu Boralkar, who is a EB member elect for 2023 of Central IAP, practicing at Aurangabad. Then we have Dr. Sanjay Deshmukh from Nagpur, who is a current EB member of Central IAP. So now, friends, what is parenting? What is good parenting? What is bad parenting? What is positive parenting? What is the negative parenting? What are all the parenting types are there? Everything, all questions come around with along with the parenting. Who are involved there in parenting? Is from what age parenting should continue? So Just before we starting with the identifying errors, I'll rush through this slide. So what is parenting? It's a process of raising and educating children from birth, of course, from conception till adulthood, and can last long beyond it. It means that really parenting involves everything under the sky as a parent. It involves everything, every care of a child in the family. So it involves all nurturing care. I think most of us must have gone through the module of NCECD, and all those 5 areas of NCECD, what they are basically meant for parenting. Now, it helps the child to make the overall development, physical, mental, social health, so as to make him fit in the society. Good parenting, it prepares children to meet all demands, challenges in this life. And these challenges are getting more and more as we are advancing. So who all can do parenting? Anybody can do parenting, no doubt. Biological parents, mother and father, grandparents, then the guardians, relatives, teachers, and of course, we doctors, we pediatricians, we make a lot of difference we can play a major role in the field of parenting. Now, from where parenting starts? Parenting starts right from conception till his child becomes young adult. Not only from conception, right from when the couple decides that they're going to plan the pregnancy or planning for to have a child. So from then parenting starts. Let me tell you, parenting is a continuous learning process by experience. असं कुठलंच पुस्तक नाही की जे सांगेल की असं असं वागा म्हणजे असं असं पॅरेंटिंग चांगलं राहतं. पुष्कळ पुस्तकं आलेत, पुष्कळ पुस्तकं गेलेत, but no one book can tell you that this is a right parenting. So ultimately, what is important is that we learn only by experience. Now, why parent? My question to Dr. Shekhar Dabhadkar, sir, why parenting is important from pediatrician's point of view?
Hello.
Hello. So good afternoon, everybody. I would like to coin one more term in these conferences, because we know Saturday night syndrome, but in conferences we should give term like Sunday afternoon syndrome, when attendance is very less. But still, I am very happy that at least few more people are there in audience. So thank you very much for coming this session. Why parenting is important? As ladies and gentlemen, you know, giving birth to a child it doesn't need anything. Producing children is natural instinct. चाहे कीड़ा मकोड़ा हो, कोई भी हो, नए बच्चे तो पैदा ही होते हैं, नई generation आती है. But what is more important, parenting in human beings, it is art and science. Unfortunately, as a parent, we are forgetting this art. And as a pediatrician, I would like to say, considering this attendance, we are overlooking this most important topic in pediatrics, that is parenting. Why parenting is important all the time? I all the time say that today we are seeing, open any paper, open any news channel or anything, crime rate is very high. And as said, high crime rate, when they were studied, it is said that this high crime rate is because of bad behavior in children in most of the cases. And why this bad behavior in children? Because parenting is bad. It is said that there are no bad children, but bad parents indeed. And that's why it is our duty. Suppose we want to diminish this crime rate in India, probably every pediatrician should know few major, as Dr. Pandrikar sir said, there is no perfection. Nobody is perfect parent, not even including me. But major mistakes should not be done. What are advantages of it is written everywhere there? I will not read everything. Empathy, honesty, self-reliance, blah, 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 blah. Cheerfulness. When I am in OPD, I can identify by looking a child that with how are the parents. By behavior of that child it is thermometer as such, and it gives barometer. It gives me indication that parenting is something wrong. So advantages are these. I will not read everything: empathy, honesty, motivation, desire to achieve, kindness, cooperation, and cheerful. For this reason, parenting is more important.
Yes, the parenting is very important to develop all the life skills in a child, so as to make him fit to meet out the challenges in his future life. Well, my question to now, Dr. Anil Raut, just define how would you just define the role of parents.
We know that couple become parent when they give birth to a
their child. Animal for centuries together, they are having their wards and they have basic instinct to rear their ward as a help them to survive. And the same thing is with the human being also. Over centuries, it has been evolved that as a much advanced animal on this planet, human being, they rear their children to make them independent to live in this world. So this is the role of the parent, but all over the world. But in our part of world, in particular in India, we take much more pains to rear our children and to give them identity in the world. So this is the definition of parent who are making their children independent and teaching them how to live in this world.
So every living being plays a major role in parenting. ती अगदी चिमणी असू देत किंवा छोटासा कबूतर असू देत, ते आपल्या पिल्लांकरता पूर्ण तयार करून ठेवतं before they lay the eggs. Or now my question to Dr. Renu Boradkar, what are some possible changes that come with being a parent?
Yeah, good afternoon, everyone. See, parenting is not a child's play, that we all know. So we need roti, kapda, makan, or paisa. So that is what every parent should have when they prepare for bringing out a child in this world. And also they should know the nurturing care, which we are going to tell in our NCCD to all of our parents in the schools, in the colleges, etc. So this is what the responsibility for parenting has to be.
My question, Dr. Sanjay, how can a potential parent prepare for this new role?
सर्वप्रथम गुड आफ्टरनून. खरं जेव्हा आपण गुड पॅरेंटिंग आणि बॅड पॅरेंटिंग बद्दल जेव्हा बोलतो, आणि मी सुद्धा जेव्हा लहान होतो तर माझ्या आईवडिलांनी माझ्याकरता काही रोल ठेवला होता, तर मी सुद्धा हा विचार करायला पाहिजे की जेव्हा मला माझे मुले झालेले आहेत तर मी सुद्धा तो एक गुड पॅरेंटिंगचा विषयाबद्दल माझ्या मुलांशी डिस्कस करायला पाहिजे. आणि त्याच्या भावना, त्याच्या आकांक्षा, त्याला काय वाटतंय हे जाणून घेऊन जर आपण प्रयत्न केला तर मला असं वाटतं एरर्स व्हायची शक्यता खूप कमी आहे.
Fine. So basically this role of parent is to help a child to develop his self-control. It's a gradual exchange of external regulation provided by parents for the internal regulation of the child. Because this internal and external regulations, they are very important as far as parenting is concerned. Now, this is a Galinsky stages of parenthood. Basically, it classifies into these 6 stages. One is a pregnancy period, that stage is called as image making, which begins from the conception. Then comes the stage of nurturing, which is from birth to 2 years of age, where the parent becomes emotionally attached to a child. Then third stage comes the authority, where this is for the age of 2 to 5 years, where the parents determine the rules and they clarify the role as a authority figure. The next stage of parenthood comes as a interpretive. This range from for the age of 5 to 13 years. But I would, this is a Galinsky has given these stages, but I would like to mention that now the overall adolescent age has gone down up to 10 years. So we should keep this age for age 5 to age 10 years. Here the parents is supposed to rethink his role as a parent and decide what knowledge, skills, values to be imparted to the child.
Dr. Pandrikar, don't you think that parenting or thought of parenting should, you said pregnancy, but before conception, thought of parenting should be there?
Yes, sir. This is what Galaxy has a stage mentioned. But of course, we have mentioned that even before the conception, that can be done. Then next comes is the interdependent. This is the most important stage period because here this parenting phase for adolescents, and nowadays is because we are getting so many the psychological problems, behavioral problems, conduct problems in adolescents. That's why probably this parenting is getting more importance. So here, as a parent, we are supposed to establish their boundaries, find disciplinary methods appropriate for that age of the teens and appropriate action for the teens. And last is a stage of departure, where child leaves home at around, say, 18 years or so. And here, parent is supposed to sit down and evaluate his parenting. So these are the Galinsky stages of parenthood. So now with this, we should know that why parenting is very important, because the various psychological studies have proved that almost 87.3% parents, they perceive that pediatricians are the helpful professionals. That's why this topic is chosen for our discussion. And of course, we pediatricians have a special status in society. It's our responsibility. All the time, parents, they come to us for various problems of a child, and we must identify those errors whenever we can find out. Now, why pediatricians should know parenting in one line?
Can I,
Yes,
previous
please.
slide, just one comment. There is very good saying in Hindi. हमने कांटों को भी नरमी से छुआ है, लेकिन लोग बेदर्द होते हैं, फूलों को मसल देते हैं. So whenever I talk with pediatrician, I all the time say that we handle children in very nice way, none other branch. And that's why we have special status in society. Why pediatricians are more important? Because they come in contact with parents when their child is developing. And when at that time we give advice, probably it will make some difference. So this is the most important. Special responsibility, everything Dr. Pandrikar told.
Thank you, sir. Sir, why pediatricians ignore such important aspect of parenting? My question to you, sir. Because every time, we all are busy in our office practice dealing with the physical elements, but rarely we do spend some time for this parenting
I all
aspect.
the time say why I'm interested in why I'm taking interest in parenting. There are so many cases coming to me, and nowadays attempt of suicide and one successful suicide I have noticed in my practice. You may be very busy pediatrician, no doubt, but a word for parenting should come from mouth of every pediatrician. More patients, less time. I don't know how people see 150, 200 OPD per day. Sir, Aditya, get that slide?
Yes.
More complicated patient. I know, because more complicated patient will generate more revenue generating options like vaccination, like NICU, like PICU, but parenting is the most neglected branch. All the time I say, more apathy for such less important. This topic is very important, parenting. Every pediatrician should inculcate this habit. No instant results. Of course, मी जसं mentally retarded childच्या बाबतीत मी म्हणतो की त्यांच्यावर आता काम करणं म्हणजे झाडावर बी लावण्यासारखं आहे. And less knowledge, least awareness, because we are not aware, and that's why we don't indulge. And non-rewarding business, no revenue generation, and that's why pediatrician never take interest in this fundraising तो कुछ नहीं हो सकती इसलिए. We should change our habit.
Yes.
Even we can see that all the other club, Rotary clubs and everything, they are going for parenting workshops. I don't think parents listen to them. If we pediatricians come forward and give lessons in parenting, probably it will be a most important to happen.
And that's why I must thank organizers to keep this topic, because even if you go through the Nelson's textbook of pediatrics, even the latest edition would give just a few lines about parenting, because parenting is such an important topic. Still, it is not mentioned as parenting in these textbooks. Probably they understand it more as an art and less of a science, but it's a science, art, and I will say commerce also, because if you have if you impart a good skills to the child, definitely it's going to help you the commercial aspects of your family also, financial aspects of your family. So with this, now we start with case scenario, and I request Dr. Neha, who is a 12-year-old girl, and I request her to have a role play and enact here. Dr. Neha, please. It's a mic, those. She's going to enact. Mic those. And we have these 4 parents. Let us see how they react to this 12-year-old girl, Neha.
Hello, Mama, Papa. I am so excited. आपको मालूम है आज मेरे सारे friends हम लोग सब जा रहे हैं रेस्टोरेंट में डिनर करने और उसके बाद सेकेंड हाफ मूवी. Wow, I am so excited और मुझे जाना है.
So I request first parent, Dr. Dabhadkar, sir.
Grandparent बोलो बोले.
Sir, please enact as a parent, not grandparent.
ये देखो रिंकू कि these days are very bad, you cannot go, you should not go. और ये क्यों मैं बोल रहा हूँ करके समझ में आ गया? आज जाने का नहीं है.
नहीं मुझे जाना है.
No, Rinku, this.
I want to go. मुझे No, I want to go.
I will not allow you, Rinku, because जो मैं बोलता हूँ ये करंजे जो मैं बोलता हूँ ये यहाँ पे होना चाहिए. आप नहीं जा सकती इसका मतलब नहीं जा सकती. आज गेस्ट आने वाले अपने पास कुछ प्रोग्राम है और you should not go to movie and moreover you should not go with your friends. No, I will not allow you. No. No.
Okay. Next parent, Dr. Sanjay Deshmukh. Please, you can enact here. This is role play.
वाव, काय छान आयडिया तुमची. आणि तुम्ही आउटिंगला चालला आहात, रेस्टॉरंटला चालला आहात, अरे वा, आणि लेट आउट मूवी, खूपच छान. जे बेटा एक काम करशील, जाताना पैसे घेऊन जा, आजकाल खूप पैसे लागतात, खर्च होतात. एन्जॉय एन्जॉय, खूप छान, जा जा.
Thank you. Third parent, Anil Raut.
अरे मनसुख भाई, पेमेंट नहीं आया अभी तक. काय चाललंय तुमचं? अरे काय काय म्हणते काय तू रिंकू? अरे साधना आहे की काय म्हणतो? तुला सांगितलं रिंकू, मी हे छोटे मोठे प्रॉब्लेम फक्त आयचे डिस्कस करायचे, मला वेळ नाही. रिंकू, अरे मनसुख भाई, शाम तक पैसा मिलना जरूरी है. हाँ, बोल रहा हूँ मैं.
And now fourth parent, Renu Boradkar.
नेहा, अरे वाह, तू पिक्चरला जाणार आहे? कौन सा ऊंचाई क्या? हाँ, वो अमिताभ बच्चन का जो रिलीज हुआ है.
yes.
अरे वाह, त्याचे रिव्ह्यूज खूप चांगले आलेत नेहा. पण आज आहे ना ते जयकुमार काका आलेले आहेत आपल्याकडे. आता कॉन्फरन्स आहे ना, आणि मागच्या वेळेस आपली भेट झाली होती बघ, तुला आठवतं का अलिबागला? यू लाईक हिम व्हेरी मच टॉकिंग टू. आणि ते गाणं पण खूप छान म्हणतात, आणि तूही गाणं म्हणते. अगं मी विसरलेच तुला सांगायला, सकाळी त्यांचा फोन आला होता, त्या संध्याकाळी आपल्याकडे जेवायला येणार आहेत. तर मग तुला आवडेल का त्यांना सोडून जायला? तर मग आपण एकत्र जेवण करायचं का आज त्यांच्या बरोबर आणि मजा करायची का? आणि मला असं वाटतं ना नेहा, की ही जी पिक्चरची आणि जेवायची आयडिया खूप छान आहे. तर तू, मी आणि बाबा काय करू, परवाच्या दिवशी रविवार आहे की नाही, तर मग त्या दिवशी आपण मस्त जेवण करूया बाहेर जाऊन, कुठलं तरी नॉनव्हेज तुला जे आवडतं ते. आणि मासे वगैरे तर तुला मस्तच आवडतात. आपला तर कोकणाचा एरिया आहे, तुला माहितीच आहे. तर मग आपण मासे खाऊया आणि मस्त ऊंचाई पिक्चरचं जाऊन मस्त एन्जॉय करू.
Thank you.
माझी डार्लिंग.
Please give a big round of applause to our special guest appearance, Dr. Neha. So friends, just enumerate what was the first type of parenting by Dr. Dabhadkar. Yes? Authoritarian. By second, Dr. Sanjay Deshmukh. Permissive. Then third, Dr. Anil. Negligent. And last, it's authoritarian. So we all know what is authoritarian, what is permissive, what is neglecting, and what is authoritative. So now tell me, which one is the best parenting? Is it best always? So what is best parenting? It's a blend of parenting as per the situation, as per the age. This parenting you have to change accordingly. No doubt, while looking at this particular role play, we feel that Renu, that parent is very good because it's authoritative. So my question to, can parenting be made at same at all ages? No, it varies. And most important question is, can parenting be same for both sexes at all ages? Question to audience. Why not? Why gender bias? My question is, can parenting be same for both sexes at all ages? It should be ideally, but does it happen practically? आपण मुलीला म्हणतोच ना, ए तू मुलगी आहे, तू 9च्या आत घरात येऊन जा बरं, मुलाला काय तू भटकत राह, काही हरकत नाही, असं म्हणतोच ना. So theoretically it's okay, but practically it varies. Well, why parenting today is different than previous years? Why parenting is different today than previous years? Yeah, situation is different, and because of so many social media and that's why. Yes.
There are so many reasons, sir. Social media to high, no doubt about it. But changing family pattern, industrialization, both parents are working. There are so many reasons, and that's why look, all the time people ask me why this lecture is important. पहला जमाना कुछ अलग था, आज का जमाना बहुत ही अलग है. अपने वक्त कुछ पब पार्टीज नहीं थी, कुछ नहीं.
सर मेरे वक्त नहीं, आपके वक्त अलग होंगे.
So that's why parenting is really very important nowadays.
Okay. So friends, there are these are the 4 major types of parentings which Diana Baumritt has suggested in way back in 1966. But later on, so many other psychologists, they came up with different types of parentings, and they named after it like helicopter parenting, free range parenting, attachment parenting, dragon parenting, and so many types out there. It's just like the story of blind and elephant. प्रत्येकाने एक वेगळ्या त्याची एरर काढली आणि त्याप्रमाणे तसं त्याला नाव देऊन दिलेलं आहे. So I not go into details of these different types of parenting, and of course the list is endless. So now parents should not make a major mistake that they should prepare the child for the road and not the road for the child. This is the most important take-home message I would like to give here. And you must give this message to your parents. Coming to case scenarios, let me tell you, there are so many errors at all ages. What we have decided, we'll take up 4 errors in the age group from 0 to 9 years and 4 errors in the age group from 9 to 18 years. So we'll discuss first 4 major errors from 0 to 9 years. My case to Dr. Renu Boradkar. 5-year-old Raju comes to OPD for cough and cold. Doctor noticed that he's not stable, just moving around, lifting his pen, stethoscope, weighing machine, and he throws mother's mobile. He's very hyperactive and talks continuously, even at school, home. His mother has added to that history. Parents say, otherwise he's okay. कोई फर्क तसा चांगलाच आहे तो, बाकी सारखा चांगलाच आहे, फक्त थोडासा उत्साही आहे, असं पॅरेंट्सचं म्हणणं आहे. So this is a case with before you, Dr. Renu.
Yes, sir. According to the case, what we see is that actually it is a case of ADHD as our clinical diagnosis. We will not go into the scientific details about it, but this patient has also come to me 3 to 4 months back when I have consulted. मी त्या आईला सांगितलं होतं की हे बघा त्याला आहे ना डेव्हलपमेंटल पिडियाट्रिशियन कडे घेऊन जावं लागेल, तो इम्पल्सिव्ह आहे, हायपर ऍक्टिव्ह आहे. तर त्यावेळेस त्याच्याबरोबरची आजी म्हणाली, नाही नाही हो, त्याचे बाबाही असेच होते आणि नंतर शाळेत जायला लागला तर तो एकदम नॉर्मल झाला आणि आमच्याकडे ना अशी पद्धतच आहे. तर these are the wishful thinking that the parents say. They are not at all listening to the doctors. Actually डॉक्टर्सला राईट टाइम आणि राईट ह्याला जर का पेशंटला पाठवलं डेव्हलपमेंटल पिडियाट्रिशियन कडे, तर त्याचा अर्ली जे थेरपी लागेल, बिहेवियरल इंटरव्हेन्शन किंवा काय, तर दॅट विल बी हेल्पफुल फॉर द चाइल्ड. But all will be well. That is what the parents think. And as part of the pediatrician, that error sometime can happen in the busy practice. Sir म्हटले की 100 ते 150. पण असा जर का चंचल मुलगा असेल, मला नाही वाटत की कोणी pediatrician will miss it. Also, sometime there might be a lack of awareness, especially in the just 1 year before 0 to 1 year, where the developmental changes are taking place. So we should have the MCP card as well as we should do the M chart at the age of 16 to 30 months that is given in our nurturing module. So this is what is we have to be, and the pediatricians should be aware and they should refer and have a proper communication skills to convince the parents to go and take the therapy.
So the error here is that parents, they are not accepting the facts. So as a pediatrician, it's our duty to make them aware that this is the fact and you have to accept it. And now we are referring it to developmental pediatrician. Please go there. So this is an error on the part of parents. Now next case scenario to Dr. Sanjay Deshmukh. 9-year-old Kunal tells his doctor that he's not allowed to go to school alone, to his friend's house, to market, and even to playground. He's fed up of his mother, who all the time accompanies him. What is the mistake? And what happens if parents are too much protective?
खूपच कॉमन गोष्ट आता आजच्या युगामध्ये आहे ही. आणि तुम्ही जर ह्या मुलाची हिस्ट्री पहा, कुणाल जो मुलगा आहे त्याला प्रत्येक ठिकाणी त्याची आई जी आहे जात आहे. दिस इज टिपिकल बिहेवियर ऑफ ओव्हर प्रोटेक्टिव्ह पॅरेंटिंग. आणि आपण म्हणतो अति तिथे माती, ते व्हायला नाही पाहिजे.
सो डज इट मेक हार्म?
याच्यामध्ये प्रॉब्लेम असा येतो की जेव्हा ओव्हर प्रोटेक्शन राहतं, तर आई वडिलांची इच्छा असते की आपल्या बाळाला काहीच व्हायला नाही पाहिजे. दे वॉन्ट टू ही शुड बी इन द ऑल कम्फर्ट झोन. आणि त्याच्यामुळे काय होतं, त्याचा स्वतःचा विकास होत नाही. सेल्फ त्याचं जे आहे इस्टीम कमी होतं. त्याच्यानंतर ओव्हर प्रोटेक्शनमुळे तो सुद्धा पॉझिटिव्ह होऊन जातो. ही मेक शो सम अग्रेशन ऑल्सो.
And even it can lead him to narcissism also.
सर डेफिनेटली जर तुम्ही खूपच ओव्हर प्रोटेक्शन केलं तर मग ते इतके सेल्फ सेंटिव्ह होऊन जातात, पण त्यांना कोणतीही गोष्ट त्यांच्या अगेन्स्ट जर गेली तर ते त्यांना आवडत नाही. त्यांना असं वाटतं मीच मोठा आहे, माझंच चांगलं व्हायला पाहिजे, आणि थोडं जर वाईट काही झालं तर दे विल नॉट गेट दॅट इन अ पॉझिटिव्ह वे.
Fine. So what is the error is overprotection. So don't overprotect your child. No doubt, as a parent, we are supposed to protect, but don't overprotect the child. And if you find your parents are doing this mistake, please point it out there and there only. Now, these are routine case scenarios. Aarti, mother of 6-month-old killed. Mother says that this is a 6-month-old child with weighing 7 kg. She's worried as her friend's 5-month-old child is 8 kgs. Sapna has beaten her 8-year-old son for securing 3rd rank in the school exams. Sanjay bought a new cycle for his son costing 3 lakhs And let me tell you this story. Just few months back only, it has appeared in Times of India and India Today also. That mother poisoned her son's friend was topper. Yes, this is a story. This is a real fact. This is a real story which has occurred. So my question to Dr. Anil Raut, how to identify these parents and what are the parenting mistakes in these particular case scenarios?
These are the parents who are competitive parents. This is the new age parenting. It started in bigger cities, first in Western countries. Now it has percolated to taluka places also. No doubt, every parent wants his child to be a first in his class, but these parents, they want their child to be first everywhere. म्हणजे अभ्यासात तर पहिला आला पाहिजे, त्यांनी गिटार वाजवलं तरी त्याला सगळं आलं पाहिजे, त्याला स्पोर्ट्स मध्ये पण पहिलं आलं पाहिजे. So this sort of parenting, this competitive parenting, you can see that लहान KG1 च्या मुलांची रेस असेल तर त्याचे आई बाबा दोन्ही पूर्ण ट्रॅकसूट घालून धावायला पळत येतात, ट्रॅकवर धावतात. So this sort of parenting is also harmful, which is competitive. These parents, they feel particularly seen in middle to higher group age parents who are working and they want their child to be first. They are competing with the child, they are competing with themselves, they are competing with the other parents also. And that's why most of the time it is very difficult, situation is very difficult. And these are seen where particularly in middle class, upper middle class, where nuclear families, both the parents are working, staying away in the big cities. Then there is media hype all over. इथे पहा तिथे पहा सगळ्या स्कूल मधला टीचर मधला हिरो सगळीकडे पहिले येतो, तसाच आपला मुलगा झाला पाहिजे. आणि they have high expectations from their children.
Well,
so this is competitive parenting. This is also very bad.
So as a pediatricians, we must identify this type of mistake in our office practice. If parents all time tell that या मुलांनी असं केलं आमचा मुलगा बघा असाच आहे, तो I must tell that you must identify this type of parenting and discourage this mistake of this parenting. Now case scenario to not grandparent, a parent, Dr. Shekhar Dabhadkar sir. In spite of many warnings, Ramesh, a 6-year-old boy, came home from school very late. His uniform was torn, he was very dirty, he was very dusty, had minor injuries on leg and missed his few notebooks and compass box. His mother could not control his temper and he was beaten a lot. He was brought to you for treatment of minor injury. There were marks of slapping. Child was looking very nervous. Apart from treating injuries and other physical ailments, what will you do from parent's perspective?
So overall, this case scenario says that probably mother punished that child very badly and baby had injury. So I would like to ask you whether mother was correct or not. Not correct. So what she should do? Punishment in other way. Okay, okay. So in this scenario, I would like to say, rather than talking theoretical details, spare a minute with parents that punishment, whatever you have done, corporal punishment, no, physical punishment. Nowadays, it is said that it is very bad and you should avoid. There are another ways of punishment, like taking away priorities of the child or a timeout method. I will not go in detail, but these are different punishments. So these punishments are really important for behavior modification. I would like to tell माझ्या औरंगाबादचे मित्र इथे आहेत. औरंगाबादला मी एकदा भाषणाला गेलो होतो. देवडे नावाचा आपला मित्र आहे आणि मग तिथे पनिशमेंट बद्दल मी बोललो तर आमचा देवडे बाजूला बसला होता. म्हणा दाभाडकर काय सांगतो, माझ्या वडिलांनी मला एक कानाखाली मारली आणि नंतर मी खूप चांगला झालो, माझं बिहेवियर सुधारलं पूर्ण भाषणात. बट लेट मी टेल यू लेडीज अँड जेंटलमन, पनिशमेंट केल्याने एक जी व्रण उमटतो मुलांच्या मनावर, हा अत्यंत वाईट आहे आणि तो आयुष्यभर राहण्याची शक्यता असते. चिल्ड्रन मे टेक रिव्हेंज, either revenge with parents, revenge with society. So these ways should be changed. And what is more important is discipline. We will not go in theoretical details as such, but discipline is more important and you should disciplinize your child. पण हे लक्षात करताना, मुलांना शिस्त लावताना एक लक्षात ठेवा की चिल्ड्रन आर युअर मिरर इमेजेस. त्यांना शिस्त लावताना तुम्ही शिस्तीत आहात का नाही हे बघा. त्यांना उशिरा घरी येताना मारण्याची तुम्ही वेळेत ऑफिस मधून घरी येता का नाही हे बघा. आणि ह्या सगळ्या गोष्टी आणि जसं आपण पॅरेंटचे वेगवेगळे प्रकार पाहिलेले आहेत, त्याप्रमाणे व्हॉट इज मोर इम्पॉर्टंट, रेणू इज द बेस्ट पॅरेंट विथ बेस्ट ऍक्टिंग, दॅट इज डिफरंट स्टोरी. पण
Yes,
हा
sir.
जो पॅरेंट आहे ह्याच्यासारखा
Okay.
अप्रोच ठेवा. सर पुढे.
So the take home message is that punishment.
पनिशमेंट केल्यापेक्षा पनिशमेंटची भीती असणं मुलांना खूप इम्पॉर्टंट आहे. कारण छोट्या कारणासाठी तुम्ही 30 पनिशमेंट द्या आणि मोठ्या कारणाला 30 पनिशमेंट द्या, तर तो रिबेलियस होतो. त्याला माहिती आहे की एवढंही केलं तरी 30 पनिशमेंट.
I think
पनिशमेंटची
Dr.
भीती राहणं इम्पॉर्टंट आहे. दॅट इज डिसिप्लिन.
Yeah. So the physical punishment should be avoided.
हल्ली मुलांना कोणाचीच भीती नाही वाटत, आई वडिलांच्या डोक्यावर बसलेले आहेत म्हणून. दॅट मे बी वन ऑफ द रिझन.
I think I request Dr. Shama madam, she wanted to add something. Please.
Hey madam, hey.
Mike.
Somebody.
As the history was describing, listen to the child because the child might be victim of bullying. So instead of punishing or beating him, you should find out whether he was a victim.
Well, so the
Frankly, madam, this was real case in my OPD. तो जो मुलगा होता तो फुटबॉल शिकत होता, त्याला फुटबॉल शिकायचं, फुटबॉल प्लेअर व्हायचं होतं, पण आईने त्याचं कधी ऐकलं नाही आणि मग ती पनिशमेंट दिली. चलो डिफरन्स.
So the parenting, if rules without relationship, you get rebellious behavior. Relationship without rules, of course, is going to chaos. But relationship with rules is equal to respect plus responsibility. So this is a most important take-home message. Now, these are the effective punishment should include these 6 things. I would avoid this slide. Now we'll switch on to the next age group, that is from 9 to 18 years. So before that, let me tell you why we are classified between these two age groups. We all know the development of limbic system is earlier than the prefrontal cortex. We know the functions of prefrontal cortex, we know the functions of limbic system, and this is the slide. And now I'll straight away go ahead with the case scenarios. My first case to Dr. Renu Borakar, a 13-year-old Yash, parents brought for complaints of not listening to them. He's back answering, going to late night movies. His mobile has bad pictures and porno pictures. His friends are not good. We keep him so much watch on him every time, but still he's not listening to us. Why? It's parents' concern.
Yeah, sir, the history is saying itself that parents are the spying, snooping, detective parents, and it is not good for that child. And that is the most important error in this parenting, which has to be, these parents are very suspicious parents, over possessive. They want to know everything what the child is doing. त्याच्या मोबाईल मध्ये काय, त्याच्या कपाटात काय, त्याच्या काही लव्ह लेटर आहे का. त्याच्या मागे एक तर माझी मैत्रीण अशी होती की तिची मुलगी जेव्हा मॉलमध्ये तिच्या मैत्रिणींबरोबर बर्थडेला गेली 12 वर्षाची, तर ती मैत्रीण जाऊन बसली त्या दुसऱ्या एका टेबलवर आणि बघत होती की हे मुलं मुली काय करतायत म्हणून. म्हणजे इतकी जासूसी करायला. तर वेदर इट इज रिअली नीडेड. सो व्हॉट इज दिस थिंग? ऍक्च्युअली इट इज रिअली द लॅक ऑफ कम्युनिकेशन बिटवीन द पॅरेंट अँड द चाइल्ड. आणि तुमचे मुलं खूप हुशार आहेत या पिढीतले. तुम्हाला वाटतं की टेक्नॉलॉजी तुम्हाला माहिती आहे, पण तुमच्यापेक्षा जास्त हे सोशल मीडियाची हँडलिंग आहे ते आपल्या पोरांना माहिती आहे. अँड दे कॅन रिअली कॅच यू की व्हॉट यू आर लुकिंग ॲट, whether you are seeing their Insta or Twitter or whatever, WhatsApp or their phones. So they catch you. आणि हेच मुलं मग नंतर सिक्रेटिव्ह होतात. They become introvert. They don't want to share anything with their parents. आणि मग म्हणून मग असे पालक साठी ते रिबेल करायला लागतात. अँड दिस पेरेंट्स कम टू यू. यू हॅव टू काउन्सिल द पेरेंट. ती प्रॉब्लेम आधी त्यांच्यामध्ये आहे, तो आपल्याला जाणून घेणं आणि त्यांना माहिती करून देणं. असे पेरेंट्सला कन्व्हिन्स करणं इज व्हेरी व्हेरी डिफिकल्ट. यू हॅव टू गिव्ह मच टाइम टू द पेरेंट्स, माय डिअर फ्रेंड्स. आणि मग त्या मुलाला घ्या काउन्सिलिंग मध्ये. अँड देन बोथ द थिंग्स हॅज टू बी हँडल्ड केअरफुली.
So the spying is very common mistake by parents, especially the adolescent age. No doubt they should keep a watch on their child's activity, but not every time and going through their phones or everything. So even if they are watching it, the child should not know that they are watching him. Now, next case to Dr. CSD, I mean Dabhadkar sir. Sir, Rohini, a 14-year-old 9th class student, her mother observes that she's not talking much for last 2 weeks and there are mood swings. She likes to sit alone. After asking reasons, she weeps and keeps mum. Worried mother contacts her classmates and reveals that somebody, probably driver, has misbehaved with her 2 weeks back. Suspecting something awful, she contacts you as a pediatrician without talking to her for your opinion. She starts blaming her for her behavior, her hairstyle. माझी मुलगी अशीच राहते, अशीच वागते, तिची हेअरस्टाईल अशीच आहे, ती अशीच कपडे घालते. कदाचित त्याच्याचमुळे ती जबाबदार असेल. So this was the case scenario. How will you manage? What will you do?
Of course, only 3 minutes are remaining. I will not take much time. It goes without saying that some abuse is there, physical abuse, maybe sexual abuse. So what you will do, how you should talk with parents. You need some seniority, not seniority, I say, but some skill to talk with parents. Probably this is this. What probable cause of such behavior? As I said, what clinical examination and investigation we should do. As a pediatrician, frankly speaking, we are not well versed with such examination, and you can take second opinion from either gynecologist or a physician for all these things. Whether we should reveal results to parents? Yes, if it is serious sexual offense, then you should take parents into confidence and you should tell everything to the parents. Where you should refer, should we inform police? If don't inform police, what are consequences? Yes, you should refer, you should inform police immediately. And if you don't inform, you may face some legal consequences. So it is mandatory, POCSO, and it is very mandatory that you should inform police. And so that's that. But ladies and gentlemen, let me tell you one thing, that child abuse is increasing to a great extent, maybe 25%. And it is said that 50% children may reveal at old age. So remember, and if you don't interfere immediately, child may develop a lot of problem in future. So as far as physical abuse and child abuse, you should take these things very seriously.
But the parental mistake in this case is this mother has not communicated properly with the child. तिने त्या मुलाला घेऊन बसायला हवं होतं मुलीला आणि तिच्याशी बोलायला हवं होतं, तिच्याशी डिस्कस करायला हवं होतं की बेटा काय झालं काय नाही झालं. दिस क्लिअरली शोज दॅट की त्या दोघांमध्ये कम्युनिकेशन गॅप आहे, तर ही आपण अवॉइड करायला पाहिजे. सो टेक होम मेसेज इज दॅट पॅरेंट शुड कम्युनिकेट ऑलवेज विथ द चाइल्ड. नेक्स्ट केस इज 16-year-old boy brought by maternal aunt. He needs medical certificate as he hasn't attended classes since 2 months. Boy has having shabby clothes, hair, no eye-to-eye contact. He's having old injury marks. The parents are separated. This is in a head SS history, and his child lives with the mother who is working. My question to Dr. Anil Raut: so what are the parenting mistakes, or how will you evaluate this case?
These sort of parents we call the negligent parents, which is not so common in Indian scenario. आपल्याकडे सध्या आतापर्यंत एवढं जास्त याचं हे नाही आहे. But we see it in the parents who are separated, who are having some dispute. अशा parents मध्ये तुम्हाला अशी condition दिसू शकते. But most important thing is that only lack of care is also one of the negligent part. Parents, they both are working in this new era, आणि त्यांना बाळाच्या स्कूल मध्ये पेरेंट मीटिंग अटेंड करायलाही वेळ नाही मिळत. So that is also one of the most important negligence which starts from this. तर त्यांना तुम्हाला असं सांगावं लागेल की this is what you are working for your children, and then if children require your presence at any time, then you have to take out time. So neglected parents, though not so common in our community, but with more and more society going forward, probably we'll get such cases, particularly seen in separated parents who are having disputes.
So here mistake is a negligent parent. Probably the case is here the mother is the only single parent. So there might be many other factors. If you go through the headesses, that's a neglected error here. I'll take just 5 minutes, please, organizers. Next case to Dr. Sanjay Deshmukh. 15-year-old Mayuri brought to doctor for non-specific complaints like not ill, reduced appetite, not listening to her after her 10th standard results. Mother complains that she has secured good marks in the 10th standard and still she wants to go for arts and not for science. Her headess's history reveals that her mother wants to join her singing and swimming, but she likes dancing and badminton. She's never allowed to wear a dress which she likes, but every time she's asked to do what her mother likes. So she feels very much depressed and she has lost interest. So my questions to Dr. Sanjay: how will you evaluate this case from parenting aspect? What is the parenting mistake here, and what are the consequences of this type of mistake?
आता आजच्या मॉडर्न युगामध्ये जसं म्हणतो ना, घर घर की कहाणी, या केसमध्ये तुम्ही पहा, ती त्या मुलीच्या ज्या इच्छा आहे आणि तिच्या आईच्या ज्या इच्छा आहे त्या कुठंच मेळ खात नाहीये. आणि हे खूप कॉमन झालेलं आहे. आपल्या इच्छा आई वडील आपल्या मुलावर थोपवतात आणि तिथंच कम्प्लीट होऊन जातं. आणि हे जसं आपण म्हणतो की आपल्या आई वडिलांना वाटतं की माझे लहानपणी मी हे स्वप्न पाहिलं होतं की मोठा बॅडमिंटन प्लेअर व्हावं किंवा मी इंजिनियर बनावं की मी डॉक्टर बनावं, आणि तेच आपण आपल्या मुलामध्ये करायचा प्रयत्न करतो. आणि मग याच्यामध्ये काय होतं, त्या मुलाच्या इच्छा न लक्षात घेता यू एनफोर्स, म्हणजे तुम्ही फोर्स करतात तुमच्या आयडिया त्यांच्यावर, आणि दिस इज ए फोर्सिंग ऑफ देअर आयडियाज ऑन देअर किड्स. आणि हे याच्यामुळे प्रॉब्लेम काय होतोय की अशी मुले जे आहे ते आयदर डिप्रेशनमध्ये जातील, त्यांना लो सिस्टीम राहील, दे मे रिबेल, त्यांचा स्कूलमध्ये ट्रबल होईल, की तुम्ही ज्या आयडिया तुम्ही टाकता आहेत त्याच्यात ते एक्सेल करणार नाही. मग पुन्हा पॅरेंटला रागवतील, बा तुला मी टाकलेलं आहे, आम्ही एवढे पैसे खर्च करतो, मग तुम्ही काहीच करत नाही आहे. So the parents need to understand the desire of their kids, and they have to encourage them to follow their dream.
Yes. Well, here let me tell you that adolescence is an age of autonomy, identity, experimentation, and exploration. These are the main four major features of the age of adolescence, and parents must understand that child might be having some experimental phase, so they must allow it, and they should not force every idea every time to the child. So this is a take home message. Well, so the role of pediatrician in parenting is, apart from routine physical examination, immunization, regarding the counseling for the safety, security, fitness, nutrition, everything. These are the 5 main components of nurturing care of every childhood: that good health, adequate nutrition, responsive parenting, early opportunities for learning, and safety and security. So as a pediatrician, we must tell them in office practice. How we can do this? We can do this by parent education in OPD. We can do this by public talks on parenting. We can do this by group discussion on parenting in our OPD itself. We can discuss this with teachers and school management, because teachers are the you can say daytime parents for the child, so they can very easily pick up any problem with the child. We can do this by parenting sessions on social media, TV, and everything. Of course, we can do this in conferences. I must thank once again organizers. Probably very rarely this type of topics are discussed in the conferences. And parenting sessions must be done for special childs. Those who are special child, for them separate parenting session should be conducted. And of course, most important is that skilled building sessions for life skills must be conducted in all schools. That is the most important. This is how we pediatricians can play a major role. So it's not why you do for you what you do for your children, but what you have taught them to do for themselves is very important, because that is going to make him a successful human being. I'll not go to the slide because it's just rush to these slides. Most important is the communication. All those mistakes will find communication is the base of every parenting style. If you lack in this communication, definitely we are going to create some get some problem in the child, maybe at below 9 years or above 9 years. So more so after 9 years of age. So these are the do's and don'ts of communications. We must keep it simple, understandable. We must share the facts with them, use proper terminology, and be relaxed while doing. Most important is have an open-ended discussion, open-ended questions. Don't never laugh at them or giggle nervously. Whenever they are asking some question, never laugh at them. Don't roll your eyes, and of course, stop the close-ended questions. We all make mistakes, but we have a chance to change for the better, and we can do it from just today only. So now, my last slide.
Just one thing I want to add. We as a pediatrician are a bridge between these parents and
Yes,
adolescents.
of course.
आपण एक दुवा आहोत. So that is what we all should take home this message.
Yes, and health includes definition of health includes physical, mental, social. It's not only the physical health. We as a pediatrician take care of mainly physical health in our OPD practice.
Yeah.
So now, sir, 2 messages for our audience. First, Dr.
Excuse me, sir.
Sir,
Sir, it's my honest request.
Yes,
Please
just last
stick to the
slide.
timeline.
Yeah.
Last
please.
slide, ma'am, 1 minute. Ignoring the kids and their problems, neglecting to fix the problem, and always saving or overprotecting the child.
2 messages.
Poor pampering is dangerous because nowadays they have one single child norm is there, and that's why over pampering is seen in the society. That should be avoided.
Next.
And every child is unique. He has got his own potential. You should not have high expectations from your child, which he can't deserve. Then you have to set the limits and you have to follow the limits. सकाळी 6 वाजता उठून चालायला जायचंय, एक्सरसाइजला जायचंय, स्पोर्ट्सला जायचंय, तर तुम्ही पण उठला पाहिजे. So these are the things which has to be meticulously followed by the parents.
Sanjay, please.
Not addressing or neglecting their demands every time, that has to be taken care. Being inconsistent, हे तुम्हाला खूप महत्वाचं आहे. कन्सिस्टंट राहणं जरुरी तुमच्या जे काय rules and regulation आहे. And neglecting to make accept changes as per the situation, that you have to taken care.
Dr. Shekhar sir, last 2 messages.
Last one. I think that communication is most important. You should know how you should communicate with parents, and parents should know how to communicate. In Marathi, it is called as samvad, susamvad. Unfortunately, susamvad तो होतच नाही, पण बऱ्याच फॅमिलीचे कुसंवाद होतो. And they come to you. They will not go to psychiatrist. They will not go to psychologist, because as Pandrekar sir put up the figure, 87% parents will believe you, and they need some advice from you. So believe that you are advisor for this good parenting. And second,
Sir,
communication. And
Sir, most
last-
important message, failing to lead by example. तुम्ही काय स्वतः, you should be their role model. So whatever you are doing, the child is going to.
It is said that children are mirror images of their parents. बोले तैसा चाले त्याची वंदावी पावले. तुम्हाला जर वाटत असेल तुमच्या मुलांनी चांगलं वागावं, अभ्यास करावा, तर तुम्ही काहीतरी घेऊन बसा. तुमचं वागणं, तुमचं बोलणं, तुमचं वर्तणूक ही इतकी चांगली पाहिजे की मुलं त्यांच्यापासून शिकतील. मुलांना शिकवण्याची गरज नाही. विच इज रिअली डिफिकल्ट की मुलांसमोर आदर्श निर्माण करणे, पण तुम्ही त्यांच्या आदर्शात तुमची
Yes.
वागणूक ही सगळ्यापेक्षा आदर्श पाहिजे असं पालकांना सांगत राहा.
Yes, thank you, sir. So this is the last slide. Take home messages for our delegates. So conduct and behavioral disorders, sexual and substance abuse in children, adolescents, they are on steep rise due to globalization, internet use. Lack of good and positive parenting is a root cause for this same. Pediatrician is the first resource person for parents to discuss. I know pediatrician is very busy in office practice taking care of physical ailments only, but he should also take care of his mental, social aspects of child health. And he should also take care of his emotional, psychological, and spiritual health. He should spare some time for NCECD, which is focusing mainly on parenting. And of course, the pediatrician and parents should invest their some time, energy in children today to make them responsible citizens of tomorrow. So with this, I thank once again organizer, and children learn more from what you are than what you teach. So thank you very much. And I wish you happy parenting to you all. Thank you.
Thank you everyone for the most needed discussion on errors in parenting. I now request Dr. Jayant Pandharikar to felicitate our speakers, Dr. Sanjay Dabhadkar, Dr. Anil Raut, Dr. Renu Boralkar, and Dr. Sanjay Deshmukh. Shekhar Dabhadkar. Extremely sorry. I request Dr. DC Ladha sir to come forward and felicitate our moderator, Jayant Pandharikar sir. आले ना सर, आले ना.
Thank you, everyone. Our next session is a capsule. To remind the speakers, this session is a capsule of 8 small snippets on the aspect of a problem and not the entire problem. Each speaker is given precisely 4 minutes, and it's my earnest request to all the speakers to stick to the timeline. I now invite Dr. Rajesh Chokhani to moderate the session. With the permission of Chokhani sir, I would like to invite our first speaker, Dr. Sachin Patil from Yavatma, to brief us about medical management of PDA. Over to you, sir.
Good afternoon, everyone. First of all, thank you so much, the organizing team of MAHAPEDICON 2022, for giving this opportunity. I'm an opening batsman today, so wish me luck. Thank you. Now, I'm discussing regarding the medical management of PDA. We all know that almost congenital heart disease take care of 28% of all congenital defects of the body. The incidence being 8 to 12 per 1,000 live birth, and incidence of PDA is 5 to 10% of all CSD. As the prematurity increases, the incidence of PDA goes high. We all know that VSD is the most common structural defect, but PDA stands third in the list also. The aims of treatment is prevention of the heart failure, prevention of the infantile endocarditis, and prevention of pulmonary vascular disorders. Regarding management, we have a medical management, at the same time surgical also. In the medical management, we have to do conservative treatment like cautious fluid management, use of diuresis. Then at the same time, we have to take care of adequate nutrition and the ventilatory support for the baby. Among drugs, we have endomethacin, ibuprofen, and acetaminophen. The indication of endomethacin in prophylactic dose is if weight is less than 1250 gram with respiratory distress, the dose being 0.1 milligram per kg per dose, 24 hourly for 6 days. The timing, it should be given within the first 24 hours of life. The therapeutic indications for the endomethacin are the clinical signs of PDA in preterm baby, or signs of congestive cardiac failure, or retreatment after failure of endomethacin, or recurrence of PDA after first closure of endomethacin. The dose of endomethacin is 0.2 milligram per kg stat, followed by, if day of life is less than 7 days, then dose will be the 0.1 milligram per kg per dose. But if day of life is more than 7 days, the dose will be 0.2 milligram per dose, 12 hourly, 2 doses. We all know that there are severe adverse effects of endomethacin like renal dysfunction, GI bleeding, periventricular accumulation. Hence, there are some contraindications for the use also. Like if serum creatinine is more than 1.8, baby is having severe sepsis, NAC, and active GI bleeding, we have to withhold the endomethacin. Another drug is ibuprofen, the dose being 10 milligram per kg, followed by 24 hours interval by 5 milligram per kg. It has a less side effect as compared to endomethacin. Another entity is acetaminophen, the dose is 15 milligram per kg per dose every 6 hourly. Second dose may be required, but important thing to tell is still more studies are awaited. When we compare all three, ibuprofen tops the table. Now, PDA management in postnatal period. If patient is symptomatic, definitely we have to treat it. But if the patient of PDA is asymptomatic, then we have to monitor on regular basis. Now, what are the indications for catheter interventions? After 1 month, if small PDA is there with intravascular coil or moderate to large PDA, then we have to go ahead with the catheter intervention. These are the indications for surgery, like preterm or full-term infant with symptomatic heart failure, in whom medical management is failed, or are there contraindication for the medical management and PDA isn't successfully closed by intervention, at the same time, along with the treatment of associational congenital heart disease, we have to take care of PDA with surgery. The age is probably after 6 months of age. Thank you so much for patience listening. Hope I have saved some minute.
Thank you, sir. I request Chokhane sir to
Thanks.
felicitate Dr. Sachin Patil, sir. Sir. Next speaker would be our very own Dr. Shama Kulkarni ma'am from Nasik. She will be enlightening us on sustaining breastfeeding in working mothers. Over to you, Shama ma'am.
Good afternoon, and thank you, Team MAHAPEDICON, for giving me the opportunity. So, working women in India, if we look at the number, unpaid working is 66%. Each housewife is working, and 66% women are continuously working. Paid working is 34%, and working hours, if you calculate in a week, for women are 62.3 hours. So impact of work on breastfeeding, the impact is on initiation, duration, exclusivity, and ultimately on infant mortality rate. So benefits of supporting breastfeeding to working mother are for employers, employee, and also baby, obviously. So antenatal counseling is very important. What doctors are supposed to do. Maternity leave length should be discussed with the mother. Adequate time for pumping breast milk. When mom returns to work, she should be explained about it. On-site child care, she should think about it, whether it is available or not. Flexible work schedules, she must discuss with her colleagues. Then types of breast pumps she should be told about. And family and friendly employers are always better. Returning to work, what she should think of before returning to work, working on her early breastfeeding challenges, working on milk production, then early weeks of maternity leave, she should focus on increasing her duration of breastfeeding and success of breastfeeding. So early initiation and exclusive breastfeeding in initial days is very important. Then gradual returning to work. She should not start vigorously working, but she should return to the work gradually. She should opt for part-time or flexible timing by discussing with the colleagues and employer. She should start on Thursday or Friday. So that initially she gets 2 days of rest, and then she can start working with full energy. Then split shifts with her colleagues, and she might opt for work from home if there is a chance. Then what happens after joining? Address coping strategies. As a doctor, we are supposed to address coping strategies and not just to prescribe the medicine. Dealing with fatigue and stress, nutritious meals, sound breastfeeding patterns, managing household chores to spare the employee energy. Offer realistic expectations for early pumping attempts. At times she starts pumping, and in initial days she might see just few drops and she might get depressed. So you should explain her the realistic goals, then determine the amount of milk the baby will need when she is away from the baby and discuss about that. Train her for milk expression, safe storage of human milk, and for introducing express milk for her baby. Then discuss realistic expectations about the first days back. Then room for expression, pump, purchase, time, safe place for storing, on-site lactation classes, lactation consultant and support. So what pediatrician must know? How to express it, relieve engorgement and maintain the lactation. So hand expression should be known to each and every pediatrician. Relax the mother, massage the breast, bring the milk forward and express. So this is how she should be massaged by somebody on back. Then she can bend down so that with gravity the milk comes forward, and with fingers she can express her milk. So fingers are remaining parallel to the chest wall, and she can express and use the both hands on each breast and compressing both the breast simultaneously. Bring milk forward, and then gravity assist the mother and gentle avoid it. It should be painless process, and the mother should be able to express it without pain. So breast should be held in C and small c. Suppose this is the breast, then it should be held like this and just press at the side. It should not be painful. She shouldn't do like this, what Malish Wali Bais are doing. So it should be very painless and comfortable process. And she should be taught how to express the milk. So small c should be of the fingers on the breast, and she can express the milk and roll the thumb and fingers forward. And to empty each breast, both hands are required, so that she can massage like this, then she can hold like this and just roll the fingers. She should not do like this. And she can she should massage in axillary tail also for getting the milk forward. So this technique should be known to all the pediatricians, because everyone is not going to afford breast pumps, and hand expression should be known to all of you. Thank you.
Thank you so much, ma'am. I now invite Dr. Jay Bhandarkar to share his words of wisdom on autocaustic emission screening, role of pediatrician.
Hello.
एक minute.
Next day here. Hello. At the outset, I'm the maybe middle batsman, who is very important. And thanks organizer for this opportunity given to me to talk on the important subject and in front of important, I think, wonderful audience. Friends, the talk given me is the role of pediatrician OE. There is a auto acoustic emission, but I have given the tagline. Sorry. Okay. Sorry. Back. Okay. So I have given the tagline, every year must hear. So Helen Keller famously said, blindness cuts us from the things, but deafness cuts from the people. The WHO ranked hearing loss as the most important or common cause of ears lost due to disability, contributing over 39.5 million years of healthy life loss, which is increased from 27 million from 2000. What is the prevalence of hearing loss? Is almost neonate hearing loss ranged from between 2 to 8.8 per 1,000 live birth. And among the high risk neonates, it ranges from 7 to up to 50 per 1,000 births. And in children, prevalence is almost 6.6 to 16.47. Commonest cause is otitis media. So when to screen? Newborn hearing screening with OE should be done to detect an intern very early. Should be done before, even or soon after the birth, and best done before discharge of the hospital and before 1 month of age. What is the physiology? How it works? OE is used to find out how well the inner ear or cochlea works. Hair cells in the inner ear responds to the sound by the vibrating. The vibration produced by the soft sounds, and that echoes back into middle ear, and these quiet echoes are measured as a OE. What is the technique? The OE is done by putting soft tip of the microphone in the earphone, in the ear. It delivers click sounds in the inner ear and it detects echoes from the inner ear. Or the term condition of prerequisite, the baby must be quiet, for which feeding before taste is enough. Room should have no noise, people around should be very quiet, not move much. OE can be done by the trained staff, on the pediatrician, audiologist, and external ear should be very, very patent. How it is reported, either reported as a pass or refer. When the result is refer, then repeated after 6 weeks, and do not, suppose the child doesn't pass the second OE test or NICU graduates, their advice BERA, that is a brainstem, evoke, response, audiometry. And mind you, only few will have the hearing loss. What are the important facts? Hearing loss cannot be diagnosed by examination alone. And screening reduces the age of diagnosis of hearing loss from 6 months to 1.5 to 3 years. Early detection allows early intervention, which avoids the deleterious effect of the hearing loss. Two types of OE, spontaneous OE, which occurs continuously without external stimulus. Evoke OE, this requires an acoustic stimulus prior to measurement. What are the signs? Do not start on the loud sounds. Do not quite smile when you talk. Baby turns head to seeing you, but does not respond to their name being called outside their field of vision. Do not move his
eyes or ears, eyes or localized sound by approximately by the 6 month of age. So other the facts, ABR actually records the activity at the level of brainstem in response to the sound played through the earphones. OE screening measures the function of outer hair cells, but does not measure the response from the auditory nerve. The hair cell respond to the sound by vibrating. So congenital hearing loss, outer must be best hearing fitted before 6 months. Cochlear implants give best results when fitted before 2 years. So what are limitations? OE affected by any middle ear disease such as middle ear effusion. OE may not be measurable in children with adhesive otitis, or even though the outer hair cells are healthy. Thus, OE cannot distinguish between conductive hearing loss and sensory loss. For the role in the older children, yes, 40% of the children who fails hearing screening before birth actually undergoes the time intervention and they lost to the follow-up and lost to the diagnosis. Even delayed hearing loss or progressive hearing loss occur in the children. That preschool hearing assess is very important with the even OE. For the take-home messages, every neonate must undergo hearing screening and don't rely on the only clinical examination. Hearing loss is very common, can cause irreversible impact on the development of untreated. Best occur achieved with the three that rules 136, screen by 1 month, diagnosed by 3 months, and hearing aid by 6 months of age. Early diagnosis intervention was excellent outcome. Many causes of hearing loss are preventable. Every year must hear should be the target of repetition. O is a very simple and easy test to do. Thank you very much.
I now invite Dr. Parag Gaikwad to enlighten us on mesenteric lymphadenitis, to treat or not to treat.
Thank you. So my topic is mesenteric lymphadenitis, not to treat or not to treat. So by definition, first we'll see what is mesenteric lymphadenopathy. Lymphadenopathy is just enlargement of mesenteric lymph node. The causes may be inflammation, non-inflammatory, and also malignancy, chronic disease, etc., etc. But this lymphadenitis is a definition is non-specific inflammation of mesenteric lymph node in cluster of 3 or more lymph node, and each measuring 5 mm or more. So on USG, if you see less than 5 mm, then it's sub-centimeter lymph node, and it's not significant, and radiologist does not report. So 5 or more and detected in right lower quadrant mesentery. So this mesenteric lymphadenitis may be acute or chronic, and as a pediatrician, this acute is most important thing. Chronic may be in various diseases, but acute we have to rule out the surgical emergencies. So another classification is primary and secondary. Primary, we as a pediatrician mostly see this primary lymphadenitis, and primary mesenteric lymphadenitis is without any identifiable inflammatory causes. And secondary, the multiple causes of inflammation are there, like appendicitis, UTI, etc., etc., and mesenteric lymphadenopathy can be seen. So etiology, varied etiology. In our developing country, mostly these viral diseases and bacterial infections causes this mesenteric lymphadenitis. In Western countries, the study says this Yersinia is most common, zoonotic diseases are most common, or maybe associated with chronic diseases like HIV. Pathophysiology in India, many studies are there. They say that after respiratory and diarrheal infection, these followed by mesenteric lymphadenitis, many patients give history of previous respiratory or diarrheal illness. Then these bacteria or viruses goes to bloodstream, then through invasion come to this intestinal epithelium and locate in Peyer's patches, and this will lead to inflammation of mesenteric lymphadenitis. So clinical feature, most important thing is fever, vomiting, and mostly diarrhea, but sometimes constipation can be seen. And these non-specific conditions, non-specific clinical features can confuse with acute surgical emergencies. Then abdominal pain in these cases may be just dragging pain or dull pain to severe pain requiring admissions also. But typically pain in periumbilical or right iliac fossa, tenderness may be there, and these children looks pale on examination. Diagnosis history is most important. We have to rule out the other surgical emergencies, and most important, chronic diseases. Lab diagnosis not required, but if investigated, then non-specific CBC, non-specific blood counts like CBC elevated, neutrophilia, eosinophilia. Most important, CRP is elevated. And important thing is you should rule out the UTI, and urine routine examination should be done. Mainstay treatment is USG mainstay. Multiple enlarged hypoechoic lymph nodes are seen, and this super microvascular imaging, many studies are there, but I think it's not available in India. Differential diagnosis, acute appendicitis, intersusception, ovarian torsion, and other chronic diseases like TB, malignancy, HIV, and most important thing is UTI. So management, most important thing is this acute submesenteric lymphadenitis is self-limiting, does not require any antibiotic. Rule out, but most important, rule out the other surgical condition, give hydration, proper hydration, pain relief, and for monitoring can admit the patient. And lastly, prognosis. This mesenteric, the counseling is most important. This resolve within 4 weeks, and again, you should counsel the parent that this is self-limiting and without complication. Thank you.
Thank you, sir. Sir, please there on the dais. I request Chokhani sir to felicitate Dr. Parag Gaikwad. I also invite Dr. Jay Bhandarkar sir and Shama Kulkarni ma'am on the dais. I request Chokhani sir to felicitate Dr. Jay Bhandarkar sir. Chokhani sir will felicitate Dr. Shama Kulkarni ma'am. For the next talk on CRP versus procalcitonin, I invite Dr. Prashant Jadhav sir to come on the dais.
Thank you. Thank you, organizers, and thank you all the audience for being here. I'm going to talk about CRP versus procalcitonin. When this thing came into my mind, I thought that I need to answer a question which many of us face, that when a patient comes toward us, whether the patient has an infection, and second, whether we need to write an antibiotic. And a very important, another thought came to my mind is that let us try to avoid the antibiotic abuse that is being widely, rampantly done. So from this perspective, we will look at CRP and procalcitonin. Yes, we all know that it is an acute phase reactant, has been widely used since long ago. We have been widely using it for screening, especially in neonatal sepsis, as well as sometimes in pediatric. It does have got some positive predictive value, but definitely CRP alone cannot tell us whether it's infection, sepsis, or whether we should write an antibiotic or not. It is synthesized in liver after stimulation by interleukin 6, and that has got some pro and anti-inflammatory properties and useful in classic complement pathway, as well as it activates phagocytic cells. But many a times it is persistently elevated in somewhat chronic infections as well as some chronic inflammatory disorders. Whereas procalcitonin is a precursor of hormone calcitonin, biochemically an amino acid. Basically, when you get an infection, especially a bacterial infection, the synthesis of procalcitonin is produced in all the parenchymal tissues either by the lipopolysaccharides they are present in the bacteria, or by the cytokines like interleukin 6, TNF alpha, and interleukin B, which are stimulated by the bacterial infections. And these peripheral cells cannot convert this PCT into calcitonin. That is what leads to accumulation of PCT, and that gives an idea about it. At the same time, an important point which you need to remember is that if you have a viral infection, the interferon gamma, it downregulates the PCT production. So in viral infections, PCT is on lower side, and in bacterial infection, it is on higher side, which we can utilize for differentiate between viral and bacterial infection. That is one other important point. Again, a degree of rise in PCT many times correlates well with the severity of infection. In some localized infections, PCT levels are less, and in severe sepsis and septic shock, the PCT levels are on higher side. PCT is very quick to respond. Within 3 to 4 hours, you get rise in PCT levels. At the same time, because of half-life period, it goes down. So it makes us suitable to monitor whether the patient is improving or not. So rather than a single reading, the multiple serial readings of PCT will definitely tell us whether we are going on a right track. One important would be when a patient is improving clinically and suddenly has a fever. At that point of time, if suppose we do a PCT and PCT is going down, then we can straight away not upgrade or change the antibiotic, but keep on track that the patient is improving. This is one of the important use of PCT. But there are certain fallacies, of course. The PCT would be increased in some non-infectious conditions like severe trauma, surgery, prolonged cardiogenic shock. And yes, in fungal sepsis also it is raised, but the level of rise in bacterial would be probably more than that in the fungal sepsis. And the newborns initially have some higher levels that we need to keep important. Whereas localized infections like empyema, abscess, and mediastinitis may not show a very rapid or rise in the level of PCT. These are things which we need to keep in mind. So coming back to utility, PCT can be used by primary pediatrician, ICU in charge, and emergency department also. It's a good tool for monitor patients' response to the therapy. It sometimes can even differentiate between gram-negative and positive infections, which I will not elaborate in view of time. And this is what the difference between a CRP and PCT is. Yes, CRP is very widely available, cheap, and we do use it since long. And PCT's availability is increasing as the time goes. So friends, both of them are useful. Use them wisely to avoid the antibiotic misuse and fight the drug resistance menace. PCT will always be helpful in differentiate between bacterial and viral, as I already said. And CRP has its own importance, and serial values are definitely more helpful. That's why I wanted to emphasize this point of time. Thank you.
Thank you, sir. I request Chokhani sir to felicitate Dr. Prashant Jadhav. Thank you, sir. For the next talk on urticaria, ditch or itch, I invite Dr. Vikram Patra on dais.
Good afternoon, esteemed audience. At the outset, thank you organizing team for giving me the opportunity. So the topic is childhood urticaria, ditch or itch. Why this topic? We all know, we all have experienced, we all see patients. If we don't ditch their itch, they will itch our brain. So for that, we must know. And 4 minutes is a less time for this vast topic. We'll try to take all the take-home messages from each slide. So we know academic achievement is lost because of the disturbance created by the urticaria and the family dysfunction. We know all how it is common. Acute urticaria to the extent of 1 to 14%, in some literature 20%. Chronic urticarias, we do get the prevalence is 0.5 to 5%. And what is urticaria in short? We know hives. But sometimes a patient can present only with angioedema, and still it is urticaria. Management is not going to change. And if we go, sometimes we may get both wheals as well as angioedema. And characteristic of wheel, always remember, urticaria may last for any time, but a single wheel, always ask whether that single wheel lasted
Yes, yes.